place where you can see all of my marks and the pop-up. Take a chance on a recommend your heart is hell just to comprehend your disbelief that I do suspend and easy now to find a breeze. Where you come from, where you going? Where you come from, where you going?
Hello, everybody. Does anybody want to check in? Anybody want to go for a swim? Hello for Ola from de Honduras. Porque no viene su foto? Honduras. Acabo de tener una charla de Argentina hoy. Grupo de pacientes con un neurocirujano hablando de su caso de ACV. San Pedro, yo he visto San Pedro. No he visto de Tegucigalpa, pero San Pedro, al norte Tela, ¿cómo se llama la ciudad al norte? Roitán. Roitán. Empieza con C. Sí, San Pedro Sula. Tengo un amigo allá. Es muy mal con gangs allá. Para un rato, no sé si es lo mismo, pero... ¿De dónde eres tú? Napoleon, venga. Habla. Ok, cualquier. Hello. What's that? See. Yeah, it's all over the internet on Facebook, WhatsApp. You haven't seen it? It's everywhere. WhatsApp, Facebook. Okay, I'll send it to you. Okay, okay, I'll send it to you. Okay, okay. Hey, bye bye. No camera. Okay, no mic. Can you hear? I don't know. I guess you must be able to hear.
inspiration. The teenage mind with the baby inside, getting high on information. Find me a star and put it all its kind.
Oh, there you are. Yeah, you get in there. Okay.
स्कोप चालू केला देते ब्लॅक मॅजिक आलंच नाही
Hello?
Yeah, hi.
Hello? Hello sir, good morning. Hello?
Hello. Hello.
Hello, are you there? Can anybody hear me? Hi, Dr. Nilesh. Are you there? Okay.
Hello.
Yeah, hi.
Sir, good morning.
Hello. To whom am I speaking? Is this Dr. Nilesh?
Yes, sir.
Hey, how are you doing tonight? Today?
Yeah, we are good. Right now, we are starting with the Dr. Abhidasha. She will be showing us the C1 C2 dissection of the C1 C2 joint and craniovertebral junction.
Abby.
And
Abby.
yes.
I don't know Abatha. I know Abby.
Yes, she will be reaching here in 5 minutes. She had
Hello, Summit Sinha.
yes. Sir?
Yeah, hi John. Hi. How are you?
It's been a little while since I've seen you.
Somehow I am not able to start my video. I don't know what is happening. Yeah. Hi.
You'll figure it out. Just play with it. Sometimes you just have to restart it, the video. Go ahead, try it now. Yeah, try it now. We have some time. Let's test it. Go ahead. You can screen share.
Already on. I'm back.
You want to screen
Good.
share? Go ahead.
Yeah, just a minute.
Yeah, there you go. Okay.
Let me check one of my videos.
Yeah, go ahead.
Is it okay?
Yeah. It doesn't have any sound, right? It's just seeing
No,
it?
it does not have a sound.
Okay.
does not have a sound.
You know, it's not playing. It's not. It's supposed to be moving. I don't see it moving.
Hmm? You don't see it moving?
Yeah, you don't see it moving, right? You refresh the screen, maybe.
Just a minute.
You know what I mean?
Now tell me, John.
It's still not moving. It's kind of stationary. Yeah, it's not really playing.
It is written here, sharing is paused. So just check your settings over there. I mean, this is on from my side. I don't know why this is happening.
And I don't think I have to adjust my settings on this side.
In just a minute.
I have no control over your video on your hard drive. You know, the video on your hard drive, right? Okay. I can hear some music now, or something's playing. Okay, I hear music there.
The video does not move, huh?
Hold on.
Does the video move now?
No, it's not moving.
Slides are moving, John?
No, not moving.
Oh, God. Just a minute.
Okay, I'll show you the problem. I'm going to put in the chat, okay?
Yeah.
Okay, I just sent you a link to send to test your computer. You probably have Wi-Fi, not very strong, and it's that's why it's not playing the video.
Let me check.
Yeah, your bandwidth is probably low. If you run that test on your computer, I bet you that's the answer. So when the bandwidth's low, videos don't work well. Like, you know, Wi-Fi, if it's low Wi-Fi, it doesn't work well.
Can you see that?
Yeah, I can see Charlie Teo. Yeah, I can see a slide, but that's it.
That's fair enough.
Okay, okay, you need more bandwidth. I don't know if you want to move to another computer. But if you run speed test, I bet you that's the answer. Can you run speed test? Speedtest.net on your computer.
Yeah, that's what I'm doing.
Oh, okay.
Can you see that?
No.
It shows 30, around 30, 34.
34 MBs?
Yeah.
That's pretty good. 34. What's the other one? Download and upload. Because it should work.
36,
Okay.
36 is download.
Upload
36
it.
is download.
Upload is what?
Let me check.
Okay.
Well, upload is 41. So that's fair enough.
That's
I don't know
good.
what is the problem.
That's good. Those are good numbers.
Can you see my slides? No. The
Yeah.
moment I bring my slides, the sharing is paused. I don't know what is happening. It doesn't happen anything.
Slide, okay. Yeah, start all over again. Go back in,
Okay.
start all
Okay.
over
Okay.
again.
I'll do that.
Have you been on the computer for a couple hours? Oh, you fell off there. You fell off completely.
Hello.
Hello.
John, this is Nilesh here.
Hello. Yeah, how you doing?
Yeah. We are just starting with the dissection. Abhida madam will be reaching here in 5 minutes. Till now, I'm
Okay.
just taking the posterior incision. We will be showing the C1, C2 dissection. Madam will be showing. I'm just starting the dissection.
Oh, okay. So we're just waiting to hook up, right?
Yes, sir.
Okay. Just let me know. Okay, your slide's okay?
Can you see it moving now?
Yeah, it's moving now.
Okay. It worked.
Oh, so we're just starting over again. That, rebooting solves 90% of problems.
Yeah. So what's the schedule like? I mean, when is my talk? Because Abhida will be operating. I mean, demonstrating right now. So what will be the approximate time that I will be on
No idea.
online?
I have no idea.
Sir. Hello.
Yes.
Dr. Nilesh maybe tell you.
Yes, sir. So if you want to continue, you can continue the talk. The dissection will be, we will just showing the intermittently main top points. Otherwise, you can continue with your
Okay.
talk. Yeah.
So
Dr.
when
Nilesh,
you want,
you want Summit to start his talk now?
Yes, sir. If he is ready, we can start his talk.
Oh, you ready to
I'm
begin?
ready.
Oh, you
Yes,
ready?
sir.
Okay, great. So let's go. Okay.
Yes, yes.
Let me start. Okay,
So,
hold on. Let me start
so when you
formally.
want me to stop, Nilesh, you just tell me. I will stop and then continue with Abhida. Okay.
Okay,
Yes,
you
sir.
want
Yes,
to
sir.
put your face on for
Uh,
introduction,
I
Summit?
Basically,
No, it's fine.
Ives concept was we will continue the dissection, and intermittently, if some important thing structure he want to discuss, we will just switch over for 2 to 3 minutes, and then we can continue with the
Yeah.
talk.
Okay, so we'll do
Okay.
Summit and then wait. I'll wait to hear from you what you want to do. That's all.
Yes.
Okay, after Summit finishes.
Yes, sir.
Okay, ready, Summit? I'm going to boot you off
Yeah.
because I'm going to introduce the webcast. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening from Miami Beach, home of Neurosurgical TV. It's really a beach. We have the pleasure of hosting the Krishna Institute of Medical Sciences, the second day. We had a great day yesterday. Today, we're going to start a good one. We'll start with Summit. Summit, hold on there. Where's Summit here? See you here. I got you. Okay, Samar Sinha that has the presentation. He's going to explain it, introduce himself, and explain it. Welcome, Summit.
Yeah, welcome. Hi, good morning here from India. And that's a wonderful pleasure to be with one of the great meetings again and presenting my experiences over here. Ayat has been a very good friend. And let me set up the screen and then we'll start sharing.
Dr. Nilesh, you're sharing a screen. I don't know what you're doing on the screen there, Dr. Nilesh. Okay, there we go. There we go.
Okay. So, good morning, everyone from New Delhi. I am Professor Sumit Sinha, and I am a minimally invasive endoscopic neurosurgeon working at RS Hospitals, Gurgaon. And a wonderful meeting, although the meeting is basically on trauma and both cranial and spinal, but I mean, there is slight variation of because of my good friend, he kept the lecture was a keyhole, a slight variation, a complete variation from the traumatic topics that today will be covered the whole day. And yesterday it has been a very nice day, John was telling me. And let's hope that this talk of mine will be covering some of the important surgical approaches towards common lesions that a neurosurgeon encounters in his practice, and how to deal with them by keyhole and minimally invasive means. Now, this keyhole approach is a completely new paradigm in neurosurgery, and I urge the newcomers and the young neurosurgeons to adopt these techniques because, I mean, they are very, very less morbid and less traumatic to the patients, and you can achieve the complete entire spectrum of the pathologies through this wonderful keyhole approaches. So I will be taking you through the operative videos, and I will request Dr. Nilesh to interrupt me anytime Abida wants to demonstrate the cadaver dissection that she is doing. Okay, I have no financial disclosures. So minimally invasive neurosurgery is done, can be done by three means. One is the pure endoscopic, in which we use only the endoscope, and instruments are passed through the working channel of the endoscope. And such type of pure endoscopic surgery can be done by in the cases of intraventricular lesions like endoscopic third ventriculostomy, taking out a neurocystic cyst or colloid cyst excisions. What we do is there is a working port or a cannula, and through this port or a cannula, we take in the instruments, dissecting instruments, the holding instruments, the biopsy forceps, and then take out the lesion. So this is a pure endoscopic minimally invasive neurosurgery. The other one is the endoscopic controlled surgery, where there is no microscope and only endoscope is used, and instruments are passed by the side of the miniature craniotomy. And this is you can make a small miniature craniotomy or a keyhole craniotomy, and then do a cortisectomy. Take inside your endoscope, and then endoscope is the only source of visualization of the pathology, and then you can take out the lesion by means of normal instruments passed through the side of the scope. So this is endoscope controlled minimally invasive surgery. And the last, not the least, is the endoscopic assisted neurosurgery, where microscope is used for most of the 95% of the operative time, and the endoscope is used to see or remove the remnants of the tumor from the corners and angles. So this is called as endoscopic assisted surgery. And so this is the nomenclature, and there are three different techniques, as we will shortly see. The one is the endoport surgery, the other one is the keyhole surgery, and the other one is the endonasal surgery. So what is the difference between these two? Well, let's see. These are the three different techniques for minimally invasive neurosurgery. What is an endoport surgery? Endoport surgery is done through a port or a cannula, which is used for deep white matter or intraventricular lesions. What we do is that we make a small cortisectomy, and then through that cortisectomy, we dig that cortisectomy and then reach the deeply situated lesions like blood clots, hematomas, or intraventricular lesions. So this is an endoport surgery. Now we can use a cannula also, and then put in onto the cortisectomy site, and then take our instruments through this cannula. Through these cannulas. And the other one is the keyhole surgery, which is done through a miniature craniotomy, and a small craniotomy is being done, which is designed to limit the skin incision bone and the dural opening. And this is the keyhole surgery. I will shortly show you the many videos of this keyhole surgery. And the last but not the least, which is the bread and butter of an endoscopic surgeon, is the endonasal surgery, which is done. We all know that this is done through the nostrils, and this uses the paranasal sinuses to access the skull base. So let us see what are the indications for doing the endoport surgery. This is the this is done in endoscopic third ventriculostomy. Septostomy, we can do a tumor biopsy with this, arachnoid cyst fenestrations, colloid cyst removal, neurocysticcercal cyst removal, intracerebral hematoma evacuation, or intraventricular tumor excision. I will take you through operative videos of each and every of these procedures, and this is what you see, that this is these are the instruments which we use during the endoport surgery. And the top figure is the Lotta ventriculoscope, and there we use the endoscopic third ventriculostomy with this procedure, or septostomy. The middle one is the cannula, which I was talking about, and the lowermost picture is the cannula which I use, which is indigenously made silicone tube of about 1 centimeter in diameter, which is slit longitudinally, and it is a beautiful instrument which is designed by one of the very well-known neurosurgeons of India, Dr. Y.R. Yadav, and he has published this also. And this is the beauty of this. I'm talking about the figure in the lowermost panel of my slide. Somehow I'm not able to use my cursor over here. I don't know why, but I hope the delegates are able to understand this. So what he did was he made a longitudinal slit in the tube, and the tube is about some 12 millimeters or 18 millimeters in diameter, which fits into the cortisectomy. And this is a self-collapsible tube, and does not exert pressure in retracting your cortisectomy. So this is a beautiful instrument, man-made, indigenously designed instrument. And through this instrument, through this tube, you take your instruments, dissecting instruments through this tube, and then do the required neurosurgical procedure. So I personally use it not too quite often, but I mean, you can do the entire neurosurgical exercise or surgical operation without the use of this. Depends on personal preferences. So let's take you through some of the videos of endoport surgery. Now, this is one inoculated hydrocephalus in a 1-year-old child, and the child came with headache and irritability and vomiting. So you can see the dilated ventricular system, and this is the loculated lateral ventricle on the right side. So we went inside with the ventriculoscope, and you see the choroid plexus over here, and this is the foramen Monro, and this is the septostomy which is being done between the two ventricular systems. This is the communication made with the other lateral, between both the lateral ventricles, and then you see finally the communication was made with the cisternal spaces outside the ventricular system, so that the free flow of the CSF is achieved. So this is a simple procedure. It hardly takes about 15 minutes, and the child is free of shunt procedure, which is much more morbid and requires a foreign body implantation throughout the age of the child. Another wonderful disease is the neurocysticcercus. Now you see this is a FLAIR image of the same patient, showing a small cyst in the left lateral occipital horn of the left lateral ventricle. This is gravitated down posterior aspect of the lateral ventricle, and then you take, this is a simple 10-minute job, and you take your Lotta ventriculoscope system. There you find a beautiful cyst dancing in the CSF, cystic spaces, and then you grab and catch hold of this cystic structure, which is the neurocystic circle cyst, and you have to be very, very careful in delivering this out. You have to take every effort to deliver this cystic structure out in single piece, and refrain from getting it ruptured inside the ventricular system because of spillage of the cystic circle content, so that it comes out with the telescope outside, as you see in this. So this is the correct way of doing this, and lateral ventricle was found to be later on closed to by the membrane. So a septostomy was made. The septum pellucidum was perforated with the telescope, so that and then there was a membrane over the foramen Monro, which was also perforated. You see the septum, you see the septal vein over here, and the choroid plexus over here, and the operation was complete. So this was intraventricular neurocystic. So endoscopic intraventricular tumor excision also can be done by this, and you see a small, not so big tumor inside the ventricular system. Now you can do this into the vision of an endoscope, and then utilizing, you take the endoscope inside through the cortisectomy and then do the entire surgery. Do the entire surgery under the endoscopic vision, take out the tumor, and then if you, there are well-designed QSAs, small thin QSAs also, which you can take inside and then suck the tumor. And then at the end, we can do a septum pellucidum perforation. So the number of cases operated 2013 till date, my personal experience is 72 cases operated by endoport, means mainly in the last 4 years. And this is the breakup of these cases. I had my share of own complications, which are these. And the colloid cyst recurrence, which happened in these patients, was one patient was converted to keyhole approach, and it was successfully taken out. So coming to the keyhole surgery, a keyhole surgery is a different, completely different branch in itself, and it's a concept first advocated by Alex Farnaski, and I had the pleasure of meeting this gentleman, a fine human and a great neurosurgeon, in 2007 when I went to Jordan to attend some meeting, and there I came to know about this concept of keyhole neurosurgery, and whom he has devised, and he did a great work. Unfortunately, we lost him at this young age in 2009. So, but bereft of his magnificent innovations in keyhole surgery. The concept of keyhole surgery is not to reduce the size of craniotomy to keyhole, rather to make a minimum craniotomy which is required to access a deep intracranial pathology. So it is not about 1 centimeter or 1.5 or 1.7 centimeter, but it is all about minimum craniotomy, which you feel is appropriate for you and appropriate for your lesion which you are going to take out. So this is a very, very important concept. And you can always work on your size of the keyhole depending on your experience and make it shorter and shorter. So this was a gentleman, and these are the two books which he published in the short span. And another one is my wonderful friend Charlie, and who I keep on meeting quite regular basis. And this photograph was taken last year, and I think pre-COVID days in Jabalpur. And this book, treatise on keyhole brain surgery, and I have read this book a number of times. And so what are the principles of keyhole? And let me disclose that some of the figures in my slide have been taken from his book only. So principles of a keyhole, let's take you around with the keyhole concept. Now, what is a keyhole? Keyhole is like viewing the entire room through the keyhole in an inverted funnel vision. And you see, when you view something from a small keyhole, your field of vision gets wider the more deeper you see inside the room. So this is the concept. Your vision is inverted funnel vision, and since you have to be very, very careful to place this keyhole at a particular location at which you want, because this is a small size, and you have to be very carefully placed over the lesion. And therefore, the image guidance is mandatory before planning your keyhole surgery. So it has a mobile viewing trajectory, and it has got wide and multiple angles of vision, as you can see in this pictorial illustration. This has got a reverse funnel shaped field of vision, and you can change your angle of vision. You can change your microscopic angles like this, and then you can enhance your operative the viewing trajectory through the keyhole. So the best approach of the keyhole surgery is to approach any lesion along the long axis of the tumor. So you have to study the preoperative MRI, and particularly spending some good amount of time before in the operation theater before you enter into the operation theater, and then find out the long axis of the tumor, and then project this long axis onto the surface of the skull. And this is the point where you have to enter to take out this tumor. Like, for example, is shown in the preoperative MRI of this thalamic glioma. You take the long axis of the tumor and then project it to the outside surface, and there you got the site of the placement of the keyhole. And this is the immediate post-operative CT scan of the same patient showing complete tumor excision. Exceptions to this long axis line rule are, of course, those tumors which are located in the eloquent areas. Now you have to modify. You cannot obviously go through the eloquent area lest you destroy this eloquent area and the patient, causing post-operative neurological deficits. So you have to change that strategy, strategy in those cases, and then you have to place your keyhole in such a manner that it covers the entire and from end to end of the lesion. So another thing is that keyhole is not good for looking at the back of the door. Hence, this particular approach is not suitable for lesions which are situated in the on the surface of the brain. However, lesions like petroclival meningiomas or other intracerebral hematomas or other lesions which are situated deep inside the skull or the brain, they are aptly suited for a keyhole approach. Not definitely for convexity meningiomas. This approach is not for that. Endoscope, yes, endoscope. The role of endoscope comes when we have to visualize around the corners in which our microscopic vision does not go inside. And there, like for example, in the olfactory groove meningioma, where it is difficult to look on the cribriform plate, we can take a 30 or 45-degree telescope after completion of the surgical excision, and then look for any remnants of the dura or remnants of the tumor stuck to the dura still, and then take it out. And I will show you shortly in some of my videos. At the end of the surgery, you take in the endoscope in an endoscopic assisted manner, and then take out the tumor tissue accordingly. So another advantage of the keyhole approach is the exposure of brain tissue for several hours through a long and wide craniotomy makes it vulnerable to injury, because there is a heat of the microscope as well, which dries the veins, dries the cortex, and this has got all an important bearing on the post-operative functional outcomes of the patient. An average craniotomy is about, if we consider to be about 8 centimeters diameter, which has an area of about 50 centimeters square, and therefore allows more and more exposure of the brain tissue to heat and to light and to other extraneous materials which can be offending to the brain. However, in a keyhole, only a small area is exposed, and the maximum diameter of a cross-sectional area of the exposure is about 3 to 4 centimeters square. So these all things have to be taken under consideration before doing it. So let's see. Any operation can be done through a keyhole approach. There is no doubt of there is nothing like which is contraindicated. However, you have to define a keyhole. Keyhole is not 1 centimeter or a 2 centimeter. Keyhole is the one which is minimum possible craniotomy for a particular lesion that you are treating. So these are the indications, and I personally don't do aneurysms with a keyhole approach. You have to be, you have to not treat the patients just for the sake of using your operative approach, but aneurysms are a different ballgame altogether. And I think that still, especially, I am talking about ruptured aneurysms. So the ruptured aneurysms are a different ballgame, and the brain is swollen, brain is angry, and we have to give space to the brain in the post-operative period also. So I do not generally recommend using a keyhole approach. However, many experienced neurosurgeons have also started doing keyhole approaches for these pathologies as well. So talking about a supraorbital keyhole approach, first let's see what is this approach. And this is dealing with any intracranial pathology through a small incision over the supraorbital region, and this is the site has been marked in blue. And the thing which is in red is the supraorbital and supratrochlear nerve, which has to be saved during this surgical procedure while we are making an skin incision. So let's see how this approach works beautifully in cases of any tumor which are located in the center of the anterior cranial fossa and in the plane of the orbit. So the trajectory has to be from here to here, and the rationale, the principle is the same. You draw a long axis of this and then project to the outside. Here is the angle of attack of this, and the placement of the keyhole is exactly in the supraorbital area. So this is how it looks like after opening, and you see this is the same patient, and this is the brain here. This is the orbital floor, sorry, orbital roof, and this is the reflected dura, which is being tucked away. And the advantage of this is that you first of all get to attack the base of the tumor, which is meningioma in this case. And the principle of meningioma, we all know, is that devascularize the tumor tissue, and then there you go. And the whole surgery is a piece of cake. So first of all, you get to attack the base of the tumor, devascularize it, and then whole of the surgery becomes so effortless, so easy. You will yourself see that this is a wonderful approach rather than going through the top. Here, you get a chance to attack the tumor on the base itself. So it's a beautiful approach, and it's cosmetically so beautiful. You don't even recognize the patient that patient has had a neurosurgical operation before. And look, in nowhere of my videos you will realize that in the keyhole approaches that there is any lack of space working. You have to, howsoever, the placement of the craniotomy has to be perfect, and it has to be planned well in advance, and use of image guidance is a must to have in these type of tumors while making a keyhole operation. So I would advise the participants to ask in between whatever they want, off and on, in order to, they keep on watching also, because there are so many videos, and they keep on watching the videos and then ask the questions at the same time wherever they feel like, and make this interaction dialogue rather than a monologue, rather than me only speaking, make an interaction. So it will be a better thing. So this is all decompression going on, and tumor decompression, and then you see this important perforator. This has to be saved at all cost, and basically the tumor decompression is being done so that the tumor becomes more manageable, more mobile, manipulative, so that it can be dissected off from the important perforators and important neurovascular structures. You see that in carotid artery and the optic nerve. So the moment it becomes more manageable, you try to push the tumor, and then to pull the tumor, and then to make the plane between the tumor and the normal brain. Again, make it thin, make it thin. This is how you lift it. As it becomes more and more manageable, you lift the tumor from the surrounding structure. This is the principle of every tumor surgery. Do not try to take it out as a whole in one single piece. I mean, it is a recipe for disaster, especially for tumors located at such critical locations near the internal carotid artery, near the important neurovascular structure. So, I mean, you make the capsule thin, make it more manageable, and then try to dissect out from the surrounding structures. One important thing in a meningioma or any other tumor surgery is the recognition of a arachnoid tumor arachnoid plane, and it has to be respected at all cost. It has to be religiously saved, because this is that tumor arachnoid plane is that structure where which is the only perfect place for you to dissect. You are allowed to use your Caesar in within the arachnoid plane. Otherwise, you might end up injuring important vascular structures or other neural structures. So this tumor arachnoid plane has to be respected and has to be kept in mind during surgery for the entire duration. So this is the complete last bit of the tumor tissue attachment of the meningioma. The last bit of meningioma attachment to the diaphragm has been taken out. And this completes the surgery and the burning of the origin of the tumor tissue. So this was it. And another is the suprasellar dermoid. Now these are the tumors which are neurosurgical pleasure to take out. And you see this was also, sorry. So this was also taken out through the supraorbital route, and this was a skin incision from here to here. And you see the successive exposures on the craniotomy. After the craniotomy, this is the dura, and the peroperative video of this procedure. And the moment that this is the planning of the skin incision. You have to save the supratrochlear nerve. Otherwise, the patient will keep on complaining of a nagging sensation above the eyebrow, and this will keep on bothering him for the rest of his life. And you see pearly white shiny structure, and on opening the most of the time during the surgery, you don't require a retraction even, and depends. So the first principle of the keyhole surgery is that you don't have to open the entire dura over the brain. So because I mean, the moment you open the entire dura over the brain, the whole of the brain might bulge out, and this you don't certainly want during your surgical procedure. Howsoever, every effort should be made. The number two principle of keyhole surgery is that every effort should be made to release the CSF from the cisterns, release the CSF from the cistern. The only success and principle of keyhole surgery is release the CSF from cisterns after opening a small bit of dura. Release the CSF, release the CSF. These are three principles of successful keyhole surgery. Release the CSF, release the CSF, release the CSF once you go inside the dura. So once the CSF gets released, the brain gets lax, and then you get to visualize the tumor tissue without even retraction of the brain, and you won't feel any lack of space whatsoever during your entire surgical procedure. So the removal of the dermoid is being in progress as it is generally done. And you see the neurovascular structure, you see the internal carotid artery over here, you see the optic nerve. This is the optic nerve, this is the carotid artery, this is the optic nerve, there's a carotid artery here, this is the carotid artery, this is the optic nerve here. So you remove it piecemeal as we do in an epidermoid, and then you see this is the carotid ocular motor membrane over here, and you will see all these structures just like you. There's absolutely no need to open a very large craniotomy. Absolutely no need. Absolutely no need. And with the advent of the endoscopes, especially 3D endoscopes, you have another important feature in your armamentarium to enhance your surgical capabilities. And then when you have taken these tumor out with a microscope, you take in the endoscope, and then you see so much amount of tumor tissue is still there, and then you remove it under the endoscopic vision using the surgical curettes, and in order to attempt a complete tumor excision. removing the last bits of tumor tissue. And there we find some more. There is a rule of epidermoid that when you are quite sure that you have removed completely, there is additional some 20-25% of the tumor tissue that is still left. So you have to, this is a rule. So you have to check it. When you think that the tumor removal has been complete, then you have to check in through your endoscope and then take it inside. And you will not be surprised to find additional 20-25% of the tumor tissue still left there, hidden in the crevices and things like that. So always use your endoscope in this type of surgery and then try to take out as complete as possible. So this is the post-operative, immediate post-op CT scan and showing complete tumor removal. So this was the keyhole approach in the showing the cosmetic results of the supraorbital keyhole approach. Now this beautiful young girl was operated for the same pathology, which was removed by the eyebrow approach. And you see, absolutely, this was about some 6 to 7 days post-operative period. And when she came for the stitch removal, find absolutely no difference in this was. So coming to the other applications of keyhole approaches, this is a mini-T-renal craniotomy. Now, mini-T-renal craniotomy is another workhorse of the neurosurgery. And we can use this approach in various neurosurgical operations. We know that. Now, this was one large cystic solid craniopharyngioma, which was done through a mini-T-renal approach. And this is the walking video of the patient that was about 1 day after the surgical procedure. And recurrent craniopharyngiomas, yes, you see this multi-compartmental craniopharyngoma. And this patient came to us from outside, somewhere outside, and who was operated through this big long incision especially from frontotemporal orbitozygomatic approach. But then when he came to us with this sort of recurrence, we chose mini-T-renal craniotomy, and this was the microscopic view. You see all the perforators and all the internal carotid and the basilar artery were quite encased with the tumor tissue. And this is the basilar artery. You see the endoscopic view. This is the pituitary stalk over here. This is the third nerve you see there. And the tumor is studded with various calcifications and the remnant tumor. And so we removed as much as we can possibly without damaging any important neurovascular structure. Always remember the safety of the patient is of paramount importance, and do not chase the tumor just simply to remove it. Here it is an important area. It's a delicate area. You can cause damage by damaging or plucking a single small perforator of about 0.5 millimeters in size. So you have to be very, very careful. Patient morbidity has not to be done by your surgery. So this was the immediate post-operative CT scan of this patient, and this patient was sent home safely without any neurological deficits. Mini-T-renal craniotomy in the medial sphenoid wing meningioma. Now, this is a wonderful surgery that we can do through a keyhole, and this is the immediate post-operative CT scan of the same patient, and you see there's a complete tumor excision without any evidence of any. And this is the first post-op day walking video of this patient, and you see this was when she came to me in the follow-up, and you see this was a skin incision which we used to take out this tumor. You can hardly recognize the site or the of the operation that was done. So a video of this procedure I would like to show, and this was
Sumit,
one of my master classes. This is being uploaded in the YouTube also.
Sumit.
And this is a keyhole T-renal craniotomy. Yes, Nilesh, you were saying something? Okay.
That was a mistake.
Nilesh, you were saying something?
No, that was a mistake.
Sumit, how much more
Yes,
time da? Yeah, Sumit, good to see you da. Fantastic. तुमको कितना और
Yes,
टाइम चाहिए सुमित?
No. You interrupt me whenever you want. Nilesh told me that he will show
नहीं,
whatever.
तुम जितना देर चाहिए तुम ले लो, कोई प्रॉब्लम नहीं. तुम्हारा सब कोई केस
No,
दिखाना, कोई प्रॉब्लम नहीं. We are enjoying it.
नहीं. Okay, so you tell me, I will stop at that time and then continue with and then I can resume later on. Okay.
हाँ ठीक है ठीक है ठीक है ठीक है.
Yeah. So should I continue now?
Please continue. Please continue.
Okay.
ठीक है ठीक है.
So this was a 40-year-old female and who came to us with this complaints of visual deterioration and headache with left-sided weakness. Mild weakness was there, and this was a lesion which was, you see that this was encasing the carotid artery over there, and this is a typical medial sphenoid ring meningioma. So this was a craniotomy, and I don't do any extradural drilling. I don't do any extradural drilling of the sphenoid ridge, and whatever I do is I do just this, which I'm showing, and this is more than enough for me in the meningiomas, which are even much larger than this what which I showed you in this scan. So I mean, this is absolutely the one of the principles of keyhole is that, which I mentioned before also, do not open whole of the dura over the brain, because then what will happen is that the whole of the brain will pop out and then your entire surgery will be a mess. Only open the dura just over the tumor, just a small amount of dura, just sufficient to make your CSF release from the cisternal spaces, as what I'm doing right now here. So you visualize these cisternal spaces here. In this case, this is a Sylvian cistern being visualized, and look, the CSF is being drained from here. And then the moment the CSF is drained out, then your life is so simple, so simple. And it is absolutely not necessary to make a huge, big flap, a skull-based flap with all the extradural drilling, intradural drilling, I don't know what all. There is absolutely no requirement for all these things in the skull-based surgery. The ghastly approaches for the skull-based surgery, they are absolutely not required in even any of the cases of a skull-based approach. So this is what we see after going inside, and then this is the same patient that I showed one slide back, and the video is of the same patient. So this tumor arachnoid plane is a must to be recognized, and then you have to take every care to preserve these important perforators which are traveling, and decompress the tumor tissue using the CUSA, make it more manageable. The moment you decompress the tumor tissue, make it more manageable, and then so that you can lift the tumor tissue from the important neurovascular structures and dissect it out from them. So in this case, the tumor was slightly hard. It is not very well easily suckable through the CUSA. So to bit of a struggle making out and taking this tumor out piecemeal, as you will be seeing in this video. I have to cut the tumor tissue now. Sometimes this happens, especially in medial sphenoid ring meningiomas. They're not very well CUSA suckable tumors, and so the moment it becomes more manageable, you use this particular hook, skin hook, which I personally prefer to lift the tumor tissue from the surrounding structures, and then put in a cotton patty between the tumor capsule and the brain, and then suck it further to make it more manageable and more maneuverable and more thin, as less voluminous as compared to the previous. So you have to use image guidance and maybe possibly ultrasound probe also in order to localize your internal carotid artery quite frequently during this operative approach. Now here is the ultrasound for localizing the internal carotid artery, and you have to be very, very careful about and your mental 3D image of the internal carotid artery, the relationship of the artery with the tumor should be always there in your mind. while dealing with these tumors. Otherwise, you will end up injuring this important structure with the attendant disastrous consequences after the surgery. So image guidance and possibly ultrasound probe, Doppler probe is a must to have. If you have, it's very good. And you see this tumor is being lifted up from the surrounding structures. So now this is the olfactory nerve. You see this tumor is being dissected from the olfactory nerve over here, saving the olfactory nerve. The sense of a smell is an important sense, which you don't definitely want your patient to lose. So this is the, you see, this is all important dissection from the vessels, which will now start. And piecemeal, you have to remove the tumor piecemeal, make it more manageable, make it more small, make it manageable, and then remove it with constant attention and constant 3D image inside your mind of the relationship of the tumor with the important vascular structures here. So this is the right MCA, and the tumor dissection from the right MCA is now taking place. Again, Doppler, confirming the location of the internal. This is the internal carotid artery, comes into view now. And you see the plane, there is a good plane between the tumor and most of the circumstances. The internal carotid artery arachnoid is well preserved. And then you can dissect in this plane and then respect this plane, and then you can avoid the damage to the internal carotid artery. So cutting the tentorial attachment, anterior tentorial attachment of the tumor. And this is the carotid artery here. This is the PCOM, and now soon you will be able to see the basilar. These are important perforators of the basilar artery. This is the basilar artery, this is the PCOM, and this is the basilar artery. This is the internal carotid artery over here. So you have to be very careful that this is the most crucial part of the operation, and you have to be very, very patient with. This is the third nerve. This is the third nerve. Oh, sorry. Oh, God. This is the third nerve, which comes into view now. And you see the complete anatomy of the suprasellar region with preserved perforators, preserved basilar artery. And now coming back to the MCA, dissecting the remnants of the tumor tissue from the MCA there. No pulling is allowed. No pulling is allowed. No pulling anytime. So this is the ICA bifurcation, and dissecting the tumor from the lentics. You see these important lenticular striate arteries over here. So a small amount of tumor tissue is there, still attached to the, just to show you the anatomy. This is the right ICA, this is the ACA, this is the PCOM over there, this is the basilar artery. This is a small amount of tumor attached to the tentorium over here. So this amount of tumor is still there. So I'm just keen to take this out as well. This is the optic nerve. Decompressing the optic nerve, just to show you the anatomy here. This is the optic canal, this is the optic nerve, the tumor beneath the optic nerve over there. This is dissecting the tumor from the right A1. You see, there is a plane. There is a beautiful plane between the tumor and the arteries. So you have to respect this plane slowly and slowly, and this is a beautiful instrument through which you can do this. So this is the right ICA there. This is the A1. This is the MCA, and this is the tumor which is being separated from the ICA bifurcation. Making it more small, decompressing with the CUSA. And there you go. It's the complete separation from the A1 of the right side has been achieved, saving all the perforators and the integrity of the A1. And the final bit of tissue from the optic nerve is being separated. Right optic nerve completely decompressed. And this is a small bit of tumor tissue which is still attached to the carotid clinodal segment, which I prefer to not to remove it because it was completely adherent to the IC, and I find it very dangerous to remove it, so I left it. So this was the completion of the operative procedure. Another yes, I.
Okay.
Sumit, can you hear me?
Yes, I tell me.
Sumit, right now I'm asking Abida to continue with the dissection right now. She will start off.
Perfect.
And after that, if you can show a few more cases during the, 12:30 like that, if you can keep on showing cases, we are keeping on recording that.
Perfect. I am all day long with you, and you tell me what the delegates want to see. I have
Done.
presentation. Don't worry. You just let me know what and when I have to see.
Thank you, thank you so much. So what we will do is, whenever we have done a session and then we are changing, we would like you to show one case, explain it beautifully, and more cases like what you have just shown, more cases where you are not editing too much, you are showing everything starting from the procedure, especially your petroclivals and all that. I want to showcase it to the world how, so all those, okay. So right now we are starting dissections. Before that, I think Yuha is here. Yuha, are you there?
चल रहा है भाई, ये थोड़ा
Yuha?
टाइट कर दो उसको.
He was in the panel briefly. He may have stepped away.
Just see if he is there.
He is there.
Yeah, he's in the panel, but he may have stepped away from his desk.
No. Is there any way you can? I will call him. I'll try to call him. 1 second.
Okay. I can try to text him, Mike.
Yeah. Okay. Now shift it back to Abida, please. Now Abida can start the dissections.
Should I start, Aib?
Yes.
Am I audible? John?
Okay. There's Abby.
Good morning, John.
Good morning, Abby.
Not for you.
Oh, no, it's okay. Good night.
Good night. Okay, so this is the craniovertebral junction. Can you see, John?
He's not sharing his screen. Hold on. I don't know why Yuha's popped up here. Okay, go ahead.
Can you see it now?
Yes.
Okay. So this is the midline. I have dissected on one side. I will dissect on the other side. But first I'll show you the anatomy on this side. Okay? So this is the midline. This is the C1 arch. This is the C2 spinous process. This is the lamina of C2. Zoom कर सकता है नीरज? बाद में कर. This is the lamina of C2. ये zoom out हो गया. Okay, focus कर. Okay. Yeah. So this is the lamina of C2. Here this is the spinal cord. This is the region of the epidural venous plexus. This is the pedicle of C2. Here you can see the pedicle. This region here is the C2 ganglion. Scissor there. See, now you can see it quite beautifully, the whole ganglion is exposed. This is the whole C2 ganglion that is coming and going laterally. This is an artery that normally goes to the C2 ganglion. There is a lot of venous plexus in this region. So now I've cut this area below the C2 ganglion, and this is the venous plexus. This is this technique of C1 C2 fixation has been described by Professor Goel, and this is the Goel C1 C2 lateral mass, C1 lateral mass, C2 pedicle screw fixation that I am demonstrating. So now this is the C2 pedicle. Now this is the C1 C2 joint. You can see my bayonet is going inside the joint, and this is the C1 facet. Is it clearly seen? So this this is the vertebral artery foramen in this region. Here you can see the vertebral artery. Here, dissect करते हैं थोड़ा. This is full of venous plexuses, and here you can see the vertebral artery as it is going in the vertebral artery foramen. Okay, so this is on this side. I will dissect it on the other side and show you now again. So these are the muscles of the C2 spinous process. Wait, 4%. Mastoid advance कर. Give me dissector. Yeah, give me dissector. So this technique was first described by Professor Goel in 1987, and it is the best and most strongest and the universal method of fixation for C1 C2 joint. Now you can see I have dissected the muscles of here. This is the lamina of C2. Sharp knife. So now I am searching for the pedicle, which I can feel here. Now we will separate some soft tissue in this region, like on the other side. Here you can see the venous plexus in the lateral gutter. Scissor. What are they? Tooth forceps, they English. So this is the venous plexus above the C2 ganglion. This is the C2 ganglion. So earlier, when the technique was described, Professor Goel used to advise sectioning of this ganglion, because as you see the location of the ganglion, it's right above the C1 C2 joint. So when you open the ganglion, when you section it here, you get a panoramic view of the atlantoaxial joint. But nowadays we are able to do the fixation without a ganglion resection, as I will show you now. So this is the C2 pedicle. इसमें दिख रहा है क्या? Not seeing. कर. Okay, now it's this side. It has to be angled like this. No, wait. Yeah, that thing fell off again. Put it. लगा दे. Other way. wait. Focus kar. Okay. So now you can see the C2 pedicle here. Sucker. Knife. बहुत बड़ा है. Suck, please. Irrigate a little and suck. Suck. Yeah. Suck. So I've reached the joint. I'll just show it to you more clearly. Knife. Suck. Suck. Here it is. So there we are in the C1 C2 joint. You can see my dissector is here. I am lifting the C1 facet. Suction there. The suction is not working. Huh? See there. I have opened the joint here. You can see the joint now. This suction is not working. Just flush this and give. This is only not working. This is only not working. Is it working? It's not working only. Disconnect हो रहेगा. See there? Okay, we're having some problem with the suction. Till then, I'll just show you the C1 arch. What? No, it's not working.
Nilesh, do you have a link? Huh? Send me the link because Salim Abdul Rauf wants to log in and say something about system.
It's not working from here only. No? Yeah.
इसमें क्या शेख बात है? इसमें कैसे सर्च करना है चैट्स करके? निलेश के लिए कैसे सर्च करना है?
हुआ?
इसको यहाँ पे लगाना पड़ेगा.
Is it working? Little better, I think. So this is the C1 facet here. There is some kind of listhesis in this cadaver actually. See this. See, this is the C2 pedicle here, and the facet of C1 is almost on the pedicle. इसको atlantoaxial तो नहीं हो गया ना? Dissector. See, this is the joint. I am lifting the C1 facet now. My dissector is in the C1 C2 joint. Okay, and this is the vertebral artery foramen in this region. So now just to show you how the ganglion can be cut, I will demonstrate that. So this is the tissue. If you remove all this tissue, you will really get a panoramic view of the C1 C2 joint. See, now you can see the C1 facet. It's clear, no? And now you can see how the C1 C2 joint is almost on the C1 C2 facet. So I am going to cut the C2 ganglion. You have to be very careful when you are doing this in normal anatomy, because in patients with occipitalized atlas, the vertebral artery is right behind this. So you might just end up having a, I have done it. One second, I'll just cut this ganglion so it's out of the way. You don't need to do this. Here. So now see, once I've cut the ganglion, you can see the beautiful, see, this is the C1 facet, this is the C2 pedicle, this is the vertebral artery foramen here. Let me see if I can dissect the artery. See, as I said, there is a listhesis here. This is behind here. On the other side, it is okay. So my dissector is now in the vertebral artery foramen, and here I am lifting the vertebral artery here. There it is, there ripe. Can you see it now?
Excellent, excellent.
That's the vertebral artery. I can dissect some tissue here. And that's the artery here. Yeah, yes.
You have to tell something.
Yeah.
Can I ask you how to tell something?
Yes, sure.
Hello? Hello?
Zoom out. Zoom out. Yeah. This is upper se C1. This is C1 facet. I told you that this is yeah, that is soft tissue on top of the facet here. Here you can see the whole bone. Yeah. Dikha. See, I'm distracting it now. If you want me to go on or wait? Oh. So, when you, for basilar invagination, what Dr. Goel has described is you distract the joint. See, now my dissector is in the C1, C2 joint here, and I'm lifting the C1 facet. About, this is the C2 pedicle. So, this is the area that you lift, and in this, what? Focus? Okay, better? Better? Okay, so this is the C1 facet, which is actually listed a little bit posteriorly, and this is the C2 pedicle. This is the C1, C2 joint, which I am lifting now, and this is the region where you insert the bone graft. And then for putting the screws, one screw goes in the C1 facet here, which is directed medially and slightly cranially, and the other screw is in the C2 pedicle. So in this region, going all the way inside, in this trajectory, the trajectory of my suction. And this is the region of the C2 lamina. All the muscles have been dissected out. And if you see from the midline, this is the C1 arch. This is the C2 spinous process. These are the lamina on both the sides. Now in this side you can see the pedicle. Again here you can zoom in. Focus. This is the C1 facet on this side, and I'm inserting the bayonet in the C1 C2 facet joint here, and now I'm distracting it, so where we can put in the bone graft. And in this region you can see the vertebral artery here that is dissected. I'm lifting the vertebral artery now in the vertebral artery foramen here. This is the vertebral artery in the C2. This is the C2 ganglion, which I cut on that side. On this side we have preserved it. There's some tissue here which we can cut to see the C1 facet more beautifully. Now you can see it here. This is the venous plexus that normally runs with the C2 ganglion and is the cause of bleeding while doing a C1 C2 fixation. So in this situation you see that we are underneath the ganglion and there is no need to cut the ganglion. We can straight enter the C1 C2 joint in this region and do the fixation. Sometimes in cases with basilar invagination, the joint is not, you cannot expose it easily without sectioning this ganglion, and that's when you section it like I did it on the other side. And this is the region of your spinal cord, and you can see there's a lot of venous bleeding from this area also. You can see the venous plexus is in this region.
That's where the vertebral artery.
Here, vertebral artery is here. No, that's your C2 pedicle here. That's your spinal cord and epidural venous plexus, and this is the vertebral artery on this side with its own venous plexus. Focus. Yeah. Can remove this. Here it's quite nicely seen. So you want to see the anatomy, Shashwat? Gloves though. नहीं नहीं वो अच्छा focus.
That is your cord region, right?
Yeah.
That is your cord.
That's a pedicle, C2 pedicle, yes. That is C1 facet. You can see how it has come back little bit.
Right.
Yeah.
That's why you're telling about it.
Yeah, yeah.
So C1 facet, if I put in a screw
Yeah.
in this
Yes,
direction also,
yes.
it will be fine.
Yes, yes.
So this is what we used to do. This is we
Yeah.
used to put in a screw in this direction,
Hmm.
and then
Laminar screw. Mm. Yeah, yeah. Yes. Yes. No. It's better on this side. That one looks hypoplastic. Yeah. Yeah. Hmm? Gone down, yeah.
So that's a foramen for sure.
Yeah.
That's a vertebral foramen. So it's a cetopedicle and that's a vertebral foramen. You can see the process there. Now, why is the C2 lateral
Hmm.
mass over the vertebral foramen?
That's what I'm saying. It is listed. You see on this side. See, this side is normal anatomy. See that and then compare with this one.
Right. Yeah, because see the vertebral foramen is here.
Yeah, yeah. It should not be there. It should be in alignment.
Right. So what we are going to do now is we are going to Nilesh, what we need to do is we need to come all the way like that. Like that. Okay.
Right side.
And do this side. Which side?
Yeah, whichever side. Do this side.
Yeah.
We come here. You know what? We could do it on the right side and then continue from there.
Okay.
Because
Yeah, you've done already on that
yeah,
side.
no,
Yeah,
no,
okay.
let it be a virgin side because we can do a transmastoid vitrectomy.
Yeah.
So here you do it, you connect it up and you know, from here you bring this down all the way like that. So this flap would come down, expose mastoid, all the group of muscles starting from trapezius, splenius, everything you bring that down as one group so that you can see this all the way till, see now you are going to see the vertebral artery here also.
Yeah. I have just dissected till that point.
So you can see the vertebral artery here also. Just, so we'll dissect the vertebral artery up and the vertebral foramen will disconnect and get the vertebral artery over to that side. And after that we'll do a far lateral, okay? So let's get it done.
John, are there any questions?
Okay, we'll ask the panel right now.
Okay.
Does anybody have any comments or questions?
Is Yuha or Salim or Professor Lawton there?
Yuha, are you here?
Yuha told me he's going to the airport in a taxi, so
Okay.
Yuha is in a taxi. So that is why.
Okay.
I mean, Yuha, I don't know whether it's comfortable for him. Salim is also supposed to log in. I don't know if he's
I haven't
logged
seen
in.
him so far.
Well, Professor Lawton also. Hira is around. Is Hira around?
No, she's not around.
Okay. Now, what we are going to do is we are going to combine this into a far lateral, extreme lateral type of approach. Yesterday we saw on the anterolateral corridor we saw up to cranial nerve 7. And then today we will see the rest of the cranial nerves and the posterior aspect of the brainstem. So all that we will see today. But that during those dissections, starting point of that dissection, we will ask Sumit to present his petroclival meningioma keyhole. So if Sumit is around, maybe Sumit can go ahead and...
Okay. So you want me to show the petroclival?
Yes, Sumit. Go ahead.
Okay. So whenever you want to stop me, you just say and I will stop them there.
Yeah,
Okay?
you have 30 minutes now, Sumit. You have 30 minutes.
Perfect. Okay.
Right,
Just a minute. Let me arrange the things. Huh?
Right.
Get this out.
You understood now what I mean. Go ahead, you guys.
Okay, someone, are you going to start someone? I can get them off the screen.
Yeah.
Okay, let me just stop the sharing so you can have the screen share. Okay, it's all yours.
Yeah. Thank you, John. Can you see this, John?
Yes,
No.
yes.
There is a problem here. It says sharing is paused. I don't know why.
Oh, it looks good here. Okay, well,
The moment I play the video, it does not play.
okay.
Can you see the video play?
I can see looks like it's ready to start, but it's not playing.
Yeah, that is the reason. So let me log in again from refresh, right?
Yeah, okay. Whoop, he fell off there, but he'll be back.
So the dissection that we showed yesterday from Karad showed exactly the anatomy of petroclival region. So if it is a sphenopetroclival meningioma, let's say a sphinocavernous petrotentorial sort of meningiomas, this is what we showed yesterday. So we showed the cavernous sinus, we showed the fifth nerve, we showed the superior petrosal sinus coursing over the fifth nerve, we showed the starting from petrolingual ligament, petroclinoidal ligament, petrosphenoid ligament, all these ligaments were sectioned, and we showed the sixth nerve, the Doralose canal, and the fifth nerve together at the petrous apex. We took the petrous apex off completely till the 7th, 8th complex was reached. And this is the anatomy that we showed yesterday. So I thought, if you are looking at petroclival meningiomas today, it will be a good experience for all of you guys to see how these tumors are done. Okay, so petroclival meningioma is okay, but when it has extensions into Meckel's cave, all these ligament sectionings are important. I'm sure Sumit will talk about what is its relation with the petroclinoidal, petrosphenoidal, and the fifth nerve.
Okay, I think he's going to present now.
Yes.
Okay.
Go ahead.
So here we go. So this is one entity which thrills us skull-based surgeons, and it has certain reasons to do that, because this is a hero of this skull-based surgery, this petroclival meningioma. There is nothing which is beyond this lesion in terms of taking out the expertise of taking out these tumors. And basically, the expertise is nothing but, it is proper knowledge of the skull base anatomy and the areas nearby these formidable tumors, which one has to be very, very familiar about. And there is not a very big deal in taking out these tumors, and particularly saving the patient's morbidity and mortality, of course. So how do we define petroclival meningiomas is a matter of concern, because many authors have described these tumors into various things. And some have also classified these tumors. But strictly speaking, if we talk strictly, specifically about petroclival meningiomas, they are the ones which arise from the upper two-thirds of the clivus, and they are located at the petroclival junction. They arise from the dura of the petroclival fissure, and they are located medial to the fifth nerve. So this is the definition of true petroclival meningiomas. However, having said this, these tumors can also extend into the nearby territories, giving rise to the nomenclature like sphenopetroclival meningiomas, petroclival-sphenoidal meningiomas, clival meningiomas. I will shortly explain. So these all well-known authors and the well-known wonderful surgeons in the world, they have their own sets of handburns in managing these formidable tumors. You see the rate of cranial deficits ranging from 20% to 70%, and the mortality rate in dealing with these tumors ranging from 0 to 3.7%. So these are not very simple tumors to treat, and one has to, as I already mentioned, one has to have a clear-cut knowledge of anatomy and a good surgical skill in dealing with these tumors. So how do we select the operative approach? So conventional literature has been full with skull-based, various skull-based approaches to deal with these tumors, ranging from frontotemporal, orbitozygomatic, anterior petrosal, posterior petrosal, combined petrosal, which includes translab, retrolab approaches, transcochlear approaches, and the retrosigmoid approach. So, with the definitive indications for each of these approaches. So, for example, let me give a bird's eye view of when to use what type of approach in, and this depends on the location of the tumor and the extent of the tumor, and also upon the familiarity of the surgeon to that operative approach. For example, I don't generally do combined petrosal approaches, so I will be the last person to choose that combined petrosal approach to take my petroclival out when I, especially when I do have more favorable approaches at my armamentarium to take out these tumors. So, having said this, let's have a quick look as to what all approach to use in what type of tumor. So, FTOZ approach is suitable for small or medium-sized tumor, which involves the upper clivus. So this is the tumor which, this is the approach which causes excellent exposure of the anterior cranial fossa and the middle cranial fossa and the upper clivus. So this is when the tumor is located over here, we use this approach. Anterior petrosal approach is used when the tumor is medial and above the internal auditory canal. So you have to study the preoperative MRIs particularly carefully, spend some time, good 10 minutes, 15 minutes inside the operation theater before you start the surgery. And of course, the night before the surgery, you have to think, you have to make a 3D dimensional image of the tumor inside your brain, and in order to select the appropriate operative approach to these tumors. So you look at the internal auditory canal, and if the tumor is ahead in front of that internal auditory canal, then probably anterior petrosal approach is the approach that you would like to do. And this approach causes excellent exposure of the upper clivus, and you can use this approach when these tumors are located here. Posterior petrosal approach when the tumor is located in the upper and the middle clivus region, and there are three variations for this: retrolab, translab, and transcochlear, as I already mentioned. Then the combined petrosal approach when the tumor is large and it covers the portion which is covered by anterior petrosal as well as the posterior petrosal. Whereas the last but not the least, retrosigmoid approach is the main workhorse of the for taking out the tumors in this region, where it is especially useful when the tumor is mainly in the posterior fossa, with some extension in the Meckel's cave. Now, when the tumor is of a sphenopetroclival type, when the tumor extends into the cavernous sinus, or maybe it extends into the Meckel's cave, then you see you can enhance the exposure provided by the retrosigmoid approach by doing a transtentorial extension of your retrosigmoid approach. I will show you shortly in one of my videos. And also by doing an intradural suprameatal approach, I will show you in the video. So if when you drill the suprameatal bone over the internal auditory meatus, then what you gain an extra 20-30 degrees of angle of vision to remove the tumor which is going into the Meckel's cave. So this is a beautiful approach for these tumors, and you can, without the additional morbidity of combined petrosal approaches, translab approaches, you can remove the tumor completely in a single stage. However, having said this, at some point of time, I have few patients of such a thing also, that you have to select staged approaches in the favor of lesser morbidity of the patient. So you take out this portion of the tumor through the subtemporal approach and the posterior fossa tumor through the retrosigmoid transtentorial approach, maybe in a staged manner, done a day after or maybe some weeks after this initial surgery. You can stage your operative procedure also. So giving this brief idea, first of all, you have to, what do you have to look in the MRI scans? You have to look for the position of two important things. First is the internal meatus, and the second is the tentorial cerebelli on the coronal images. So the tumor, the petroclival tumor, is, if it is located behind the internal meatus, then possibly retroblastoid, retrosigmoid craniotomy is the approach of choice. And if it is located in front of the internal meatus, medial to the internal meatus, then probably subtemporal or transpetrosal approach is the your operative desired trajectory of approach. So this is what you have to seriously look for and while planning your operative approaches to these particular regions. This was one beautiful paper which I come across, and I always quote this from China, and they published and then they classified these tumors into 6 particular categories. And one is the clivus meningioma, and you see that the tumor is predominantly midline, and the other one is a petroclival tumor where it goes into the ipsilateral internal meatus, towards the side of the internal meatus and towards the side of the clivus also. So the basic approach for treating these type of tumors depends on the involvement of tentorium. If the tentorium is involved, then they use the retrosigmoid transtentorial approach for removing these tumors. And if it is not involved, then they use the basic normal retrosigmoid approach for removal of these tumors. However, the strategy changes for a petroclevosphenodal type of tumors. And if these are mainly located in the posterior cranial fossa, then they use that same retrosigmoid approach. Whereas if the middle fossa is also involved, as you can see in the fourth image over here, then they use either the subtemporal approach or the presigmoid combined petrocell approaches. The final classification is the phenopetroclival meningioma, where the tumor is located in the middle cranial fossa as well as the posterior fossa. Then they use the extended terminal approaches or the pretemporal combined petrocell approaches also. So this is a combination of a gamut of different approaches that they have used in managing these type of tumors. I would like to rather modify this classification in terms of selecting the operative approach, and I will show you in my many of the operative videos here as to how you can choose your operative approach for these. So the conventional skull-based approaches to these tumors have now changed, in my experience, to keyhole approaches to petroclival. There is absolutely no need to do these ghastly big surgical incisions and FTOZ, combined petrocell, trans lab, retro lab. There is absolutely no use if the tumor is not being able to be managed in a single sitting. You can easily stage the tumor, and then you can remove this through the posterior fossa portion through the retrosigmoid route, and the middle fossa through the subtemporal route. And most of the times, I mean, in my practice, 90%, I would say 95% of the times, you are able to remove the entire tumor in one sitting only, as you will see shortly. So the rationale of the keyhole approach is this is a less approach. Everybody know that this is less time consuming process. A single keyhole incision, which is better cosmesis, lesser temporal muscle atrophy, etc., etc. So we all desire for this keyhole approach. I have already told the advantages of the keyhole. The concept of the keyhole I have already told in my last slide, so I would not waste my time. I straight away go to the surgical videos. So the basic workhorse for managing the petroclival meningiomas, they are based on two keyhole approaches in my practice. One is the subtemporal approach, and the other one is the retrosigmoid approach. And in the retrosigmoid, either it is a basic retrosigmoid, or maybe it is a transtentorial approach, or a retrosigmoid intradural suprameatal approach. So I will show you all the videos for these approaches. So I have modified this classification, which I showed you by these Chinese authors, to manage the clival, petroclival, and the petroclevosphenodal tumor through the basic subtemporal approach or the basic retrosigmoid approach. And in cases of sphenopetroclival tumors, where there is a large middle fossa component, large posterior fossa component, sometimes, I would say 5% of the times, I would have to stage the operative procedure into initial subtemporal or initial retrosigmoid, and then later on going from back again to remove the remnant of the tumor. So this is basically only two approaches to remember. These are simple approach to do with familiar with, to the neurosurgeon, and with associated with less morbidity. So this was one. I apologize for the poor quality of these images. This was an old case which I operated some time back, and this, you can see that the entire tumor is located in front of the internal auditory meatus, and this I chose to operate through the keyhole subtemporal approach, and this is the post-operative MRI showing complete excision of the tumor. And similar other tumor, which is almost similar to this, and which you have to look for two things in these type of tumors. One is the location. I'm not able to use my cursor. I don't know why. Anyway, you have to look forward for the location of the tumor with respect to the internal canal, and of course the facial nerve and the auditory complex. And if they are located anterior, then probably the subtemporal approach is the best approach to approach this tumor. And this is the immediate first night post-operative CT scan. You see the complete tumor excision, and there is no residual. This is one large sphenopetroclival meningioma, and basically it is mainly the middle fossa component which is more as compared to the posterior fossa. So this prompted me to go through the subtemporal route rather than through the posterior fossa, because through the posterior fossa, this subtemporal, the middle fossa component would not be very much amenable to excision. So I went through the subtemporal approach, and this was again a keyhole approach, and this is the incision. So this patient came to us from outside, and somebody attempted somebody attempted a retrosigmoid craniotomy for this tumor before only. So what we did was we attempted this tumor through the subtemporal approach, and this was, you see, this is the immediate post-operative CT scan, the entire tumor. There is absolutely no need for doing the combined petrosal approaches for going through the retrosigmoid approach. In this case, because the majority of the tumor is in the middle cranial fossa, and you have to deal with this middle cranial fossa tumor first, and then when the tumor becomes less bulky around, and then do the Kawase approach, and then take out the tumor through the posterior fossa as well. Another similar petroclaval tumor, and you see this is a Ken keyhole approach. This is the incision. This is the size of the incision that I usually keep, and this is the craniotomy, the circular craniotomy, which this is the size of the craniotomy for this tumor, and this is the immediate post-operative first night CT scan. I always keep these patients ventilated overnight, and then wake them up the next morning after the surgery. And maybe sometimes if the hydrocephalus is there, I elect to choose to put in an Umaya reservoir to keep the CSF drainage overnight, because the patient is kept ventilated, so we will not be able to assess the GCS of the patient. So it is safe. It acts as a safety valve mechanism to drain the CSF bit by bit till the morning he or she wakes up after the surgical procedure. So here is a short video of the subtemporal approach, a keyhole or Kawase approach, which I generally do, and this is how I do it. Patient positioning. So this is how I generally prefer to keep the patient in the lateral position, and I draw two lines. One line is a zygomatic line, which is from the outer canthus to the external meatus. And so this is the zygomatic line. So this denotes the base of the temporal fossa. And another one is the meatal line, which is perpendicular to the external meatus. So my incision is just in front of this meatal line and centered and based on the zygomatic line. It's about 4 centimeters skin incision, a linear straight incision, no too much complexity, very simple incision. And this incision goes straight away in one cut down till the bone. So this is the position you see with all the neuromonitoring, and the principle is the keyhole concept, because this is the lesion which, if we are going to take it out, this window, a small keyhole, will cover the entire extent of the tumor up and down and medial and lateral, anterior and posteriorly. So this is the concept. You see, this is the meatal line, the zygomatic line. In front of this is a 4 centimeter long incision, and this is the simple cut which is given, and the temporal muscle fibers, they are dissected, teased, not cut. And your image guidance is absolutely necessary for completion of this surgery, for the accomplishment of this good surgery. And the surface bony landmarks are, and this is the posterior root of the zygoma. So you have to work between the anterior end of the posterior root of zygoma and the posterior end of the posterior root of zygoma. Between these two anterior and posterior roots lies your Kawase's rhomboid. So you have to work somewhere around this area. And the lifting of the bone flap, and now doing some drilling of the temporal base. And this is the tumor which I'm going to take out through the subtemporal approach. And this is the concept of a keyhole. And so this is how you work interdurally now. You work interdurally now. You lift the dura from the V1, V2, V3 complex, and then slowly and slowly you lift the dura with a sharp dissection. So this is how it looks like. Coagulating and cutting the middle meningeal artery. This is the GSPN, which is being now separated. This is the facial hiatus. This is the facial hiatus. The GSPN is going. This is the lesser superficial petrosal nerve, and the dura is being reflected from this. Now, this GSPN is a very, very important landmark to preserve, and this is because below this lies your internal carotid artery, and your drilling is not allowed lateral to this GSPN, because you then, in all probabilities, damage the internal carotid artery. So this is your area of interest where you drill, and this is the lie of the arcuate eminence. And when you, this is the GSPN, and when you bisect this angle, you get the meatal line where the internal auditory canal lies with the traveling facial and the auditory nerves. So this is the cavus rhomboid, and here what this drilling is being carried on. Now you have to avoid the drilling the cochlea, which is at the superolateral border of the meatal line, and this is the lie of the internal canal, which you don't have to drill in a Kawase traditional Kawase approach. Now the intradural work is being started, and then you see you immediately get hold of the tumor, and then the tumor is being debulked, cut, and biopsy being taken and checking with it. Now the important structure which comes here laterally in the medial edge of the tentorium is the fourth nerve. Now you soon identify this fourth nerve here. You see that you have to save this fourth nerve at all costs because it provides an important function for the eye movements. And soon you localize this PCA over here. Now this tumor arachnoid plane, I always stress in every lecture of mine to very carefully to tackle this tumor arachnoid plane over here. And with the important perforators, they are, if you have respect for this plane, then you very little chance that you might end up damaging the important perforators. You debulk the tumor, make the tumor more manageable, debulk the tumor, take care of the tumor arachnoid plane, and soon you will end up by taking out the. Now see how important this perforator is to preserve this perforator and to slide it down away from the tumor capsule. This is the superior cerebral artery, and you see this is, it is not the PCA, this is the superior cerebral artery, it's wrongly printed over here. And then debulk the tumor, making it more manageable. It's lifting the tumor from the brain stem and dissecting the perforator. Now this is the superior cerebral artery dissection. This is always a sharp dissection. You see, this is always a sharp dissection which has to be there, separating the perforators from the. Nowhere in the entire surgery you feel the dearth of space. There is ample space, provided you have made your keyhole at a perfect location, which is directed by the image guidance. So you see there is no dearth of space. Now you soon are going to see this basilar artery, and the tumor is being separated from the basilar perforators and the basilar artery over there. This is the tumor attachment to the tentorium and the petroclival dura over here. And slowly the tumor is being debulked, is being shrunk by coagulating it. And this is the basilar artery over there again. And then this is the brain stem. You see that this is the basilar artery. This is the basilar artery. Now this is the fifth nerve which comes into view now. And the fifth nerve, you have to, this is the brain stem, you have to debulk the tumor, separate the tumor from the fifth nerve again. And tumor arachnoid plane, very important thing, very important. And in order to avoid any complications, morbidity in terms of cranial nerve or neurovascular deficits after surgery, very important to take care of this. Again, separation of the tumor from the superior cerebral artery. The last bit of tumor tissue being lifted off from the brainstem. Not a very good plane over there. I generally prefer to not to, if the tumor is very deeply attached to the brainstem, I generally prefer to leave that rather than chasing it and causing morbidities to the patient. Nowadays, the radiosurgery is very well advanced, and you can take care of the small amount of residual tumor rather than plucking the perforator from the basilar artery and causing damage to the patient throughout his life. So you see all the basilar artery and these perforators in all their glory, very well preserved. And this is the fifth nerve, and the tumor has been completely taken out almost. And checking for any remnants of the tumor tissue, stimulating the fifth nerve at the end of the surgery, and then taking out the endoscope inside, and then looking for, this is the basilar artery, this is the superior cerebral artery, up there will be the posterior cerebral artery over here. This is the fifth nerve. You see that all these structures, this is the attachment of the tumor over the petroclival dura, and all these structures you are able to see in a wonderful manner. So this is the immediate post-operative CT scan on the first night after surgery, showing complete tumor excision and without any remnant tumor tissue from the medial fossa or the posterior fossa. And this is the immediate, you see the third nerve is not there. There's no third nerve. There's mild fourth nerve was there, but the patient came to us in the follow-up at 6 months that also disappeared. So this is the incision size. Another petroclavian meningioma, and this is done through a keyhole retrosigmoid transtentorial approach. Why? Because majority of the tumor was in the posterior fossa, and then I chose to do it through the retrosigmoid. This was the size of the craniotomy, 2 by 2 centimeters in size, and this is the immediate postoperative CT scan. You see the complete tumor excision. The first immediate after coming from the operation theater, immediate operative video showing no gross motor deficits of the patient, moving all the full limb. This is 1 month follow-up video. Patient has mild first division paralysis, which is recovering, and that is why he's wearing the black specs, and otherwise he's...
Sumit, can you hear me?
Yes, yes.
Yeah, Sumit.
Yes,
yeah, so you've shown one case of petroclavial. We go on with the dissections and again, and then we will show another case of petroclavial again. You be ready with another case of your petroclavial? Okay, excellent, excellent, very good work.
Yeah.
So we are going to start off with dissections again here. We're just going to show you the vertebral artery in far left. This is a very different vertebral artery. You can see that there is a bony canal around the vertebral artery. You will see that now. Nilesh is doing it. And Salim is here. Salim, must be a crazy time for you there, Salim.
Yeah, this is 11:15 at night here in the central part of America, but it's great to join you guys. It's good to see you all, and congratulations on the course.
Hi, Salim. Good to see you.
Oh, hi. How you doing? Good to see you.
Yuha is here. Salim, Yuha is also here.
Great, Yuha. Good to see you all.
And Salim and me, we go back a long way together, maybe 10 years, a decade. So
But I'm a lot younger than Ike. I just want to make sure people know that.
When I met him, he was older. Now he's become younger.
He's getting younger day by day.
Yeah. Salim, you know, this is a trauma meeting where the bone of, today we are talking about the past, present and future of trauma surgery. You must remember way back in 2011 and 2012, these lectures that we gave of cystonostomy in St. Louis at a time when nobody was accepting. And I must say, I'm very thankful for the fact that you had to invite us and let us talk about during a time when nobody was into it. Now things have changed a lot. Things have changed a lot, and now, one of the bone of contention for trauma surgeons, or I would say trauma physicians, is that how to get into the base of a tight brain. Now, yesterday Vlad and Luis was talking about it. Today Yuha is here, and Professor Lawton also will be talking about it. And we thought we could get some masters and then talk about how to get into the base of a tight brain. Is it possible or is it impossible, as the trauma surgeons say? Or this is what we wanted you to have a say on.
Right. Well, Ipe, first of all, I'm honored to be with you guys. It was great to had invited you to come to St. Louis when you started this work, and you have you've done tremendous work around the world with this. In all honesty, I have not done trauma surgery myself for some years. I did a lot of it starting in my career, and one of the things that have evolved in neurosurgery, in vascular neurosurgery, is the fact that we're not doing a lot of high-grade aneurysms acutely. For example, grade 4 and 5 aneurysms are rarely now operated on. So from a neurosurgical standpoint, clipping of aneurysms is really relegated to grade 1, 2, and 3. So in grade 4 and 5 in general undergo endovascular coiling. Not to say there's no coiling happening in grade 1 and 2 and 3, but in general, we in the United States or around the world are not clipping high-grade aneurysms, which translates into what you just said, which is very swollen brain. So the days of doing craniotomies for tight brain aneurysm surgery are really pretty much over. And I believe that's the right thing, because when you go into a tight brain and you're trying to split the fissure, you try to get down, you're liable to injure the brain. So, and the fact that we have endovascular treatment now, that we're not really doing open microsurgical clipping of very tight brain. So I guess what I'm trying to really get to through this circular argument is that there is less and less experience of operating on very tight brain for microsurgical access, which is access to cisterns. And those of us who did a lot of that during residency and early career, when we were doing a lot of grade 4 or 5 aneurysms, are no longer doing that. So that means that we're left with a smaller and smaller subsegment of neurosurgeons who are very, very comfortable doing surgery on very tight brain. So when you have unique kind of abilities like you have shown, of getting down to the cisterns and very tight brain, the truth is it is doable, it's accessible, but I think we have to really say it is probably not, it's a set of experience that some of the masters you have in your course are capable of doing. I just don't know if the larger segment of neurosurgeons being trained today are going to be that comfortable with very tight brain, which is exactly what happens in trauma, to get access to the cisterns. So that's really the balance that has to be given, you know, in trauma surgery. I mean, obviously you would have to do a more, if a person is not that comfortable, they would have to do a larger craniotomy or extending to the orbital roof or the middle fossa. And that's a fine balance in accessing, you know, the cisterns in trauma surgery. So that's really the difficulty of that issue. And where do you draw the balance of risk-benefit ratio for a younger neurosurgeon who's being trained in this era, where there is less and less microsurgery training, and of course there's less and less vascular neurosurgery during very tight brain situation. So that's a combination I'm trying to get to, is that the ideal situation that existed for some of us who trained in the golden days of microneurosurgery, where we did everything microsurgically, we got very familiar and comfortable of accessing whatever area of the brain, just like you know, you and Sunit and Yoha and others in this talk who are very comfortable. So the reality is, where do you draw that line? It's a risk-benefit ratio for the patient, because if you get into a tight brain situation and somebody ends up injuring the temporal tip and the front subfrontal area to get to the cistern in the process, perhaps the benefit aspect of that may be lost in some of the stuff you have shown in your publications, If that's what happens in somebody who's not that comfortable and they end up getting contusions or something to that area of the brain, then the fine benefit from a cisternostomy may be, you know, lost in the process. So I think that's a dilemma, That's really the dilemma for truly, you know, the ability to do that and get that done in the new generation of people being trained in neurosurgery. So what do you think, Aip, about what I just said?
Can you unmute myself? Yeah, so Salim, you have hit the nail on its head. The problem is that most of the young neurosurgeons right now, they're not trained for good skull base or microvascular surgery. Very few centers give them training for that. Most of them has to go for some fellowships, stand outside the operating field, get back and get an experience. And now that there are a lot of people, the cases are also distributed. So you don't have one high volume center, except in a few places where experts are there, but the experts are not really willing to share. So that has put, and then this disease of publication. So this disease of publication, where a young neurosurgeon thinks that publications are more important than operative neurosurgery, is also killing neurosurgery off. So with all these combined things, I would not be surprised if DC stays on, because the only argument people have against cystonostomy is incompetence. And apparently now that is a valid argument. So as you said, I mean, people like you who are educators, like, we should tap from experts, the experience that we've had. I mean, Yuha is here, he's got so much of experience, you're here, Sumit is here. Masters like that, we should get them to share their experience of getting into the base with the tight brain. And this people, the new generation, should be able to tap from that and go forward. Instead of saying this is impossible, this is what I feel about it. What you said, I completely agree with you. I mean, if somebody is not trained, they're not going to do it, for sure. So for them, DC seems to be a safer option than going and creating a carotid injury.
Right.
But thank you so much for coming in and talking about your perspective at this
Thank
late
you.
night.
It's okay. You guys are friends and colleagues, and I'm here available anytime for you. And thank you so much for asking me to give my insight into this.
Thank you, Salim. Thank you very much. We now shift to Abida's and Nilesh's dissection. We are showing the vertebral artery. Can you take over, Abida, and show the C1, C2 joint as well as the vertebral artery? Salim, yesterday we did a anterolateral skull base approach where I was leading. We showed the entire transcavernous dissection, we showed the Kawase, and we showed cranial nerves 2 to 7, everything. And then we sectioned the tent as well as took out all the ligaments. We exposed the Meckel's cave and showed the petroclival meningioma, whatever is necessary for pitutentorial and petroclival meningiomas. The anatomy we showed people. Today we had Sumit showing petroclival keyhole approaches. And today, the dissections we go technique. And after that we are going into far transcondylar approaches. So this is what we are doing today, and after that we'll have the spine committee, WFNS spine committee, talking about the spine procedures to end this conference today.
So hi, so this is John, can you hear me?
Yes, go ahead, Abby.
Okay, so this is the craniovertebral junction. I've already dissected and kept, and I'm showing the Goel's technique of C1 lateral mass, C2 pedicle screw fixation. So this is the C2 spinous process. This is the lamina of C2 here. Is it focused?
Yes, it is in focus.
Okay. Then this is the pedicle of C2 here. Here you can see the epidural plexus and the spinal canal. So this is the pedicle of C2. This is the C2 superior facet, and this is the C1 inferior facet, as you can see here. And this, my bayonet is now in the C1, C2 joint, which I am distracting, where we put in the bone graft prior to doing a fixation. And to expose this region, generally, this is the tissue that comes in the way. Here it has already been dissected. Here you can see the C2 ganglion. Here, this is the C2 ganglion. So previously, Professor Goyal used to say we used to cut this ganglion to get this exposure, panoramic view of the C1, C2 joint here, because this is how the C2 ganglion is placed over the C1, C2 joint. So once you cut this, you directly get this exposure. But now in majority of the cases, we are able to mobilize the ganglion superiorly and then enter the C1, C2 joint here. This is the vertebral artery foramen here. This is the vertebral artery foramen, as you can see, and the vertebral artery is present here in its cuff of venous plexus. This is the vertebral artery. Here, it's quite clearly visible now, as it is entering into the vertebral artery foramen of C2. This is a little high riding, because you see how thin the pedicle is here, and it is going a little bit into the superior facet of C2. So you have to be careful when putting a screw here. So basically, as Dr. Goyal described, this is the region of the pars, and this can be divided into 9 quadrants, and the safest area is to enter in this region, the most superior and medial quadrant, and you direct the screw in this direction, so you will avoid injury to the vertebral artery, which will turn here. And now recently we have also described a technique of mobilization of the vertebral artery by drilling the bone in this area and pushing the vertebral artery inferiorly, so that you can direct the screw from this direction, thus avoiding the injury to vertebral artery. So this is on one side, the C1, C2 joint. On the other side, the C1, C2 joint is a little abnormal. Here you can see that again this is the C2 lamina. Focus. Yeah, so C2 lamina, this is the C2 pedicle, and here you can see the C1 facet is little bit posteriorly displaced. There is a listhesis here. The C1 facet has come over the C2 in this region. You saw it in the normal position on that side, dissector. And on this side, you can see that it is displaced posteriorly. Now this is the as I'm lifting the facet here, and that is the region of the C1, C2 joint. So maybe this guy had a kind of a dislocation, ante-mortem or post-mortem. And this is the abnormal C1 facet overhanging the C2 pedicle. This is the intervertebral foramen on this side. There. And this is the vertebral artery on this side. Here it is mobilized laterally. It's not that high riding here as it was on that side. And in this side, I have cut the C2 ganglion already. It was lying in this region here. So cutting the ganglion exposes the whole C1, C2 joint. This is your region of the spinal canal. So this is your area for C1, C2 fixation. And as we move superiorly, focus. Now this is the C1 arch. This is the occipital bone. This is the C1 arch that has been dissected, and the vertebral artery has been mobilized here as it is entering on the superior aspect of the C1 arch. So here you see the C1 arch here, and the vertebral artery is turning and coming here and entering the intracranial compartment. Now here you see that there is a bone formation. It is entering an osseous canal here. Normally this you can see this bone that I'm holding. This is not present in all persons. And this osseous, now I've broken it, and now you can see how it is entering into the intracranial compartment. And now we are going to proceed with an exposure for a far lateral approach. Here you can see I'm removing this bone now, right? Yeah?
Yeah, you can remove
Yeah, I think we'll remove it now.
Expose the vertebral artery on top of the C1 also. Put in a
Tooth forceps.
there isn't punch and
Yeah, up bite. Huh? I think
we
it.
find this very, very rarely.
Yeah, very rare.
This bone all over C1, but I mean all over above the C1 and covering the vertebral artery.
It's very rare. I mean,
It's rare,
very
it's
rare.
Very rare.
Yeah.
Then the problem is this bleeding because
You can see the venous plexus in that region. Scissors, please. There.
vertebral artery is going there, very clearly seen there. Once we mobilize that, we can do a
Focus.
suboccipital cranial.
Focus. Yeah.
See the vertebral artery going in and entering the dura there. This place you have to be very
Suck.
careful about because you can have a pica which originates from this region. That will be. Have you seen such a combination, Abhida?
I've seen it on angiograms, not while dissecting.
Sometimes you can see.
11 बजे.
So this region you have to be careful because sometimes you can have a vertebral. We can have a pica originating from this segment of the vertebral artery, extracranial origin of the pica, and so if you think it's a meningeal branch, there is usually a meningeal branch there. So if you think that's a meningeal branch and just take it off, you may get into trouble. So you must study the angiogram very, very clearly before you do this procedure. Once we do the suboccipital craniectomy and disconnect that region, we'll be able to show you where the vertebral artery goes into the dural region very clearly.
Okay, I think we should do the craniectomy now?
Yeah. We'll do the craniotomy first and then after that. Once we do that, what we can do is we can mobilize laterally, downstairs we can mobilize the vertebral foramen also. We can go ahead and bite that arch. We can lateral to C1. If you see lateral to C1, that is what we have to mobilize. So and then you will see the vertebral. Yes. So that you can bite off. Then we can mobilize the entire vertebral artery. So you can put in a kerrison and bite off that region, and we will. That is what you are seeing right now. Is exactly what. So you put in a kerrison and then bite off that region, and then we can free the entire vertebral artery.
It's too big.
You can drill it off generally in cases, but then you can use a kerrison punch is also very safe. That is where the thing, that bone scoop that we designed with Manman is very, very useful. That is not going to touch, even if it touches the vertebral artery or the venous plexus, it's not going to create any damage, because it's like a mechanical QSI, it will easily take off the bone without any issue. So this is what we have designed, and this way of finding it extremely useful for bone removal. So that is what Abhida is doing. She's disconnected that now. Now the vertebral artery is free. So we dissect it free, and then we move. You can move this vertebral artery laterally completely and out of your way. So your condyle can be exposed beautifully now. So that is the whole point of it. When you are doing a transcondylar approach, you don't want the vertebral artery sitting very close to you, breathing down your neck. So once you do this procedure, once you just disengage the vertebral artery, then you can easily move it the way you want it. Where you want it moved, you can move it. And the whole arch, yeah, so the whole arch is now movable. You can see how this is so tortuous. You can see this this segment of the artery is very, very tortuous. So those are the venous plexus. It's like the cavernous sinus in the neck. You know, it bleeds. Nothing to worry if you put patties and Surgicel and Flosil. It stops. There's nothing to panic about it. Never use bipolar there, for God's sake. Okay, unless you have two vertebral arteries, but even then, you really don't want to, take chances and bipolar there.
Quite a tortuous artery.
Very tortuous. Yeah, that is a ball dissector is a good thing to do. Right.
Mm. One second. Dissector.
So now you can displace the vertebral artery completely posteriorly. The whole arch, the foramen can be taken off laterally also, and this vertebral artery can be displaced posteriorly completely. Yeah, that foramen, that part of the bone also can be taken out.
Yeah. They punched it.
Yes.
Dissector.
So whenever somebody talks about displacement of vertebral artery, or this is how it can be done. Although in most cases you really don't need to do it. Most far lateral and extreme lateral cases you really don't need to do it.
Artery niche, no?
Yeah, you can sweep it back.
Yeah.
You can just
cut
sweep the
it.
whole artery.
Yeah.
Once you free it, you can sweep the whole artery back.
Nothing is there, no? There. Scissor.
Yes. Excellent. Yeah. So the artery is free now from the foramen. Then you should avoid sharp edges there, and then we sweep the entire artery down. Yes. Now release the top part. We'll release, and then once we do that, we are going to see the C0 C1 joint very clearly. Abhida, anything underneath this vertebral artery? Abhida is a master. This is, I also know a bit about this territory. Because for skull-based surgeons, this territory is most important. If you think that you don't, that is CV junction, that is wrong. It is skull-based territory. It's completely skull-based territory.
Okay.
Yes, beautifully done. Very beautifully done. So the vertebral artery is getting completely swept down. So you get lateral access, a lot of lateral access, a lot of superior access also. And if you go that direction, you will find the jugular and the carotid artery. If you go laterally there, you will find the jugular and the carotid artery.
Then, yeah.
It's a branch there, usually a muscular branch. Generally there is a muscular branch. You can just dissect it and cut it off. Yeah.
Sure. Yeah.
That's usually a muscular branch there. You got that branch there?
I tried.
Yeah, I think you got it.
Yeah.
You got that muscle.
Okay.
And you will see, if you go anteriorly, you will see the jugular and the carotid.
So I think now we got most of it.
Yeah, you can see, I think you can already see the jugular there.
Surely.
Now you displace the vertebral completely down. You see
Cutting this
beautifully.
branch. Yeah.
Now, if you displace it, you will see anterior to that is the C0, C1
Yeah.
joint.
Yeah, muscular branch. I'm going to just take this, okay?
Yeah. You can take the branch.
Yeah.
Okay.
Okay.
So when you're talking about transcondylar, you
Dissector.
cannot drill without the condyle, without doing this procedure. Yes, beautiful, beautiful. So you can see the condyle, you can show the condyle there.
Yeah.
C0, C1 joint.
Knife.
Excellent. Now we can go ahead and do the craniotomy and combine it with some transcondyle. If you drill this condyle, which cranial nerve are you going to encounter? Anybody in the group? Which cranial nerve are you going to encounter when you drill this condyle? Yes, obviously. You don't want to drill it so much so that you end up creating an
There it is.
instability. That is the C0, C1 joint.
You can see it.
So the vertebral artery is all mobilized beautifully so that you can see the entire C0, C1 joint now.
Yeah, the audio is much better now.
The audience have any questions, please?
No, I was saying the audio is much better.
Yeah, because I was keeping my mic near my backside, just brought it up.
Okay. I won't comment on that.
Yeah, I know.
Yeah.
Most of my statements are nothing to comment on, John. So now, now you can see the C0, C1 joint very clearly. And if you trace the vertebral artery now, you're going to see where it enters the dura. And if that dural cuff is cut, you can further sweep the vertebral artery out of your way. So this is one good technique to get some space, If you don't do that, then you will have the cranial nerves, you will have the vertebral artery. Exposure is everything in skull base. And exposure means maximum bone removal, move the vascular, neurovascular structures in your way, not what is not required. So, in your way something is there, you should be able to mobilize them. For example, that is why the proximal distal dural ring is cut, clinoidectomy is done, so that you can mobilize the carotid. So the same technique here, you're mobilizing the vertebral artery. There is nothing different here, you're just mobilizing the vertebral artery. And once you mobilize the vertebral artery, you have a very good corridor to go in. Right.
Yeah.
So we go ahead with the craniotomy
Yes.
now. Yeah. Excellent work, Abida. Fantastic work.
Thanks, I.
Now Hira is here.
Come, Nilesh.
I haven't seen her.
Yeah, I mean, I wanted to know if there is any program in the morning. That is what I wanted to know. What time is day 2 starting? Cranial Symposium is starting by 4, I guess. Yeah, so we will finish much before that. And now, during the time that the craniotomy is being done, we don't need it to be telecast. And we can have Sumit to, is Yuha around? Is Yuha there? Yuha, are you there?
You know, he's checked in the panel, but no one seems to answer.
Let me ask Yuha. Oh, I think Yuha is probably busy. So I'm going to ask Sumit. Sumit, can you continue with one of your petroclival meningiomas again, Sumit?
Okay. Okay.
More of operative video, mostly unedited. And Sumit, could you let us know the relationship of these tumors with the fifth nerve, with the petroclinoidal ligament, with the petrosphenoidal ligament, the carotid, the fourth nerve, and the basilar. So if you can tell us the relationships like we showed in yesterday's dissection, you can show us where these structures are, then it will be much more enlightening. And especially with your technique of minimally invasive approaches to the petroclival, I think it's a fantastic way to go ahead instead of the huge approaches that we do. Your results are equally good or far better than most of us. So this is why I wanted to showcase it. So go ahead, please, and show us the cases.
Thank you. Thank you. Probably not worthy of such a beautiful description about the techniques that I do. I just simply learned after years of watching other people doing this. So continuing forward in the same direction, I mean, I had showed you the subtemporal approaches, but continuing forward, I mean, I would like to further proceed in the direction of, I mean, there's some problem with the sharing again. I don't know why it happens.
We can see it fine here.
No, video
Okay,
does not move.
Okay, you want to start it again?
Yeah.
Start it again. Okay, well, he fell off, but he'll come back. Meanwhile, we'll watch Abby dissect in the area. This is kind of an unusual approach, a mixture of neuroanatomy and clinical cases. The cases having to do with the same area that's being dissected, which is kind of unusual. Okay, I believe so. He's back already. He's coming in. Okay, let's try it again. Is it okay now?
No.
Okay. Well, keep trying. You did it before, so keep trying. Not moving at all, huh?
Yeah.
The only thing I can suggest is just load it, unload it, load it, unload it. But when you unload it, you drop off for some reason. I don't know why.
Yeah, it does not. It says that sharing is paused. If you can see my screen, you can see my screen.
Yeah, I see petroclival meningiomas and a couple of X-rays, a couple of CAT scans.
Yeah, I mean, but it shows here that the sharing is paused. Bring your shared window to the front. I don't know what the hell does it mean. It never happened before. I don't know. Let me check.
These things happen. Unusual stuff happens. Well, the only thing we can do is just load it and unload it. That's the only thing that we can.
Yeah.
I don't think there's anything in your settings that you can change. It's a matter of it getting loaded correctly onto your computer. But it's not loading correctly, obviously.
See, the moment I go off my presentation, the
Okay.
sharing gets. But the moment I share it, it shows that it is not good.
Okay, maybe
So
present with that size screen. Do you know what I mean? Like it
that is
is.
what. That is what.
Yeah, just present with that size screen and change the slides on the left column.
That is what I'm trying.
Yeah. Like don't enlarge it. Well, maybe
It doesn't work.
it's too late for that.
Anyway, okay, now it moves. Okay. So continuing forward in the retrosigmoid approach, choosing the retrosigmoid approach for the petroclavian meningioma.
I'm sorry. I'll get that. Okay. Sorry about that.
That's okay. So the retrosigmoid approach, I mean, it is usually preferred. Suppose if the tumor is predominantly in the posterior fossa and it's a huge component. Now, the reason why I chose this patient to approach through the retrosigmoid is another one, because this patient, somebody attempted from outside the subtemporal approach. So my approach through the subtemporal area was gone, because I mean, it is very difficult for a redo subtemporal approach to do again. And therefore, I chose this to be done again through the retrosigmoid approach. However, if this patient would have come to me first, then I would have definitely preferred a subtemporal approach for this tumor. Even though this is the post-operative scan done through the retrosigmoid route, and this is the immediate first post-operative MRI of this patient. You see complete tumor excision. There is no evidence of any residual. And I did it through the transtentorial route. I mean, the retrosigmoid transtentorial. And you see, this is the tent which is being cut here in order to increase your enhancement and increase your field of vision. And the tumor going into the Meckel's cave, and the anterior-most and the superior-most portion of the tumor you visualize. This is the 7th nerve complex, and the tumor sitting anterior to the 7th nerve complex and going above the tent also. The part of the tumor going above the tent, you will be able to take it out after doing a transtentorial approach. And you see there, this is the superior cerebellar artery, which is being draped very tightly over the tumor, and this has to be saved at all the cost. And I will show you shortly. This is the endoscopic vision after the end of surgery. And I will show you this video a short while, how to do a retrosigmoid approach in case of petroclavian meningiomas. Another such tumor done through the retrosigmoid route, this is the sphenopetroclavian meningioma, and this is done through the retrosigmoid approach because suprameatal transtentorial approach, because majority of the portion of the tumor was in the posterior fossa. A small part going into the Meckel's cave could be dealt with by doing a suprameatal extension of the retrosigmoid approach. And this was the size of the skin incision. This was the size of the craniotomy, which was required to take down this tumor. And this is the immediate post-operative CT scan showing complete excision, and you can see the part going into the Meckel's cave also. This is the immediate post-operative video of this patient.
बताइए नाम बताइए हाँ
immediately after the surgery, immediately after extubation,
दोनों हाथ ऊपर उठाइए
showing no gross motor neurological deficits, and of course
ये वाला हाथ उठाइए दोनों हाथ ऊपर उठाइए ऐसे ही से कीजिए ठीक है पैर चलाइए घुटने से मोड़िए हाँ ये वाला मोड़िए
this is the immediate post-operative endoscopic view of this, showing a beautiful anatomy of the region after the complete tumor excision which has been achieved. The basilar artery, the superior cerebellar artery, the 7th complex, the 4th nerve anteriorly, and the lower cranial nerves all are seen after the complete excision of the tumor tissue. This is the 4th nerve. The finest strand which you are seeing here is the 4th nerve at the top of the near the tent after the excision of the tumor. And this is the piece of gel foam which I personally prefer to keep over the basilar perforators and the superior cerebral artery, because they are prone to go into vasospasm and can ruin your beautiful surgery later on by causing infarcts and the precarious locations. So this is one short video which I want to show you. This is the left retroclavian meningioma dealt with by retrosigmoid transtentorial approach. And this is the same lady which the slides I showed you somewhat before. So basically, somebody attempted it from outside through the subtemporal approach. So that approach was blocked for me. So I had to choose to go through the retrogastric route. And otherwise, I would have gone through the subtemporal approach for this lady also. So this is a small keyhole retrosigmoid craniotomy, about 4 centimeters diameter and 2 centimeters wide. And this is the, let me orient you. This is a left side tumor. This is the tent. This is superior. This is inferior. This is patient's right side. And this is towards the floor. Sorry. So this is a left-sided tumor. It's a pure retroclavian meningioma. And this is left-sided craniotomy being made. This is patient's head, top side. This is leg towards the leg. This is patient is in the acoustic neuroma position, left lateral position. So this is towards the cranial side. This is towards the caudal side. And arachnoidal dissection. This is the 7th complex being seen. This is the tumor tissue visualized. This is the tent attachment. And this is the superior cerebral artery. You have to save these branches with impunity. This is the main superior cerebral artery trunk between the 2 lobes of the tumor. You have to take extreme care to protect this artery. And this is the success of your surgery. 7th complex. Shrink the tumor and then decompress the tumor. Taking care your cautery does not touch the artery. Over-papaverine saline over these important vessels so that they do not go into vasospasm. Decompress the tumor so that it becomes manageable. Separation of the superior cerebral artery from the tumor. Sucking with a CUSA. Lifting the tumor when it becomes more mobile, and you see the CSF coming out. Cutting the tent so that you get a vision of the part of the tumor going supratentorially also. So this is a beautiful approach, and you can expand this approach. And soon you are going to see another important structure here, anterior to the tumor. This is the 4th nerve. You see that? Separation of the tumor from the brainstem, cutting more of the tent. Taking a stitch, and so that the tent can be retracted. So now tumor becomes more manageable as it is more and more decompressed. Papaverine soaked cotton patties. protecting the superior cerebellar artery. Elevating the tumor from the brainstem, protecting the brainstem with cotton patties, debulking the tumor again. So the process of debulking and lifting the tumor goes hand in hand. Maintaining the tumor arachnoid plane, it is the absolute must. Maintaining the tumor arachnoid plane and dissection of the superior cerebellar artery. This is the third nerve that you see there. This is the attachment of the tumor to the petroclival dura. Making the tumor more manageable, cutting it, removing it piecemeal, decompressing, cutting the tumor at places, separating it slowly from the superior cerebellar artery. Here's the third nerve. That's the basilar artery there. Tumor being lifted from the basilar artery and being lifted from the brainstem. You see, extreme respect to the tumor arachnoid plane. That's the brainstem. Pushing the arachnoid down, cutting it sharply at places, making the tumor small. Sharp dissection at places to separate the superior cerebellar artery from the tumor. Badly adhered, badly stuck to the tumor, this artery. And this dissection took me quite long. And it is the most important part of your surgical procedure. You have to spend good time in this. You see the thalamo perforator of the basilar artery. Epivarin soaked gel foam. Capped as soon as the superior cerebellar artery is dissected away from the tumor. And the tumor is taken out completely. And this is the panoramic view after the removal of the tumor. Seventh complex preserved. Taking the endoscope inside. So this is the view which you see after taking your endoscope inside. The occipital lobe, temporal lobe, sorry. This is the tent. This is the tent, cut piece of the tent. This is the fifth nerve over there. And this is the immediate postoperative CT scan, immediate postoperative MRI of the patient showing complete tumor excision. So this is the, now there are some tumors which have to be dealt with by combined approaches and do not obey your simple approaches like single stage subtemporal. This was one tumor which have to be operated by combined approaches, and therefore you see this is a huge middle fossa component and the posterior fossa component also. At the same time, both of the components are huge. Somebody attempted outside the posterior retrosegment approach, but could not take out the tumor. And then this is the attempted subtemporal approach by me, which shows the significant amount of residual. And then again did it the next day through the retrobascular approach, the posterior fossa component. So these are the indications for me for doing a combined approach if the tumor is not very well suckable or coming into your CUSA and it is badly stuck to the
Hello, Sumit.
surrounding structures. So this is another such tumor which
Sumit,
I did by
Sumit?
combined. Yes,
Can you hear me?
yes.
Yeah,
Yes, yes, tell me.
Sumit, we are going on ahead with the dissections again. The next case
Yes,
you can
yes.
show later. Now, I guess Juha is here. Juha, can you say something, Juha? And then we are going on with the dissection. Abida is going to show what has been dissected till now. Juha, can you say something, please? Juha, are you there?
I'm here. I'm here. You cannot see me, but I'm here. Can you hear me?
Yes, yes, we can hear you.
Yes, yes.
Go ahead, Yuha.
You can hear me?
Yes, we can hear you.
Show my picture. But
Did you want to share something, Yuha?
no, I just want to speak. I cannot show my picture because the video is not working, but I can say a few words about cranial and spinal trauma.
Okay.
Is that okay?
Yes, please.
I'm sitting in the airport lounge.
Okay.
With my iPhone.
Okay.
So what?
Did you see
Shall I
the
speak
slides?
now?
You go ahead. You comment on what you saw, if you can.
Okay. No, I can now say a few sentences.
Okay.
Just tell me when to begin.
Right now is fine.
Now?
Yes, please.
Okay, okay. Dear colleagues, I'm sorry that I cannot not join you with my picture or video. I'm sitting in the airport lounge in Shenzhen, China, to travel back to Chengzhou. So I have been watching times to this nice webinar about cranial and spinal trauma. Beautiful treatments, techniques. One thing remained not to be discussed. I came to neurosurgery in 1973, and that time in Finland there were more than 1,300 deaths in traffic accidents, and it was our residents every day work to see young guys to die, operate on traumatic hematomas, but then there were big changes in prevention. So speed limits came, safety belts, helmets, everything came. And nowadays, there are only 300 deaths, less than 300 deaths in traffic accidents in Finland. And the traffic is 3 times more than 1973, when these high figures were. So prevention is one of the most important things in treating traumas. You should do it all over the world. It is futile to treat young people who go amok, driving fast, driving drunk, and also the regular traffic accidents in big countries. So, of course, this is more easy to do in a small country, but also in big countries with strong government, you can do it. So it is by far better to prevent the injuries with these prevention methods, speed limits, safety belts, strict controls, obligatory helmets. So, for example, number of epidural hematomas is so low in Finland. Helmets, so many of the residents with surgery have no experience. They don't see any epidural hematomas because most people are wearing helmets. So, what are the most common causes nowadays for traumatic head injuries? This is drunken fall. drunken fall in males, and this could be reduced by going down with drinking habits, but this is more difficult and to reduce the traffic accidents. To speak about spinal injuries, I think you are advertising heavily all the time yourself, so I can advertise also myself. I was one of the first to do under microscope lumbar disc roll-up surgery, cervical disc roll-up surgery 40 years ago, and I began to also to do cervical spine and lumbar spine, thoracolumbar spine.
Look at that. Look at that. Okay, go ahead, Yuha.
We can't hear you.
Yes, we hear you.
This is your announcement. Discs, and then we can also do lumbar, cervical, and lumbar. Now to something else. Can you hear me?
Yes.
Yeah, but you saw the dissection picture now. So I finish soon. A few sentences. Let me speak.
Okay.
So, beginning of 80s, I began to do cervical traumas, anterior plating and screwing, and this has continued, but also, of course, the prevention of these injuries, terrible injuries with para and tetraplegia is the best way to treat them. So I strongly speak for prevention, and neurosurgeons are in front line of them because they see all these terrible cases of severe head injuries and spinal injuries. That's all what I want to say. Thank you very much.
Thank you, Yuha. Okay, Ipe, are you there? Ipe?
Hello.
Yes, go ahead.
Thank you very much. It's an honor, always an honor having you with us. Now we are going back to the dissection. Abhida is going to show the far lateral approach. The vertebral artery has been completely dissected up to its dural entrance, and then the condyle has been exposed, and the craniovertebral junction has been exposed, and we are going to remove a bit of a condyle so that we can get a far lateral or extreme lateral access to the brainstem. That is what we are going to do right now. In here, I would like to say something that I always find very interesting. So, Yuha doesn't go ahead and say far lateral, extreme lateral, or anything. So, Yuha says enough lateral. So, that is something that that is something that we all have to understand. It is always according to the cases. It's not extreme lateral, far lateral, and things. It's just enough lateral. So, depending on the cases, we can do enough lateral.
I think enough.
Yeah, because here the brain is fixed by formalin. You're not going to get any space after CSF let out. So you might want to go a little bit more enough lateral.
Yeah.
This really helps that the vertebral artery is
I
completely
think we're already
mobile.
in the mastoid.
Going
Yeah.
above that will be the sigmoid sinus
The upper-
turning there. So that part can be taken completely. Yes, excellent. The whole idea is to see the vertebral artery joining the dura so that that cuff of dura can be opened and now we are seeing that the dural entrance of the vertebral artery.
Sorry. Okay, I think. It's too अभी जाएगा नहीं अब बैठ
So we've got very good lateral exposure here. We can go all the way up to the front of the brainstem from here. Some more, little bit more we'll take.
I'll just take it.
Little bit more we'll take.
The bone is quite big for the upbite.
You want a drill?
I think so.
You want to use that the scoop, bone scoop?
Yeah.
You can try the bone scoop. This is something,
Fantastic, this much.
Take care of the vertebra. This is a bit.
They are giving you the bone scoop. You will love it, Abhida.
Okay.
So this comes with their standard drill system now.
Okay. I think we'll use that. Just this bit. Yeah.
Yes, Abhida, they are ready.
Okay. Give me the foot pedal.
You can touch the dural structures or vessels without any problem.
Okay.
That's not just like a CUSA, it's not going to create any issues unless it's calcified.
कहाँ है? वो गिरा दिया मैंने किधर? वो eyepiece. How do you? This way? Right?
Yeah. You just scoop it out, just like an ice cream. You scoop it out. That's the whole idea. You don't need any force. You just just keep on scooping it out.
Suctionless. Come from this side, Shashwat, behind me. Ready?
How do you like it?
Yeah, it's great. Quite smooth, huh? Quite smooth. Effortless, basically.
That's what. This thing we designed for fine bone removal, and it can remove firm tumors also
Okay.
without hurting any vessels. It's not even like a drill. There is absolutely no effort
Yeah,
required.
it's really effortless.
Yeah. And the cutting power, unlike the unlike the Cusa, the cutting power is also much better.
Okay. Sure. It's practically like an ice cream, only it has scooped it out.
Huh?
They scooped it out like an ice cream only.
Yeah. So that is the beauty of this instrument.
Yeah.
So when we designed it, we wanted to make sure if it goes and touches a vessel or something, it's not going to create any harm. Dura also, it's not going to create any harm.
Yeah.
And we are going to design it much more ergonomically better. And the price of this is a fraction of a Cusa.
Give the action. Hold this. Shashwat, hold this.
You don't have to dissect it, I'm telling you. You really don't have to worry about it. You just can go ahead with it, and you will scrape off everything till the last bit from the dura, and you won't touch the dura, I'm telling you.
Suction.
How do you like this?
Yeah. It's great. You don't have to really worry too much, huh?
You don't have to worry about anything at all.
थोड़ा पीछे जा शाश्वत. हाँ.
The same thing can be done in tumors, even in glial tumors, you know, it can. So this thing we designed.
Yeah.
And only thing is, now we need to get it ergonomic. That's the whole thing. Because for deep usage and stuff, deep bone removal,
Can just remove this now. Just come with an upbite.
huh?
Just this is left.
It's not causing any tears.
No,
on
no,
the
no,
dura
no,
or anything,
nothing,
right?
nothing.
That's why it's a beautiful piece of.
Upbite there. Hold. No, not yet. There. Give the drip. Suck. Just section बीच में आ रहा है सर.
Sumit and rest of the people in the panel, can you see this instrument working?
Yes.
This is a dream thing, you know, if you want to do Petrus or if you want to do an anterior clinoidectomy or a strut removal or something. Earlier people were dependent on bone Cusa. Now this thing which we designed, We designed it with an Indian company, and you touch the vessel, nothing is going to happen, unless of course the vessel is calcified. You don't want to take a risk. I mean, that the Cusa also doesn't give any protection, but this thing has got much more cutting power. The problem with Cusa is doesn't have much cutting power. And in tumors, we have different types of tips here where you can just scoop out the tumor, and the vessel, if you touch it, nothing is going to happen. So we will show you that. And it's a mechanical Cusa kind of thing where we can just attach the tips. We are making it much more ergonomic now. But once we do that, at the fraction of a cost of the Cusa, at a really a fraction of the cost of the Cusa, you will have all this. You will have the drill, you will have the craniotome, and you will have this tumor cutter. It is actually our first prototypes testing, you can say. That is why it may not look a bit ergonomic, but you can ask Abida how the bone is just being shaved off easily.
Saline.
Good, good, excellent, Abida, fantastic. Sumit or anybody, you have any comments?
Yeah, I was watching this beautiful piece of instrumentation that you have invented. I mean, it's a beautiful piece of creativity, and I would certainly love to use this instrumentation and during my surgeries. And is it available in the market?
No, not yet. Unfortunately, it is not yet available in the market. So we have to do a few prototype testings there. See, basically, could you touch the vertebral artery for this? I mean, it's a cadaver, so you can touch the vertebral artery and see if it is creating a tear or something. No?
No.
Yeah, so Abida has gone, and this has got a serrated edge.
Yeah.
So, but the one that we are coming out will be a scoop without any serration. So if you go and touch the vertebral artery or the carotid, it's not going to harm in any way, just like the Cusa. And I would say this attachment would come in 1/35th the price of a Cusa. Can you imagine? And it would have double or triple the cutting power of Cusa. So fast bone removal, especially for Kawase and all that, where you're worried, you can literally shave the bone off.
Yeah, beautiful, very nice instrument.
See what happened here?
Anybody else on the anybody else? Yes, somebody was asking, is it a oscillation saw? Yes, it's a modified oscillation saw. It's from Manman company, and it's actually an oscillation. It's a modified. It's not exactly a oscillation. So it's a modified oscillation. So we put it on that attachment. So here with this drill we can change the torque and the RPM attachment, torque and RPM, that is also programmable here. So once it comes to the market, you will see how it is, and I'm sure all of you will like it. For skull-based surgeons, this would be a invaluable instrument, I'm sure.
Hold the okay.
You got excellent lateral exposure. Huh?
Yeah.
You want to open the dura and
Yeah.
show these
Just
colors?
remove this bit and that's it. Yes, bite is not going in.
You can use the same instrument. Do you have space for that?
No, I think we are done actually.
Yeah.
I think we can open the
you removed
dura.
a lot of condyle, but you haven't seen the hypoglossal canal, so there is nothing to worry about
Yeah.
instability unless you see the hypoglossal canal.
Yeah.
You can open the dura and just go anteriorly, and you will see all the.
नरेश वो गिर गया है, वो कहाँ गिरा है? लगाया? नहीं लगा, आई पैसा या? Yeah, okay, give it. Okay. Suction. So I'm going to go ahead and open the dura, okay?
Yes, please.
Zoom out, please. Knife there. Yeah, okay. हाँ, tooth. कुत्ता भी दे यार. ये पकड़ रहा है आदित्य, स्टिच या कुछ डाल दे, स्टिच है तो स्टिच डाल दे.
You take that dura completely anterior.
Yeah.
Cut it all the way up to the sinus junction.
स्टील ही दे दे. Okay. Yeah, beautiful. Oh man, the brain is tight. You have a brain retractor type of thing by any chance?
Maybe you want to take that part of the
dura.
Also. No, the bone also. That part of the bone which is jutting up.
Suction.
That. Take it out with that thing. Yes, done. He's strong.
Right. I think we are done now. Yeah. That's now that part.
You can cut the dura all the way down and then stitches there. Retract the brain a little bit.
Brain retractor there. Show me that. Take one. Shashwat, can you hold this dura or take a stitch or? Yeah, okay. That's the lower cranials.
It's opening up?
Yeah, a little bit.
Yes, you have the lateral exposure. Complete.
Just hold it, no? There.
That arachnoid has to be completely
Yeah.
taken out, and you will see all the nerves there.
There's the medulla.
Okay, you can see the medulla.
Yeah.
You can see the pica.
Yeah.
You can see, go see the 9th, 10th, 11th nerves. Good, good.
Give me one bayonet.
Yeah. So see the jugular foramen.
Aditya, can you hold this? Steady. Micro scissors is there? Nilesh? Give. Little up, Shashwat. Here.
Where is Nilesh?
I don't know.
Here?
I can't see
You
the.
can see?
Ah. Yeah.
Starting from 9,
Something has
starting
been.
from upstairs, can you show the CP angle and, oh, that's a vessel which is,
Yeah. At suction there?
yeah.
Retractor?
So, Amida,
Yeah, just a minute.
7th, 8th you can show first. Yes, yes. So that is the IAM.
Yeah, that's the 7th, 8th here.
Yeah.
Okay?
So you can see the
Micro scissor.
jugular foramen downstairs there. Okay.
Yeah?
9th, 10th, 11th, you can see.
And that's the 5th.
Yeah.
Micro scissor.
So the whole anatomy of the CP angle and far lateral region, you can see there. So we saw front.
No
You
need.
can see the, yeah, you can get that dura a little bit down. And you can retract the flocculus and see the pica also.
Really? We'll cut it a bit. Wait. Give me a.
And you can see the lateral aspect of the medulla.
Yeah, okay.
And if you go further, you will see the anterior aspect of the medulla with the pyramids and everything. You can see that also. Go down below the. I didn't have to finally scrubbing.
We have the arch here actually.
Yeah. So if you cut down to where the vertebral artery enters, you can see the vertebral artery entering, and you can completely take off that dura to that side. So that's a cerebellomedullary cistern. You can see that bluish discoloration. The cerebral, that's where you will get
Tooth
CSF.
forceps. Tooth forceps. There it is.
See the pica there.
That's the medulla. Yeah.
It's the lateral surface of the medulla. You will see the anterior surface. If you just go a little bit, elevate the flocculus, and then you will see, elevate the tonsils, and you will see
The brain retractor. You'll have to. Yeah, that's the obex.
that is, you can see
Fourth ventricle.
fourth ventricle there.
Yeah, you can see the choroid plexus also there in the roof.
If you go a little bit, turn your retractor,
Yeah.
and then go laterally. You can see the entire. You can see the pica also there.
Yeah.
And see the entire rootlets coming out there.
Bayonet.
And then you go see the 11th and the 12th anteriorly. The pica is there.
Yeah, that's the
In
vertebra.
the depth you can see the pica there.
Yeah, that's vertebra.
Beg your pardon?
Yeah, there are the rootlets of the. This some vessel has been, I think cerebral vessel has been cut. Yeah, the rootlets of the lower cranial nerves.
Can you see the pica in the depth?
Yeah. Oh, the rootlets will get. It's too tight. The brain is too tight. Right?
Obviously.
Yeah.
Focus onto the pica
Yeah.
there. And then the vertebral also. Vertebral pica junction you can see there.
Yeah, there.
Right.
Yes.
I
Yeah,
think
that's
I
the
might
vertebral junction. Yeah.
because it's becoming difficult for me to. I'm having a high fever now again.
Sumit, you wanted to tell me something?
Yeah, I tell you that I'm afraid that
Hello?
I might have to. It's been high fever again now. So I would like to, you to excuse me for a while.
Yes,
I will
yes,
come back
Sumit.
and
Yes, yes.
go inside and take my medicine back. Okay.
Yes,
Right?
yes, Sumit, please.
Lower cranial.
Yeah, thank you, Sumit. Thank you so much for being there, man.
Yeah, my pleasure. My pleasure. Thank you so much.
And above that is
Right.
7th, 8th. Yeah. There it is. Here, yeah, yeah,
Abida,
yeah.
I'll also carry on.
Okay.
It's done. Bilateral is done.
Yeah.
C1, C2 is done.
Yeah. So I
These
think.
guys can, see around for some time. And after that, we start at 4 o'clock. You
Four.
guys can go.
Yeah.
Let us go for lunch.
Yeah, let's
The
go.
food court, if it is there. Go for lunch, and then after that, we'll go for lunch. I mean, first, I'll just go home and then maybe come here to pick you up. You change.
Okay.
Or you want to change right now and come?
Yeah, I'll come to the.
Come.
Okay. Can you remove this mic, please?
So today's dissection was about C1, C2 and far lateral extreme lateral.
Well, Abby, we don't have any sound. Abby, you're right. We don't have sound. Hello, Abby. We don't have sound. Hello, can anybody hear me?
Hello.
Yeah, we're not having sound, Dr. Nilesh.
Actually, we have completed the dissection. We shown all the nerves, and
Okay, they weren't commenting then. Okay.
Yeah.
Okay.
Yeah. After Abhida madam has just completed dissection, Dr. Shashwat is here. He is doing the carrying forward.
Okay.
Yeah. John.
Yes.
I think we are wrapping it up now, and we will start the online lectures webinars at 4 o'clock.
Okay, very good.
Yeah.
Okay,
Yeah.
let me think if I'll use the same link. Uh, yeah, we'll use the same link. Okay.
Yeah. Yes.
Right. So that's in how many hours from now? 4 hours. Is that 4 hours?
3 hours 40 minutes.
3 hours and 40 minutes. Okay, we'll keep the same link and we'll see you then.
Yes. Thank you, John.
Thank you, Doc. Okay, I guess everybody heard. We're going to leave this meeting. I'm going to keep the same link. I may even leave this open. And you're welcome to stay. I'm not recording it. And I guess I'll stop it on YouTube also. I'll just leave it on YouTube so people can still watch it. I guess you can have worse backgrounds. Okay, we'll see you in 3 hours and 40 minutes. Was now streaming live on YouTube. How the heck did that happen?
Hello.
Yes.
Yeah, I think John, we can close it, and we will meet at 4 o'clock.
Yes.
Yes.
Okay, well, I'm just going to leave this open though. Okay, it's not being televised, it's not being recorded. Okay? Greetings, everybody. We start, I think, in a bit. Yeah, we start in a few minutes. Okay. You can hear me, Corrado, you can hear me. I don't see you in the room. I don't see you. Okay. There's no difference between attendee and panelist. Oh, I see. Oh, okay. There, yeah. You're in the chat.
Okay, now you promote me panelist.
Yeah, yes. Yeah, you are. I didn't realize that You were in the waiting room.
I was just attending before.
Yeah.
Okay, 30 minutes.
Yeah.
So I will back.
Okay.
Okay, I use that link, the last link that you sent me.
Yeah, the same link.
Okay.
Hello, John.
Hey, Emmanuel, how you doing?
Oh, good.
You doing okay? Is it still sunny in Moscow?
What?
A lot of sun in Moscow? A lot of sun?
I'm watching. It's very sunny. It's very sunny. It's very sunny.
You put your suntan oil on?
What?
You put your suntan oil on?
Yes, yes, yes.
They would think you're crazy in Moscow.
You should come to Moscow to take the sunny time here.
Yeah, my brother lived there. He wanted to stay there. He was in Moscow.
Oh, really?
Yeah. He was selling real estate. But at the time, the mafia was very strong.
Ah, yes, 90s. It's something like 90s. 90s was
Right. He was here in the 90s. And he could not believe it. He could not believe it. He said when he made a deal, the mafia would come and say, "Okay, you owe us 15% of the And he said, "This is ridiculous. I can't do business." But I think it's changed.
Of course. It's I find Moscow extremely safe. It's a very safe place.
Really?
Yeah. Yes, Moscow is very safe now.
Yeah. Okay. Hey, that's a great background you got there.
Oh, thank you. Thank you.
That's probably part of your topic. Hello.
Can you hear me? I'm Sina.
Hey, how you doing?
You can hear me?
Yes.
Okay. Thank you.
Yeah, we can see you. You're presenting?
Yeah. I'm presenting.
Okay. I think you're first, Manuel, right?
Yes, I go first.
Okay, I think in 7 minutes, I think.
Yes. I also I prepare. Do you know, John, this application? It's called I forgot. I'm getting old. I forgot the name. It's called Prezi.
Too much sun.
Too much sun. Yes, it's
it's getting to your head.
Neurons. John, it's called Prezi.
Prexit.
Yes.
Really? What is it? What kind of platform is it?
It's very good for make presentation. I already prepared a presentation of the basal system. Maybe I'm gonna make it next week, or it's like it's something like I was talking with Professor Cherian, because for cystonostomy you must understand very well the system is the base. So
yes.
what I prepare already the presentation. I'm gonna show you because the effects is very nice. The effects of the wait. I think I can show you like.
Okay. Yeah. Sure. We got a couple minutes.
Yes. Give me a second.
Oh, Simmer. Okay.
What are you doing?
I'm sorry. Go ahead.
Okay. I'm gonna share my screen.
Okay.
You see, John? This is the presentation.
Yep.
It's very intuitive, very easy to use.
Is it? Oh, those are kind of make the slides bigger on its own.
Yes, make the slides look very different.
Oh, okay.
You see?
Brexit, huh?
Brexit. And here I have a presentation here because inside of the pictures you can put the presentation. You see this cool effects it's give. And I get here. You can put videos.
Yeah, things are changing, and let me tell you about artificial intelligence. I heard from a company that said, "Hey, can we come into your webcast and analyze it, and first of all, write a script for it?" So in other words, I would let them in the panel like I let you in, and they do something. They record it, and I think there's going to be lots of things you can do. With the AI, you can analyze the script, and you can, I don't know, you'll be able to put into I don't know what you can do it, but I think there's a way that a presentation will be put into a big data bank, and you'll be able to organize it and etc. There's a lot of possibilities, but anyways, I think all presentations will be analyzed by AI.
Yes, that's true.
Yeah. In some way, I know it's going to be used.
Can I share my screen? Can I check my presentation?
Go ahead.
Yeah. Okay.
Yep.
Okay, no problem.
No problem. You want to make it big?
Yeah, I will make it big.
Yeah, there you go.
Good.
Yeah, perfect.
Okay.
You got it.
Okay. Thank you.
Okay, I guess I'm gonna see who's moderating.
You know, John, now I am learning German.
Oh my God, ach du Liebe.
Yes, in my free time, so I'm learning German.
Oh my God, you really?
I finished with the French, so now I am working in that.
Are you gonna work in a?
No, but it's like a hobby. It's
okay.
To put the brain to work all the time.
Oh, okay.
It's something I learned, John. More language you speak, more doors are open for you.
Yeah. Oh, if I learned Spanish, I went to school in Mexico. I had no idea I would end up in Miami. It's all Spanish here. It's all Spanish. So, and when I first started working, I got all my jobs because I spoke Spanish.
That's good.
Yeah. It was great. I mean, it was such a big advantage in a town, and I couldn't believe doctors were getting by without speaking Spanish with, 100% Spanish people population. Oh, okay. Well, who's going to moderate?
Hello, John. This is Nilesh here.
Oh, how you doing? Okay, so you're going to moderate, right?
Yeah. It's already 4 o'clock.
Okay, you ready
to start with the manuals presentation.
Okay, you ready to start?
Hello.
Hello, are you ready to start?
Yes. Manuals presentation was going to be start at 4 o'clock. I think we can start. Cherian sir has not yet logged in, but I think we are ready to go.
Yeah, manual's here.
Yeah, we can start.
Okay, 10, 9, 8, 7, 6. Let me get you off there, Nilesh. And Dr. Sinha, let me mute him. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett. Oh, hold on. Let me get for some reason, the showing you, Dr. Nilesh. Let me just get this straightened out first before I start. Are you related to Daniel Encarnacion, Manuel?
What?
There's a Daniel Encarnacion. Are you related? Are you related to him?
Where he is?
He's here. Daniel Encarnacion.
Maybe I know a Daniel. I don't know what this is him. From where he is?
I don't know. He's in now. Hey, Daniel, you here? Okay. Yeah. Let me just straighten this away before we start. I got to figure out why the screen's not go. Okay, it's going.
Maybe it's because I have a friend here. He also studying neurosurgery here. Maybe it's him. Maybe it's him.
Hey, let's start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach in the continuation of the Krishna Institute of Medical Sciences Cranial and Spinal Trauma. We have Manuel Encarnacion here. But first, let me turn over to Nilesh, Dr. Nilesh from Krishna. Hello, Dr. Nilesh.
Hi, John. Hello.
Okay. Hi.
Can you hear me?
Yes.
Yeah. Are we ready to go? We can start the meeting.
Okay, Nilesh, could you introduce Manuel, please?
Okay.
Do you want to, or do you want me to?
If you could, please do that. Because I have to search for that presentation.
Yeah, don't worry about it. Hi, Manuel's been doing presentations for a while. He's from the Dominican Republic, and he learned Russian, and I just found out he's learning German. So let me just turn over to Manuel right now. Hi, Manuel.
Hello, John. How are you?
Good.
How are everybody? How are you?
Good. I can see you got a lot of sun.
Yes. Moscow is very sunny today, especially today.
Good to have you. Okay. Could you introduce yourself and before you start your topic?
Yes. My name is Manuel Encarnacion. I am third-year resident of neurosurgery of the University Rudein, Moscow, Russia.
Welcome.
Thank you. I am ready, John, when you think it.
Yes, we're all ready.
Can I start?
Sure.
Well, we're going to start to talk about the history of the head trauma, because it's very important to understand. It's a very important part of the neurosurgery. So the knowledge of the prehistoric medical practice comes from two disciplines, which are in one hand, the paleopathology. There is the science that studies the disease in the primitive man, and the paleomedicine is the science to study the medical technique used in the past. Probably the first hominid appears in Africa, the Australopithecus. This is the first one you can see here. Later of the Australopithecus, we have the Homo habilis, who can use instrument and can be in bipedal station, but also sometimes need two legs on the hands to walk. And later we have the Homo erectus, who can frankly walk in bipedal station. Since the men can start to use instruments, start to hurt each other, and the trauma, head trauma, start since that time. Hippocrates, father of the medicine, he says, nullum capitis vulnum contemnendum est. It means no head injury should be considered trivial. So all the head injuries are very, very important. Skulls found in the battleground grave with with the hole drill.
Okay, you there, Manuel? May have had a slow down of his connection. Are you there, Manuel? Okay, just hang on. Okay, I think he just dropped off. Just hang in there. He'll be back.
Hello, John.
Hey, Manuel, go ahead. Continue.
Yeah, sorry, my connection fault. Okay.
Okay.
Well, what I was saying, this civilization, in the Mesoamerican civilization, we have a lot of head injuries because you know the theory of the noble savage. It's an oxymoron because, like Rousseau say, the man is kind, the man is noble by nature, but it's the society who corrupt them. No, that's not true because since the humankind start to live in society, we have violence and we have a lot of head trauma. You can see here in the Inca civilization, we can find the whole drill hole, even the cranioplasty using gold. In the ancient Egypt, we're gonna find the Edwin Smith papyrus. It's a scroll of 4 meters. It have writing in the since the 3000 to 2005 year before Christ, and probably is the most older document of medicine in the history of the humankind. What is important of this papyrus? In this papyrus, it's important because it have 48 description of clinical cases. 27 of these cases was about head injuries. In this papyrus, they work with science very precisely, not using magical culture stuff. No, it was working with the patient, directly with the patient. This papyrus was translated by James Headrested. Was Edwin Smith get the papyrus in the 1862, approximately in this time. People attribute the papyrus to Himotech, and they say he wrote them. From these cases, the most important is the case number 6, the case number 8, and case 22. Why? Because in case number 6 is it says after a head injury, the open skull. This mostly refers to the molten copper, this circumrugation inside the head. This look like the first description of the gyrus of the brain. In the case number 8, in this case it's important because it's described in which side of the body affecting the head injury. We have a case of the contracop here. And the case 22, this case is amazing because this talk about a patient who have an injury, a fracture in the temporal bone, and the patient cannot talk. So if we see in this case, 2004 years before, they already are talking about aphasia. In the Greek times, the intellectual development of the neurosurgery began during this golden age of Greece. There is the ancient times, we have the Hippocrates writing, he wrote in his school. And Hippocrates was very important. Why? Because we have these treatises Hippocrates treatise. The Hippocrates treatise was the most important was the Corpus Hippocraticum. Have two parts very important, which talk about the head injury. The first one on the wound of the head, and the epidemic, the other one. On the wound of the head, Hippocrates described how the skull and bone are formed by two layers, and in the middle of them we have the diploid. Also inside the meninges. He reported the anterior part of the skull, it's thinner than the posterior, so it's more possible to have fractures in this area. He also said the debrief fractures need to use trepanation. Also, he described in the wound of the head the technique from the trepanation. This is a copy of the Hippocrates. In the epidemic, he talked about different cases of patients. It's like a clinical history of very patient of a guy who had a head injury, and they used the trepanation on him, like in the frontal bone. This is a myth of Aeschylus. This is a Greek performance in the theater. The legend say he went to the oracle, and the oracle say you're gonna die by crushing by a house. A house is gonna crush you, and you're gonna die. So he went out to the valley, very big area, and live there to avoid to his house fall and kill him. And what happened? What the legend say? An eagle was flying with the turtle in the hands, with the turtle, and because the eagle need to open the turtle shell, let it fall unfortunately fall in Aeschylus' head. So this is another case of brain injury, traumatic brain injury. In the Abrahamic religion, we have the case, we have the legend of the David and Goliath. It says David was very small in comparison with Goliath. He had a Honda, and with the stone, he crushed Goliath's head in the frontal bone. He fell and he died. He killed him after that. So a very important figure in the Roman medicine was Aulus Aurelius Cornelius Celsus. Oh, sorry. His merit was collect appropriate medical knowledge at the time in his treatise, De Re Medicina. This book was lost until 1443. Some of these patients he described in his book suffer from this wound, lose their sense, and not hear when they call it. Also, they have a fierce look and deadly gaze. Most often, delirium comes after the third day or even the fifth day. Also, is come with the convulsive movement. That was part of the description in this book, what he said. If we can see, was very precise description of the traumatic brain injury and the consequences in the patient. He say also, when you need to operate the brain fractures, the skull fractures. So Galen, he recommend remove all the bone fragment, particularly all the depression brain. If they said depression fractures, need to remove all. Galen was also very optimistic, more than Hippocrates about the brain injuries. Paul de Aegina, he was the first to suggest that the possibility of the intraventricular hemorrhage. It might also hydrocephalus. John, are you hearing me?
Yes, we can hear you.
Okay. Sorry for my Arabic. Abu Bakr Muhammad Ibn al-Ghazi. He was the first one to introduce a concept of concussion. That's very important. About the head injury, he wrote, it's among the most devastating of all injuries. He advocated the surgery only when it's a penetrate injury of the skull. The outcome always was fatal. He understood that the skull fractures is because a compression of the brain require elevation to prevent the lasting. So in the medieval time, wasn't the most peaceful time. So if you ask, so the Egypt, the Greece, and the Roman already they talk about brain injury, but a lot of this knowledge was missing. Almost the Egypt knowledge was in the Alexandria library, but as you know, was burned by Julius Caesar in the 48 before Christ. So this a lot of knowledge of the Greece and the Egyptians was missing. Constantinus Africanus introduced the Arabic medicine to the school of Salerno and to Europe also. Roger di Salerno, in his book Chirurgia Practica, introduced an unusual technique of checking for the tear of the dura to see if there is cerebral fluid leaking. In that time, they don't know the function or what is the cerebrospinal fluid. For the leakage of the patient with the skull fracture, what he did was to say to the patient to hold the breath. So it's now we know this is a Valsalva maneuver, and he see if there is liquor going out also if there is bubbles. Theodoric Borgognoni was a surgical. In his surgical work, he appreciated the importance of the skull fracture, especially one in the depressing skull fractures should be elevated. Guy de Chauliac was the most influential surgeon in the 14th to the 15th centuries. He used egg albumin to provide adequate hemostasis. Always was very difficult in that time to the surgeons. His great contribution to the surgery, to the surgery, was to write the most important work of the craniocerebral surgery, Tractus de Fractura Calvae Sive Craniae, in which he described the entire set of surgical instruments to use in cranial operation. Also, this was a systematic treatise to compare mechanism, classification. Even he made 7 classifications of the skull fractures. He was very famous because he operated one of the Medici family because he had a fracture of the occipital region. Dominique Jean Larrey was one of the surgeons of the Napoleon army. He was very famous because he made a lot of trepanation even in the battlefield. So we can say that was one of the first war neurosurgeons in the battlefield. François Sigot de Perron, he was very famous because maybe no other surgeons before him made more approaches for the craniocervical and cranial traumatism. He's famous because he make a lot of experiments in live person. Remember, we don't have the treats in that time was like almost normal, make a live experiment and even vivisection, dissection in life. Brain trauma in the surgical time, in the military surgery. The penetration brain injuries become extremely frequent with the introduction of the firearms in the 18th centuries. The manual of the Dr. John focused on the scalp wound and the depression fractures. This manual stresses the usefulness, the prophylactic, and of the trepanation. He even used an algorithm for that. So we get to the First World War, and we can say we find a new way to kill each other from this time. During the First World War, the pioneer of the neurosurgery, such as Harvey Cushing, he served in the British and the US armies, offering the traumatic brain injury patient the most advanced treatment available at that time. Required to define the management was only possible in specialized hospitals. In the Second World War, this can be a full presentation apart. John, I am on time?
Yes, I believe so.
Okay, so during the Second World War, the care of the injury was provided by the better organized care system. Using a standardized instrumentation, the neurosurgery is already standardized, is already settled, like a specialization. We have the blood transfusion, improvement of the anesthesia and the antiseptic. Specialized treatment for the head injury was promoted by the Oxford Group, led by Sir Hugh Kerr, who created the motorized neurosurgical unit in the battlefront. That was the first mobile unit was in Africa, in the north of Africa. The main or not only possible traumatic brain injuries treatment, however, was the surgery. There was no specific therapy for the traumatic brain injury. A fatal outcome was always expected. You can see here, this is a case of the traumatic brain injury, penetrating brain injury in a patient in Italy, in the front of Italy. You see, the debate regarding always was the benefit of the delayed surgery or the fast in the moment surgery was fierce. But the evidence accumulated by the surgeons was make it fast, make it now. So after World War II, the interest of the traumatic brain injuries declined. The general feeling was that severe cases were not amenable to successful treatment in some of the self-fulfilling prophecy. However, these patients were ultimately dying because of the respiratory failure or the concept of the preventing treating respiratory complication. You can see here some of the Vietnam War time, and also you can see here a patient who was using the Hamlet and prevent his it's 100% death. Да, medium.
Oh, okay.
Sorry. So the improvement of the diagnostic in intracranial lesion, the possibility of the imaging in the intracranial vasculature by injection. We remember the Egad Moniz, when he was a Portuguese doctor. He introduced in 1927 the angiography, and later one of the most important was one of the most important of the past century was the CT. The standard diagnosis of the CT was in October of the 1971 was made the first CT scan, and a couple of years later, of course, they got the Nobel Prize. In the 70s, also it's important in Glasgow City, by Janetta and his group, the development of the Glasgow Coma Scale, who give to us the outcome of the patient. We don't want to even talk about the part of the Glasgow Coma Scale. We already know here. So the new problem we have with the traumatic brain injury, as with the beginning, we find, as I said, we find a new way to kill each other. The traumatic brain injury in this time, mostly in the war zone, are very catastrophic. There is more than 27,000 articles of the ICP at the same database. And the traumatic brain injury is a huge problem in the developed country, in the outcome country, like in Latin America or the Caribbean. Why for? The lack of the knowledge of education, they use the right protection in the day by day, in the car, in the motorcycle. So, thank you for your attention. Gracias por la atención. Gracias. Preguntas, comentarios.
Okay, thank you, Manuel. Ipe, are you here?
Yes, excellent talk, Manuel. A very good talk. Thank you very much. Now, Nilesh is here. Is Nilesh around?
Yes, sir.
Yeah, Nilesh, please.
Yes, sir. I'm hearing you. Next talk. Next talk is from Dr. Samir Hos on the blast-related traumatic brain injury. Is Samir here?
Yes.
Yeah.
Welcome,
Yes,
Samir.
I'm here. Welcome, John.
Welcome.
Hi, everybody. Hi, Dr. Ipe. I hope you are doing well. And thank you for this opportunity.
Well, Samir is somebody whose work I have been following over the years. And I have been very happy to see how he's progressed over the years. And I'm really proud of you. So please go ahead and present your work, Samir.
Thank you, sir. Thank you for your kind words. John, is the full screen there?
Yeah, perfect.
Okay. So, hi everybody again. Thank you for the Neurosurgical TV for such opportunity, and thank you for Professor Ipe Cherian for giving us sharing different experience from different parts of the world, especially regarding the trauma. And today's topic, I'm Samir Hos from Iraq, and today's topic will be a blast-induced traumatic brain injury, a peculiar type of brain injury, and maybe have a different characteristic and different management strategies. It's not about options, it's about the strategies. So I will take approximately less than 10 minutes describing giving an overview about this specific type of brain injury. I have no conflict of interest, and I always start my presentation with this slide. We are not in ourselves superior to our father, and we are shamefully inferior to them, or we do not advance beyond them. Many mentors from different parts of the world. I think there is something on the screen, John. Okay, so a blast-induced traumatic brain injury, it's mainly related to a car bombing causing a head injury, causing a various scale of head injury. I think Iraq, one of the hottest spots in the world regarding such type of injury because of the war against terrorism. And according to our review, that Baghdad, which is the capital of Iraq, witnessed the highest number of bombing attack as per city in the world. Maybe in Afghanistan or Pakistan, a comparable rate, but I think Baghdad as per blast-related injury, it's the hottest spot and the which is unfortunately and the highest number of bombing occur in Baghdad, which is our city and the capital of Iraq. So, in general, I want to highlight the damage control neurosurgery, which is um, a nice concept in neurosurgery, specifically related to trauma. We usually hear about damage control surgery that's applicable for the general surgery, but here, damage control neurosurgery, a tailored triaging system I will describe. We use it for such mass trauma, and we always need alter the standard while facing such disaster, and if there is a future perspective regarding the blast related traumatic brain injury. So as introduction, I will give some numbers, and yes, it's maybe a frightening number that in recent decade there is tenfold spike in terroristic activity over the world, and specifically for the blast previously was used on in the military setting, but now 60% related to terroristic attack. So mainly we are discussing a civilian injury rather than the expected military. That's a main difference here, that these blast injuries targeting civilian people, those unexpecting or not protecting themselves, that will cause a mass casualty, overwhelm even the most sophisticated care system. That's why we are sharing our experience. Um, and what we mean by car bombing, scientifically we call it vehicle-borne improvised explosive device, and the quantities may be held within the car, may reach up to 3,000 kg, and in Iraq specifically from 2003 up to now, more than 20,000 explosions, 1,600 suicidal attack, mainly by blast, killing more than 100,000 people, and wounding the wounded population is much more of that number. That's sadly a gruesome injury. And in 2009 specifically, which is the year that we make the study in it, there is more than 800 explosion and suicidal attack, including 82 vehicle-borne improvised explosive device. I mean, blasts related to car bombing, and this eventually killing more than 4,000 civilians. That's how severe the injury is, how focus this type of this mechanism of head injury should take care of it. So in general, as per ballistics and mechanism, the blast related injury include a primary type of injury or a primary wave, which is the direct, then the secondary, where the other particle or missile hits the victim, and finally the tertiary, when the victim fall or stuck by other stuff. And even some article added a quaternary blast injury, which is related to heat and chemicals. That's the mechanism of the blast injury and how it hurt the body. And from that point, we go and start to document this injury, because in Iraq, as like most of the let's say undeveloped country or developing countries, as per healthcare system, we have no real documentation, no real systemic documentation. So we start so the documentation is already one of the toughest job while doing such studies. So we are happy to finally publish this article at the titled "The Blast-Induced Traumatic Brain Injury Experience from the Deadliest Suicidal Double Car Bomb Attack in Iraq." This is study done by Iraqi neurosurgeon practicing in neurosurgery teaching hospital, and with the support of our resident aspire to be a neurosurgeon, Zahra Sharshahi, which is a very brilliant person, help us to document and to share our experience with the world. And also with the supervision of Dr. Ali Biden from Johns Hopkins, Maryland, USA. So the incident we are talking about is occurred in 2009 near in the center of Baghdad, involving two suicidal truck bomb with an interval of like 10 or 15 minutes between the two bombs that will result eventually in more than in 152 deaths, and I think more than this number, but the documented number of injured people is 520, which is very deadly regarding morbidity and mortality resulting from this attack. The setting is the neurosurgery teaching hospital, and we analyzed the patient according to all the possible parameters. And this is the summary of our study that in the neurosurgery teaching hospital, we received 75 patients. You can imagine that these patients were all received at the same time in a tertiary center for neurosurgery. So it's a very high number. And from the 75, 19 died directly or immediately in the emergency department, 56 admitted to the hospital. From that number, 39% go direct or patient go direct to the surgery, and the other treated conservatively either in the neuro ICU or in the ward. As per Glasgow outcome scale at the discharge, eventually 17 dead from the admitted patient and the other between good and poor outcome. In general, it's a poor outcome for such type of injuries, but let's take it from the neurosurgical point of view or from the management point of view, that doing 39 surgeries for patients coming at the same time, this is a huge number, and actually it takes 4 days, 24 over 24, with the 3 operating room working in parallel to manage such number of patients. That's the general idea of how we manage this patient. As per statistic, we analyze all the possible parameters with the patient regarding imaging or associated injuries, and also management and outcome. Specifically regarding the management, we took a step further. While usually such injuries described are decompressive craniectomy, we dig in the details and divided it into hemicraniectomy or bilateral frontotemporal craniectomy or posterior fossa craniectomy, and compare it with other factor to ask for the significance or the difference between these treatment options. Also regarding corticectomy, while dealing with the wounds, sometimes there is a brain tissue injured. Either you can do localized corticectomy, or sometimes you are obligated to perform frontal lobectomy or even temporal lobectomy. These factors studied in detail, and this is in our study. And even for we perform subgroup analysis comparing Glasgow below and above 8, pupil normal versus abnormal, according single versus multiple shell injury, single versus multiple lobe injury, and even intact or injured dural venous sinus. Also, we add I think a new factor if the patient has a brain tissue out from the wound at the reception in the OR or not, and how it affects the prognosis. This specific point, I will talk about it later, but statistically, these subgroup analysis give no significant difference, but give a comparable, and that one of the expected result from such random injuries. As I said before, the damage control neurosurgery, it's not very well discussed in all the study, but here we are focusing, comparing it to the standard surgery. It's a difference in the speed and efficacy of operating room rather than a difference in the nature of the specific surgery. The damage control neurosurgery, we mean by it to elevate the depressive fracture, removal of shell or accessible bone, hematoma evacuation, cleaning and debridement, hemostasis, dural repair, and then wound repair. That's in total called, we call it the damage control neurosurgery. This means that doing the most urgent thing only and leave time consuming steps for a later surgery. That's the idea. I think as per management, we put it in this context. In hospital, four-level triaging approach, while receiving the patients, the first stage occur in the emergency department, two neurosurgeon and four resident receiving the patient and doing a primary survey according to ATLS, then all the patient referred to the level two. Level two is occur near the CT scan in the radiology department. Two radiologists involved with a neurosurgeon so he can take the decision at the CT scan while doing the CT scans for the patient one by one. And from this, from the radiology unit, either the neurosurgeon decide to transfer this patient to the nearest hospital if there is polytrauma and need other specific treatment rather than neurosurgery, or refer to the next levels, either direct to the ER or direct to the ER or to the neuro ICU. Level 3 in the neuro ICU, two anesthetists, one neurosurgeon, and two residents. Those with a Glasgow less than 8 or need stabilization and preparation for surgery, or not candidate for surgery but need ICU maybe for respiratory care. All these are admitted to level 3. And level 4, it's a 3 trauma neurosurgery ORs where in operation at the same time, each with a neurosurgeon and resident working together, and it take, as I said, 4 days to finish the 39 surgeries. That's the real challenge, and this maybe for practicing in neurosurgeon, they know the difficulty while managing 39 at the same time is the prioritization. Some sample of blast-related injuries that we receive or we expected from the CT scan. These are the findings, examples of the finding. Also, sometimes you find a large shell from part of a car sticking in the head of the patient. All are severe injury and gruesome. As I said, I will return to the brain tissue out point. Sometimes in the emergency department, the patient came with the brain, came out from the wound, and this will be inside the operation and require cortisectomy. Sure, any brain tissue external to the skull, this is mainly non-functional tissue. And specifically regarding this point, that traumatic acute, we call it brain tissue out, call it, or traumatic acute extracranial cerebral herniation, we found very few talks about it in the literature. So we explore it into another article in the form of letter to editor asking about how much do we know about this type of, or this parameter of injury. That's in general, that's the idea that I want to give about the blast related. It's just, I can just give an overview. I invite you to read our published article because it contained all the details. You know from this presentation that more details for each step can be discussed. And yes, that's the type of trauma that we are dealing with it here in this part of the world. And also maybe in a later presentation, we can discuss total different type of trauma. It's caused by tear gas canister, which proposed to be a safe um, 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 issue, but in Iraq and the final, in the last year protest, we receive such type of injuries. All are tear gas bomb penetrating the skull, and yes, I think for a neurosurgeon, it's rare rare imaging how this canister enter inside the skull, and for sure it's mostly deadly, and you can think that this patient came alive to the OR, to the emergency department, and thus require CT scan, and a lot of patients do not reach the emergency department already. All of the work, and I think from the tier system or the triaging system, we propose that managing trauma or massive trauma definitely require a team and a synchronized team to give the best result for the patient. And thank you. I'm ready for any question if you want.
Okay, very good. Thank you, Samir. Ipe, are you there?
Yes, yes, I'm here. I see Samir, very good, excellent talk. And now I see Professor Goyal is here. Are you here, Professor Goyal? Are you here? Sir, are you here?
Yeah, I told you you're muted.
Yes, yes, yes. Now can you hear me, Ipe?
Yes.
Yes, absolutely. We would like you to talk something about this whole ongoing thing about decompression versus cystonostomy.
Okay, so I will first, can I start talking now?
Yes,
you think? Okay. Okay. I'm going to talk on reconstruction of skull. Okay?
Yes,
which
yes,
is very, as you know, which is very important topic for trauma. And then after that, I will talk on decompression. But you know what? I will talk on decompression in the way I feel like, and in the way I think it is correct, and in the way I think it should never be done. Essentially, I have a feeling which is very, very contradictory to most of the people in the world. My feeling is maybe I will talk to you about that after I finish my lecture on reconstruction. Okay?
Yes, yes, absolutely.
So you can see my slide, Ipe?
Yes, sir. Yes,
you
sir.
can
We can
see my.
Yes, we can see.
Okay. So you know what? The scalp is the most vascular skin, And when it bleeds furiously. And when it bleeds, there are some special ways to control that bleeding. It is not the bleeding of the skin of the abdomen or the hand. The control of bleeding of the scalp is completely, absolutely in a special way that we all know. The other thing that we must know, when we talk about trauma, is when there is injury of the skull, the whole brain is a very protected environment. It is, I call, a sacred environment or a spiritual environment. There is not a single bacteria inside that environment. And that environment is enclosed by the dura. The dura is the compact cavity, and it encloses the brain in such a manner that it will not allow any small little bacteria to enter into the skull, into the brain. That is one beauty. You see, the brain is surrounded by nose, by ear, by all kind of nasopharynx, sphenoid sinus. There are so many bacteria outside the skull, but not a single bacteria inside the skull. And that separation, that compartmentalization is absolutely given by the dura. So we have to remember that this compartmentalization has to be maintained. So also I must, before I start my lecture, I must say that brain has some special powers. You see, when the head gets injured, when the skull gets injured, even the brain matter can come out, and lot of, muck, stones, garbage can go inside the skull cavity. But how many brain abscesses have we seen following trauma? I have to say that brain abscess following trauma is an absolutely rare phenomenon, because there are some special reparative mechanisms of the brain which does not allow infection to occur. It can occur. You see, meningitis can occur, infection can occur, brain abscesses can occur, but they are extremely rare. The amount of trauma, in Mumbai, There are about 150 skull fractures daily in Mumbai. And there are several deaths in Mumbai due to trauma, which is, of course, due to severe trauma. But skull fractures are 150 daily, and the brain matter, dura mater injury is at least 10 or 15 daily. How many brain abscesses have been seen? I will say in my, in my career, I have not seen a single brain abscess related to trauma. I have seen abscess due to ear infection, due to various other kinds of things, but not due to trauma. So brain is a special compartment. Brain is a spiritual compartment. It is covered by a lot of blood vessels. Scalp is the most vascular structure, vascular skin. And apart from the scalp, you see the vascularity of the various facial layers, the gallia, the pericranium, the facial layers surrounding the temporalis muscle are extremely vascular structures. The other thing I want to touch is, you see, when there is a basal fracture and when there is a CSF leakage, you know that that leakage can kill the person. And at that time, it is absolutely critical or crucial to do a good reconstruction. And also at that time, it is critical to do vascularized pedicle reconstruction. Okay, so I will now, you see, this is the scalp and there are multiple blood vessels, middle, the deep temporal arteries, anterior, posterior, middle, deep temporal artery, superficial temporal artery. There is a facial layer, deep temporal fascia, superficial temporal fascia, and this fascia continues. Another beautiful thing, I hope you are listening?
Sir, I'm listening. I'm here, sir.
Yeah, I have to say one beautiful concept. You know, we say that the fascia finishes here or fascia ends here. Fascia never ends. Dura never ends. This is like a folded membrane, folded, and the whole body is of folded membranes. Membranes are the mother, dura mother, arachnoid mother, pia mother. So these membranes are completely folded to make the whole body. Similarly, you see this superficial layer of the deep temporal fascia, the deep temporal fascia, and then there is a gallial layer, and then there is another layer that we have described, I will show you, a subgallial fascia, which is also a very vascularized structure. So I will now show you how to reconstruct the skull and the skull base in the event of tumors, in the event of skull base surgery, and in the event of CSF leakage. So one must remember that the superficial temporal fascia, the deep temporal fascia are all continuous with the pericranial layer. There is no marginalization. It doesn't end here. It is continuous. Gallia is continuous. So between the gallia and the subgallial layer, there is a movement. You see, we can move our scalp. We can move our scalp in the subgallial plane. And this movement is also an absolutely protective, nature's miracle. You see, this movement is a protective phenomena of the body. So we must remember these small little things. One thing is the facial layer. You see this facial layer I have shown here? These are continuous. It just covers the whole skull. These are continuous. These are huge membranes. And also we must remember something we do not remember and something we do not recognize and something we do not use is these are vascularized pedicle flaps. And I have to tell you that we have to know and we have to learn these vascularized flaps. So I'm going to show you some alternative methods of reconstruction, alternative methods. My keywords are, they are all locally available and they are all vascularized pedicles. Suppose we are going to do this tumor, which is inside the skull and outside the skull. Suppose we are going to do this tumor, middle fossa coming out of the skull. You must know that you can remove the tumor and you can remove the whole tumor, but then you have to make a very strong reconstruction. and you have to make a small, very strong and very, very strong reconstruction, because you do not want to communicate a spiritual cavity with a zoo of animals in the paranasal sinuses. You do not want to communicate the most spiritual compartment with the most animated compartment of the body, which is the nasopharynx and the oral pharynx. You know, the number of bacteria, animal biomass in these two cavities, you cannot even imagine. They're whole loaded with bacteria. And then if we have to remove this tumor, we have to make a very solid compartmentalization. And that compartmentalization has to be so strong that we maintain the spirituality of this brain. That is very important. So I will show you some techniques which I have described of skull base and convexity reconstruction based on vascularized flaps, vascularized pedicle flaps. Those are all locally available. And you see, this case I had done in 1994 or 1993, so about 27 years ago. You see, this is the tumor, olfactory groove meningioma, and it is coming in the nasopharynx. You see this tumor? Hype, you can see this tumor?
Yes, sir, I can see this.
See, this is the tumor and it is going in the nose. Either you remove it or you do not remove it. But if you plan to remove it, then you have to give a very solid reconstruction. So 1993, I think I did this. So this is the tumor, and I described this vascularized. I split the cranium here, and then I took a vascularized pericranial flap, and then I turned it over the base after removing the tumor. You can see that? So this is the reconstruction. This is the bone reconstruction here on the skull base. And this bone has been taken from here. Can you see this? This bone has been taken from here and it has been plugged here. And this is in 1994, I described this vascularized bone flap for anterior skull base reconstruction. It is, of course, controversial whether you need bone flap or you do not need bone, whether you can use just pericranium, whether you can use just fascia, or whether you want to use just fat. But this is an alternative. My feeling is you put your reconstruction vascularized flap, and then you rotate a vascularized flap, and you can do a beautiful reconstruction. So you saw this. Now you see this another case. There is a CSF leakage in a big hole in the middle fossa here, quite a huge hole. And there is air bubble here and there is air bubble here. This case also I did about 25 years ago. And now when you are going to do this reconstruction, and this patient is having continuous CSF leakage from the ear, now you have to do a very beautiful reconstruction here. So you first plug this with fat and all those things, and then you can do a vascularized flap based on the temporalis muscle. So you can do, you see, this is a vascularized osteomyoplastic flap. You can put the flap along with the bone along the skull base. After, if you want to use fat, if you want to use other fascia, you can of course use it. But this is a vascularized. So what I have done is you see, I have taken the split bone here and I have rotated the muscle here. You see the osteomyoplastic flap, and I have done reconstruction by taking some bone here and putting the bone here. So split here, here. And this I published in 1994, vascularized osteomyoplastic flap for skull base reconstruction. So this is another kind of flap that can be used. This is another tumor. You see the whole skull is having a tumor. And it is in the forehead. You see, I'm not sure if you can see it properly, but there is a tumor here. Now, if you want to remove this tumor, there will be a huge skull base defect, convexity defect. Of course, nowadays you can use titanium and you can use all these kind of fancy material. But 25 years, 30 years ago, these things were not available. But my feeling is that you have to do a beautiful reconstruction, and vascularized pedicle reconstruction is the best. So what we have done is, you see here, we have split the skull here, and this is the superficial and deep temporal fascia with the blood vessels, and this is the temporalis muscle, and there is a long, you see, we have split and we have retained the facial layer and then split the skull and then rotated the skull. So this is a long vascularized split cranial bone flap. So you see there is a split here, and the bone flap is now reconstructing the forehead, if you can see it beautifully here. So this is a long vascularized pedicle convexity reconstruction. So essentially you can realize that you can split here and you can rotate the flap. You can rotate it in all directions in circumferential rotation. You can rotate it here, you can rotate it back, and you can rotate it all in the, and also the vascularized pedicle. If you give a vascularized pedicle, the most vascular structure of the body, if you can retain, you can have a live skull base reconstruction. So you see here, there are various layers of the temporalis fascia. One is superficial layer of temporalis fascia. One is the deep layer of temporalis fascia. Then there is a gallial layer. And then we had described a subgallial fascia. So fascia, you see subgallial fascia, you must remember this is also a well-defined layer which can be used for reconstruction. And you can have a long vascularized flap. So there is temporalis muscle here. There is superficial and deep temporalis fascia here. There is pericranium here. And there is subgallial fascia. So you can have extended subgallial fascia, pericranial, temporalis muscle-based flap, which we described for skull-based reconstruction. And I can tell you, believe me, whether you want to believe me or not, that is upon you. But I can tell you, this is a beautiful flap. And this flap can be used for tumor surgery, following chordoma surgery of the middle cranial fossa. I have seen, some people have described the use of this flap following endoscopic surgery. They take it laterally from the nose. So this flap is a versatile flap, and it is a locally available alternative. It can be hugely rotated. I must tell you that I have never used this artificial glue or artificial sealing material, or never in my, I don't know what these things are. I have always used vascularized pedicle flaps, and this is one beautiful flap you can see for skull-based reconstruction. Now I will show you extended vascularized temporalis muscle fascia flap. Muscle fascia. So there is a extended muscle fascia flap. So you see here, this is the temporalis muscle. And you cut this muscle here, this facial layers here, and rotate them up. And then you can rotate this. You see, this becomes a long flap. And you can also use this pericranium and cut the muscle here and rotate it. If you have done glomus jugularis surgery, if you have done some mastoid surgery, if you have done huge petrosectomy, if you have done petrous apex removal, if you have communicated, you see, various cavities to the sphenoid sinus, to the clivus, and all those things, you can use this beautiful, this is just beautiful temporalis muscle fascia flap. Now you see here another case I am showing you. There is a huge, John, there is some noise coming in between.
Yeah, I got it.
Got it? Okay.
Okay.
Now you see there is a huge middle cranial fossa defect. And you see the whole brain is herniating into the middle cranial fossa. You can see the temporal brain herniating into the infratemporal fossa and into the nasal cavity. You see here? And you see there is a CSF leakage coming from the ear. There is some CSF seen. So I did this case about 25 years ago. Now you see, I am wondering, I want to ask this question to the young people in the audience, what they will like to do for such a case. I will just wait for few seconds for them to think what they will like to do in this situation. You see, you cannot do reconstruction in this situation by forcing it fat and all those things. Of course, you can do it, but you will have to do a vascularized pedicle reconstruction. Now you see here, what I did was a multi-layer facial reconstruction. This was a life-threatening condition. This young boy had come with CSF leakage and with a situation where he was having multiple episodes of meningitis and all those things. So he needed a solid reconstruction. So what is done here, you see these beautiful line drawings which I made. This is the temporalis muscle and the fascia. So I cut here, and this is a long flap. This is a vascularized flap, temporalis muscle fascia flap. Then what you can do is you can make the distal layer thick. You see, you can cut here and rotate partially this part of the fascia. So this part, the distal part, becomes thick and multi-layered. So what has been done is this distal part has been cut like this and first rotated in the middle cranial fossa base. And then this temporalis osteomyoplastic flap has been rotated and put in so there is a multi-layer vascularized pedicle reconstruction of the skull base. You see, first this one will go like this, and then this one will go, and there will be a multi-layer reconstruction of the skull base. So this is actually multi-layer reconstruction of the middle cranial fossa floor, okay? Now I will show you another case, a very big VIP patient, the son of a VIP who was a minister at that time in in the union ministry, and his son had suffered a trauma and he developed CSF leakage from the nose. And after CSF leakage, he was operated 13 times. 4 or 5 times from the nose to stop the leakage, then shunts were done, the lumboperitoneal shunt was done, and various kinds of procedure, 13 times, and a big man's son. He was, when I treated him, he had already, he was about 27, 28-year-old. And now you see the ventricle is large. You see the ventricle is huge, and it is, the whole thing is coming in the ventricle is herniating into the paranasal sinus. And also because there were multiple operations done, you see there are so many holes in the skull base. Every time somebody used to go, he used to make additional holes, and the holes were around the internal carotid artery. You see here, internal carotid artery is almost exposed around the skull base defect. And you see the multiple defects in the skull base, and the whole ventricle is coming. I want to ask the young people in the audience, I will give them few minutes. I want them to think as to what they will be doing in this situation. You see, this is a life-threatening condition, and I got phone calls from various people, and I will not like to boast this, but even from the topmost in our country, phoned me for this gentleman, saying that now do something, otherwise this gentleman is gone and finished. 27-year-old, healthy and a very intelligent young man. So I did this reconstruction. I will like to show you. So what we did is, this is one layer of reconstruction. You see, this is one huge, because he was operated so many times, there was nothing in the frontal skull. It was completely barren. All the layers had been taken, pericranial layers, for reconstruction. So I used this long facial pericranial flap from here. You see this here, and rotated it down here. Like this is one layer of reconstruction. You saw this? So this is a vascularized pedicle reconstruction. I did this operation about 25 years ago. And the other thing is, at that time, this fibrin glue had just been introduced in the market, and this guy brought for me from Singapore multiple vials of fibrin glue, At that time, it was known as TCL, and he gave it to me to use it for his son. And I kept it, but I did not use it. And I kept that TCL for several years till it disappeared from my refrigerator, because I don't know how to use this TCL business and glue business. You see here, this is a long vascularized reconstruction I did. That is one. Now you see there is another thing. One is this facial layer. And second, what I do is I split the cranium here. So I do a split cranium, and then I put one split cranial flap here and multiple layer like here, and the guy was cured and he did not need any further surgery for CSF leakage. So this is a multi-layer reconstruction of anterior cranial fossa floor. You see, though, when you have a problem of CSF leakage, your operation is like giving new life. So you have to use this pericranium and temporalis fascia and all those things for tumors. If you are doing skull-based tumors, if you are doing malignancies of the skull base, and if you are going to do all these kind of complex chordomas of the middle cranial fossa, glomus jugulare tumors, reconstruction has to be solid. You cannot, bypass reconstruction and say, yeah, I have to remove the tumor, because you have removed the tumor, but this leakage will kill the person. So you have to use it. You see how much the vascularized layers you can get. You can harvest the whole skull. You can open you can dissect subgallially, get the pericranium, get the gallia, get the facial layer, and you can get the whole skull and do the reconstruction whenever it is necessary. Other thing is, as I mentioned, I don't do decompressive craniectomies at all. At all, no decompressive craniectomies. I think this is a absolute disastrous operation neurosurgeons have devised for the poor patients who are unconscious and all those things. But 30 years ago, this article I had written 30 years ago, when I was, somebody had done, not somebody, you see, this decompressive craniectomies were a common norm. And what I started using is you preserve the skull bone in the abdomen, in the thigh, and some people, because they want to they preserve it in various kind of refrigeration. And some very intelligent people like to put some expensive titanium material and PEEK material, because that is expensive for the patient and for good for them a little bit. You can use those things. I don't want to criticize these things, but I just do not use them. So you can preserve the skull in the subgallial fascia. It is a very vascular compartment. And when the person becomes all right, you can introduce the skull back. So this is skull subgallial reconstruction of the preservation of the thing. My fascination and my passion for vascularized pedicle reconstruction has gone for the pituitary tumors. You see, pituitary tumors, now we know about Haddad flap and all those things, but 25 years ago, these flaps were not available. So what I use is reconstruction of the cellular floor using vascularized pedicle mucosal flap. You see, there is a sphenoid sinus mucosa. You can preserve this mucosa, and you can make it like, you see, I'm separating the mucosa from the sphenoid sinus, preserving this mucosa, and then putting fat and also adding this vascularized pedicle reconstruction. This flap is being used a little bit, not very commonly, but many people who do endoscopic surgery like to use this flap. So this is a vascularized pedicle mucosal flap. I also describe this flap outer layer. Sometimes, you can use the outer layer of the dura mother. Outer layer of dura I used, you see, you can read this paper. This was published in Surgical Neurology, which was then renamed as World Neurosurgery, but at that time it was Surgical Neurology. And you can split the dura and you can use it as a pedicle flap for reconstruction. Here, the mastoid bone was reconstructed using this. I'm not saying you use it always. I'm not trying to say, oh, very good, very good. But I am giving you some options and alternatives. When you think they are necessary, when you think you can use them, you should try, and you should have options available. This is not that you will split and I cannot split, oh, it cannot be split, start arguing with me, all this kind of, what argue? You don't argue. Hello? John, just see. Hello? So this is, now this is another patient. Are you with me?
Yes, sir, I'm here, sir. I'm here.
I'm showing you another beautiful thing which you have not seen. Beautiful.
Yes,
You
sir,
see,
yes,
we
sir.
know about CSF CT cystonogram, MR cystonogram. We know about introduction of dyes into the skull, and we know how to get the site of leakage. You see, this is a site of leakage. We know how to get, but there are many occasions, and you will agree that there are several occasions where the exact site of leakage cannot be deciphered. You cannot identify where the leakage is coming. And you open the skull and you come and you do not find the site of leakage, you can be in a big problem. You agree with that? This can be a big, huge problem. So,
Yes, yes, yes.
So this is another case who is a big VIP of Mumbai. And he was operated several times by endoscopy and all those things to repair the leak. And when they, the leak persisted, and then they did lumbar puncture, the whole test tube was full of pus. That kind of difficult situation he was. Then, then he landed with me somehow, and I was not able to exactly find out where exactly is the leak. And I did this 3D model. You see this 3D model? This is the first time in the world this kind of model has been made to identify the leak. And now can you see multiple holes here in the skull? Which had to be, you see, in the frontal sinus, in the region of cribriform plate, in the region of plenum sphenoidal, in the region of anticlinoid process, and there are multiple small holes all around the place. And you have to, if you have to cure him, you have to take care of all these things. So this is one new method which we have found out, a 3D model. 3D scan is all right, but model, you can hold the model in your hand and you can go in the theater with that model. This is another case. You see this patient, very big trauma, and has been repaired several times. And you see the air in the brain, and you see here the huge skull base, and then there is a craniotomy. You can see here somebody has done a craniotomy, but now he comes to me and you see the hole here in the region of ethmoid sinus, in the region of sphenoid sinus, in the region, you see the number of holes that he has got, like a absolute disaster. My feeling is, to cure this person, you need a huge, huge multi-layered vascularized pedicle reconstruction. And you must know that if you can do a good reconstruction, you can give new life to these patients. And this was my first technical paper in my lifetime in 1992, which was published in British Journal of Neurosurgery. And here what I'm doing is, you see the scalp at the time of closure, you can do this tenting scalp stitch. You stitch the pericranium with the scalp. You can stitch the pericranium with the skull. And you will be surprised. Many of the young people listening to me will be absolutely surprised that I have never sutured the scalp in 2 layers in my lifetime. You see, if you go to Cushing grave, you know what is written on Cushing grave? You don't know. Cushing grave, it is written that here lies a man who stitched the scalp in 2 layers. And when you will come to make a grave for me, you remember that you write, here lies a man who stitched scalp in 1 layer. Okay, you will remember that, right? Okay. So here are the various flaps that we have described, and I hope you will use these flaps whenever they are required. You will use them judiciously. and you will use them effectively. These are very effective way of compartmentalization of the skull. Skull is a divine cavity. Skull is a spiritual cavity. It contains our brain, the seat of emotions, the seat of thought, and seat which can completely change the whole world. So you must remember these beautiful flaps. So thank you very much, I.
Thank you, sir. Thank you, sir, for the excellent lecture, sir. Any questions for this thing? Any questions for this talk, please? I mean, we missed him yesterday, but thank you very much for coming today and the next day of Diwali and delivering this beautiful talk, sir.
Thank you, Aip. And I can only send you my best wishes and if you think my blessings, if you think they are appropriate, but because you are now already a very big man in the field, but I can send you my love and affection, and I wish that you make this Karad a beautiful center of neurosurgery. And I'm sure, without doubt and without hesitation, I can say that you will do it. The number of people who attended, of course, I could not attend because after 8 months of Corona thing, for the first time, I ventured out of Mumbai to city Pune with my family. So that was the reason I could not attend yesterday. But I know exactly, I was in touch. I know exactly what happened and how it happened. And I'm sure you must be very happy and very proud. I would like to have questions. Yes. Questions on my...
So I must say that whatever I grow into, sir, I will always remain to be your disciple, somebody as a resident who was fascinated when you achieved so many things, and that was what a lot of a generation of us.
Can I a question, sir?
I have a question also.
Hello.
Yes, please. Yes, please take ask questions.
So, what is any difference in patients with a frontotemporoparietal decompressive or a versus a patient undergoing a hinge craniotomy, hinge decompressive or a 4-quadrant decompressive, where we are replacing the bone back?
Uday, you asked this question to Aip or to somebody else because, I told you I never do decompression, craniectomy. I never do in my lifetime. I don't think it is a good operation. I don't think it should be done. But I also know that if I make these statements, many of the people who are experts in head trauma will not like it. So I was not here because I was out of town, but also deliberately because my controversial statements can become controversy. But I do not think any kind of decompression is a relevant or good operation. I want to remove this word decompression from neurosurgery. Dr. Uday, this is my...
Thank you, sir.
I have a question or comment.
Yes.
Thank you, Professor Goel, for this presentation. Actually, what those who follow Dr. Goel publications or presentation know that he likes to share philosophy, and I like this concept very much. Sharing philosophy and give us some idea. For sure, after knowing cysternostomy, if you see the example that I give in the presentation about managing blast injury, that was in 2009, and we are managing like around 40 patients in OR in emergency at the same time. So the resident there or the neurosurgeon there, we call it, they act by default. They are familiar with the decompressive craniotomy, easier for them. But for sure, I hope we will not face blast injury anymore. But at this time, yes, we have different strategies after 10 years from those incidents. I can say that we can think 10 times before doing decompressive. That's maybe a lower level of expectation from decompressive. But yes, I will think of cysternostomy cysternostomy, and let's say cysternostomy, what can did for this patient, and if possible, many modification rather than decompressive, and I will put it at the final stage. That's what we are doing now in the practice. And yes, regarding the reconstruction, for me, it's interesting, and I think not for me only, other person and colleague will think of this method of reconstruction in situ at the end of surgery. Why not? We can do such a flaps if literature proved effective, and your experience means a lot to us, sir. Thank you.
You know what? Other thing is, there are, now you will ask me that if not decompressive craniectomies, then what? You will ask me this question.
Professor, I would like this question for you.
Yeah, okay. So this is one question that I will give you my thoughts that if the person comes to me with a trauma, I will never do decompression. Okay, decompression and bone flap rejection is never in my. I have never done it. I do not recommend, and I have seen disasters and I have seen complications. And I think that this divine material, God has given this skull to protect. It is like mother. It is protecting an injured brain. It is protecting a normal brain. It is protecting an injured brain. Don't remove the mother from the baby. Brain is like a very small kid when it is injured. And if you remove the skull, you have removed the protection and you have removed the mother. Don't do it. This is not good. Now you will ask me what is to be done. One is, if you can avoid doing anything, like if you can do drug treatment, if you can give some various decongestive drugs and you observe, you see when the person is come unconscious, his brain is very seriously and severely injured. So there are many situations when you can tide over and you can try drugs, and if you cannot, drugs fail, then the cysternostomy that IPE is recommended is one option. There are other options, like you see, if there are huge frontal brain contusions and temporal lobe contusions, you can do temporal lobectomy, you can do frontal lobectomies and decompress the brain. And by the time you are decompressing the brain, you open the cisterns and also decompress the cisterns. And you will find that you have released the brain quite a bit. Rather than throwing the bone, you can remove the part which is the injured brain, you can remove. That will be my concept. Rather than entering and coming and removing the whole skull, and I have seen bilateral craniectomies and all. You see, the people who are following trauma and doing trauma work are very happy with what they are doing. But my feeling is, and I am giving you a feeling which is controversial. Like Ibe says, that cysternostomy, when he started, everybody started laughing. But now many people in the last World Federation of Neurological Surgery meeting, there was a whole session on cysternostomy. There should be a whole session on no decompression should be done. Please leave the heads of the injured people intact. Leave the mother of the baby intact. And the baby needs the head. It needs a protection. Don't just throw away the head. I know there will be many negative opinions about this, but this is my opinion. Like if there is an intracerebral hematoma or bleeding, you go and remove the hematoma. Why you have to throw the bone of the skull? Skull removal is a dangerous. All the brain which comes out of the skull and bulges, this completely finished. The person will develop, if the person recovers, he will never recover from hemiplegia. You will see these patients walking with one hand like that and the bulging head. You see, I think there should be a complete session. You think about it, there should be a complete session as to abandoning decompression. From the face of neurosurgery, you introduce this session and you concentrate. Of course, cysternostomy is one way, but there are other ways. You make a proposal in front of the World Federation or whichever federation, or I don't know about federations, but you make a proposal in front of the world of neurosurgery that use alternative options. Don't throw away the bones like that unnecessarily.
Sir, I've been talking about this for many years. I mean, decompression is really, really bad surgery, and I mean, I think we should grow out of it. And now
We should
people
grow out of. You know why we are doing? Why we are doing? You know what? We say that we do because we cannot do anything else. We at least do something. Our hands will keep on moving, and stitching will take and remove. Some hands will move. And many of the people whose other brain tumors they don't get spinal disease, they don't get anything. They are just waiting and putting their thumb on their palm and just twiddling their thumbs. They get some trauma and they do, okay, let us do this decompression. You see, unnecessarily. You don't know how, it is not a minor thing. I am telling you, it is not a minor thing to say like this in front of people who are, and you have been, you have been courageous enough to say that, and I completely admire your courage, how you could stand in front of these people of the neurosurgeons who are completely, many people in the neurosurgical world are only familiar with one operation, and that is decompressive craniectomies. To stand tall in front of these people must have been a very difficult job. And I was, first time I'm actually saying in front of an audience about this. Otherwise, I talk to you in private that don't do this nonsense of decompression. There is some trauma and person comes and you just remove the bone flap. There is some intracerebral hematoma and you just remove the bone flap. There are some people who just, there are several articles of mine you must read there. Brain edema is a natural protective maneuvering by the body. If there is a brain edema, it is a natural protection. It is not negative. You see, this tumor is primary, edema is secondary. Trauma is primary, edema is secondary, and whatever is secondary is nature, is God. Is trying to make up the huge injury that you have subjected your brain to. Brain edema is protective. You see, tumors, you will not know. During 25 years ago, there were some people for malignant brain tumor, they just used to remove the bone flap. You know why? The concept was make the space for the tumor to grow, at least the brain. This kind of idiotic concepts existed. You don't know. You see, this bone flap has been very badly bashed by the neurosurgeons. I think there has to be a concentrated effort. And I have seen young people, bone flaps have been removed and a huge depression in the skull. And when you remove the bone flap from the left side of the skull, the person stops talking for life. His weakness of the right side is such a huge. And, there are people who are recommending all these kind of foolish things. There should be a very big concentrated effort in the world of neurosurgery led by you. You make some proposal that these kind of is not good. Please, for heaven's sake, don't do this kind of foolish things. Remove the tumor if it is there. Deal with the problem of whatever is there. Some temporal lobe contusion is there. Do temporal lobectomy. Frontal lobe contusion. Do frontal lobectomy. If you understand when cystostomy can be helpful, when CSF drainage from the ventricle can be helpful. You see, this can be game changers, as you know. You see, you have to know when to do what. But one thing you should know, never to do one unnecessary thing. Just because you don't have anything else to do, you just do this thing. That is a wrong kind of attitude. I think we are having too many neurosurgeons in our country and in our world. The number of neurosurgeons should be reduced to 10%. So that these kind of foolish things can be avoided.
Yes, I completely agree with you, sir. Decompression is a criminal.
But I know you agree, but there will be many people in the audience who will not agree and who are ready to bash me and bash you. But I don't bother. Now I've gone too far in my career. You see, to get disturbed by anybody talking bad about me or saying, oh, what nonsense, or go to do whatever you have to do. You see, other thing, if you remember, if you know, I have recently said that decompression for Chiari malformation is a nonsense operation. I have said recently. There are many people in the audience putting with stones and coming, oh, what? They'll go, will do decompression. And another thing which I have recently, which you don't know, which recently my several articles in the literature, I have said that decompressive laminectomies is an absolutely nonsense operation. Decompressive laminectomy for degenerative spinal, nonsense. Then decompressive corpectomies and all those things, complete nonsense. This is my recent introduction to neurosurgery. So sometimes next time I will, we will talk on this decompression as a subject, where I will be talking about decompression of the rest of the spine, of the brain, of the skull, as a completely negative, redundant operation which should not be done. This word decompression should be removed from the textbooks of neurosurgery.
Yes, sir.
May
Yes.
I say something?
Yes, Corrado, please.
Okay. Now, the first question that I would ask to you, and how to explain to all my patients that survived after the compressive craniectomy and coming back to work, and how can I explain that they live in a nonsense way?
You can explain that despite what you did, despite shooting them in the head, they survived. Corrado.
Okay,
you know what? I will tell you. I will like to answer this question. You see, when your brain is injured,
no, please, Atul, please. I can understand, but it doesn't matter if I agree with you or not. It absolutely doesn't matter that you say that something can be bored, offended by your words. You have your opinion, you have your huge experience, and of course, your choice of management is one choice, and I completely respect your choice. Maybe the message is that we have to think, we have to understand what we are doing or not. And I cannot stand just about the talking of decompressive craniectomy as a surgery where there is only throw away the bone. The decompressive craniectomy is a complex surgery, and we need also a neurointensivist workload and a complete approach, even neurosurgical approach and neurointensivist approach. And even yesterday and today, to be honest, maybe I miss the presence of a neurointensivist to know to understand which kind of work is behind decompressed patients. I'm not defending the decompressive craniectomy at all. And nobody of decompressive work, let me use these terms, nobody defend at all. And ICP rescue and rescue ACDH are the proof that that part of neurosurgeons that work with the decompressive craniectomy are searching for the truth, are searching for the selection of patients, which patient can benefit from decompressive the craniectomy and which patient not. Of course, decompressive craniectomy at all is not the solution. So we have to search the truth. And we are search the way to manage at the best way the traumatic patient. And you know, as I showed yesterday, and as you know, of course, that the patient in a part of the world is not the same of traumatic patient for another part of the world. And this is fundamental because our experience and our consideration, even scientific consideration, then clinical consideration, could be different among the group of patients that we treat. And this is another fundamental thing that we have to keep in mind. So I'm the only thing that I'm not agree is the message so absolute about the throw away one technique against another techniques. If the techniques like the compressive craniotomy means that all the people died, I can understand we have to abandon. But I don't think so. And I don't think that all the patients the compressor die or will get worse in all parts of the world. In some part of the world, the compressive craniotomy could be not possible because the work of intensivists, the work of monitoring, the work of attention to this kind of patient is not possible. And this is the first thing that I say to IPE when we meet the first time. You're right, you are offering a solution in a part of the world where there is no way to decompress, no way to reconstruct, no way to monitor. So, and the first time that I see the cisternostomy on YouTube, I say this could be a solution in a part of the world, and this could be a solution to bettering the decompressive craniotomy. So it's just a kind of message, not the message. Professor Gold, you are a master and you have a big responsible about your words is deep words in the young neurosurgeon. So when you say something, you have to understand, and I know that you understand, when you say something, there is a young neurosurgeon that have a mind and can follow you, but unfortunately there is also some young neurosurgeon that don't have so brilliant mind and can follow just the few words that young neurosurgeons once follow. So when you suggest something, please, I think that we have also to suggest how to study and how to understand that suggestion, not just follow the suggestion.
So Corrado, you have put it in a very beautiful way, beautiful. You have really put, you have really put the whole thing into right perspective. I know that many people in the world are doing decompressive craniectomies, and many people really think it is a good operation. Many people, many people think it is a good operation, it is a useful operation, and it should be done and all those things. And many people have got huge experience in these things. And it should be, but it is time, Corrado, that we have to really sit down and try to, and many studies have been done, many double-blind studies have been done, but you see the trauma is such a huge thing, and the trauma is different in every patient, different kind of injuries. They are not, two patients will never have the same kind of injury. So when to do what, when to do something which is not necessary, when we can avoid anything. We see, as you said, intensive care unit, intensive care management is so important, and it has gone such a distance. We should use the services of intensive monitoring, intensive care, rather than just taking the patient and removing the thing if can be avoided, you see. And there are ways to avoid these things. I know that what these statements I have never made in my lifetime, some of these statements, but I made them today. I had this pent up feeling in me that this decompression is not such a, it is overused, and it is much more used than it is necessary in the world. And in many situations it can be avoided. And in most situations it can be avoided. This is my feeling. And to the extent that now my neurosurgical career is more than 40 years, nearing 40 years. For the last 35 years of my career, I have not resorted to any kind of decompressive craniectomy. And I do not talk from, high pedestal or from ego or pride and all those things. I never like to talk particularly to the young people. But if I have my opinion, and I have my I have experienced many head trauma patients done by various people all over the place by decompression, and then they come to me through various channels, and then I see the disaster. So what we have to do is we have to really think and have a forum of discussion of people who are for it, people who are saying that there are alternative options can be used, and people who are against, and let's discuss it headlong. And when you see I give my points, you argue out, no, I don't agree, Atul, on this point I don't agree, maybe here it is okay but here it is not okay. And we have one-to-one discussion and discussion in a forum where this issue, and you also know that this issue of decompressive craniectomy is being discussed on various forums in the world. Recently, it was being discussed in the ethics committee of the World Federation of Neurological Surgery. This was the subject being discussed. So it is not that it is not discussed. And it is not that everybody agrees that this thing can be done and should be done in this kind of patients. So I have a feeling that we should have arguments, and we should have strong arguments with people who have enough experience. And let's sort out this issue of but I have given you my opinion in no uncertain terms. In no uncertain terms, I have given you my opinion. I am not saying that I am the only person in the world who is right and everybody else is wrong. I am not trying to say that. I'm not trying to say that. But I am also trying to say that I am not talking from, you see, I am working in one of the biggest centers of neurosurgery in the world, one of the busiest centers. And from that experience, I am saying whether somebody has to take, and of course my decompressive craniectomy thing I have never published, but I have published on Chiari malformation. Have you read, Corrado, my work on Chiari malformation?
On Chiari malformation, I read your work, I follow your meeting, and and I'm friend of Massimiliano Visocchi, so you know how we follow you, and of course, but I suppose that maybe it could be more useful the same approach that you have with Chiari. You could have also for traumatic patient to understand.
I've never published on that, never.
So when I decide do not decompress the Chiari, when I decide to block the articulation, I decide because I understand your mood, I understand your choice, I study your choice. And so the same approach should be done for decompressive craniectomy. When you say don't do this at work, you have a big responsibility. And when you say this, you have to say, not because I see that doesn't work. You should at least publish, or you should at least to explain why not. We are in the same boat because all me and Virendra Signa, Professor Signa, that I'm seeing that is listening us. We are searching.
I know. When he's listening, you know what, Corrado? Virendra is listening, but he is also ready with a gun pointed at me. Virendra, I want your
Yes, yes. Last time we had a webinar on decompressive craniotomy only. So finally, we decided multi-centric study results that at 6 months or 1 year, we keep the patient in very vegetative state. So we do some changes in guidelines that can make the patient much better. So I think Corrado was there also in this webinar. So he was one of the speakers. So we do some changes rather than very strongly we say it is useless. So we do some changes, then we should speak. Right?
Can I say a few words?
Barish, good morning.
Yeah, good morning. Professor Goel, I respect your experience and your thought as someone who is a leader in this field. And I agree with IF Dr. Goel that I don't want to do a decompressive craniectomy. And I've seen, removal of, swollen brain tissue, stroke tissue, along with cysternal decompression is enough for these patients. Even though I'm convinced that is it, you have to understand that I practice in the Western world, where evidence is the biggest order of science. And as Corrado pointed out, neurointensivists, neurologists are big players in taking care of trauma patients in the intensive care units. So I think it is important to publish results of not doing decompression and doing other things, and what are the outcomes, and what are the complications, and how these patients do in large scale from all over the world in big trauma centers. And your experience, like I'm sure you clearly said that you've not done decompression for 35 years and you've managed so many trauma patients. Maybe if you can publish your results. I'm just trying to figure out, I'm a believer. I believe that we should not do decompression. I believe that we should not do, but how are we going to make the world believe this? How are we going to, when I do that part of the operation, when I do the right thing for my patient, I just want to walk out of the OR and take care of a next patient rather than argue with 10 people that I did the right thing or did not do the right thing.
I agree with you. I agree with you. You rather do it rather than getting into discussion. And you see, on the other hand, in a hospital where sometimes, the intensivist will say, okay, do it. And if you do not do it, and if you say, I will not do it, the patient will be sent to somebody else. That, because there is so much faith in this operation. So this is a matter for discussion, and I hope that, this question, you think about it.
I think, we discussed yesterday, I presented that maybe we should do a randomized controlled trial. And I've been thinking about the discussions we had and, Dr. Goyal's talk, and maybe we should not have the randomized control trial. But there should be some kind of evidence we need to publish, prospective, adjudicated, outcome-based. We did not do this that we do every day, or everyone, what people recommend we do for this, and still the patients are doing okay. And that needs to be published prospectively, multi-center, as a good science. And that should be enough. If we do that, I don't think people are going to talk against us. And I believe in it because I want to do that for my patients. Every time I do not do a decompression, I put a cystostomy drain, I come out, there is hell broke loose everywhere. Right? And we live in a very litigious environment. And it is not good if there is no data to support your actions.
Yeah, you're right, Sabarish. We have Ikran and we have so many more discussions. From 13 years, it's the 14th year that I'm doing it, and you will not believe how the outlook has changed for the whole world. So that is an advancement. I remember doing it in the face of real criticism when I had to fight against everybody. Now we have a lot of people who has seen this and who believes in this. Now I'd ask Prakash to present. Prakash is one of our previous team. When I was in Biratnagar, Prakash was our consultant there. Prakash and Pramod, both of them has a series of cystonostomies. They are very young neurosurgeons. Prakash, I believe, has just finished 2 years post MCH. And he's got a series of cystonostomies and they're still doing cystonostomies. So I'd like Prakash to go ahead and present. And after that, Andrea, who's been with us from the Italian group itself, I will ask Andrea to present. And after both these brief talks, I would like Professor Sinha to go about his talk. And then we have Goi. So we have 1 hour only before the spine seminar starts. So now we'll have to keep our time.
Good evening, everyone. Thank you, sir, for the wonderful opportunity. It's very hard to start the presentation after the talk after eminent peoples like Professor Atul Goyal. Is my screen shared, sir?
Yeah, perfect, perfect.
So there is no conflict of interest. So this is outline of my today's talk. So this is the place I would like to remind where I work in. This is the eastern part of the Nepal. So this is the exactly Nagar where I work in. This is the hospital where I work in. This is the medical college, Nobel Medical College, located in the Nagar. It is 25 bedded neurosurgery dedicated ICU with total of 82 bedded neurosurgery bed with intraoperative MI, OARM, navigation system, neuronavigation, sonopet, Pentro, this and in-house rehabilitation center. And this is my working team. This is my working place. So coming to the introduction, I think I need not to talk much about the introductory part. And though cystinostomy is defined as opening the basal system at atmospheric pressure, which helps to reduce the ICP in severe head injury. So this is the intraoperative picture of putting the cystinostomy drain, and this is the post-operative picture where we do the scan. So if anyone interested and new guys can go through this beautiful paper about the anatomy and physiology of cystinostomy, where it is beautifully written about all the steps and pathophysiological changes that occurs in the cystinostomy. So why I follow the cystinostomy is that among the 18 recommendations in the Brain Trauma Foundation, one of the recommendation, though it is of level 3 recommendation, the CSF drainage, fluid drainage is one of the options. It says that instead of drawing the CSF intermittently, it is more effective than draining of CSF by continuous method is effective than draining it by intermittent use. So if we have opened the skulls and if we can do the arachnoid dissection and go into the basal system, why not to do the continuous draining of CSF? So when I do it, so all the cases with severe, moderate to severe head injuries and CT image showing intradural pathology with significant midline shift will be carried on. So when I don't do it, when the GCS, especially motor, is less than 3 and suspected sinus injury, we usually don't do cystinostomy. So how do I do it? Like keep the patient in the 3-pin head holder with standard terminal craniotomy most of the time, and sagittal unlocking, which helps to unlock this frontal and the temporal part of and make the roomy space. And usually we do the extradural cranioidectomy, which is not required in all the cases in which we want to do cystinostomy. I want to highlight this topic. This point is that if you want to do the cystinostomy, it is not required in all the cases to go for extradural the SCP drilling or SCP removal. And we do durotomy, basal cysternal opening and placement of drain and watertight dural closure. Is Goel sir always says that dura is the mother. So you always respect and make the tight dural closure and bone flap replacement and the skin flap closure. So I take this picture from Fukuda, in which this is the picture of SCP, where we go from the lesser wing of the sphenoid wing, this sphenoid, and then detach the dura, but we don't go towards the lateral lateral wall of the cavernous sinus in all the cases, because chances of injury to thorn knob is very high, and it is not required in all the cases that we need to do SCP removal. So in ICU after post-cystinostomy, we do this general management, like patient will be sedated, cysternal drain, and at the height of the level of tragus for about 5 days, and volume of 150 to 300 ml is drained, and hyperosmolar therapy SOS, not as a regular protocol in our, and the systolic blood pressure is maintained, normotheremia, normoventilation. Yes, in our center, we regularly use these antiplepic drugs. And this is the picture which we place the cysternal drain. It is coming from this lady's head at the level of tragus. So what do I expect of the cystinostomy? Obviously, I expect of tremendous brain relaxation like this shown in the this picture. This is the intraoperative picture showing a malignant brain edema, and this is the post-cystinostomy. You see the brain is lax and pulsatile. and this is the cisternal drain in situ. So I expect possible dural closure, possible bone flap replacement, and avoids second surgery like cranioplasty. And there is a patient and patient party satisfaction that this patient doesn't need second surgery. Yes, I of course expect some intracranial hypotension which can be managed. So here I would like to show some representative cases. So this is lady, 67 years lady, right-handed, female with road traffic accident with motor of 4. And if you see her, this pupil on the right side, it is 4 mm, 5 mm fixed dilated. Sluggish reactive, sorry. So this is a intraoperative picture after this craniotomy. And you see after this craniotomy, the cisternal drain has been kept, and this dura has been watertight, and cisternal drain is in situ, and bone flap has been replaced. So this is the post-operative image in which the bone flap has been kept back with cisternal drain in situ and this bone flap. So here I would like to show the intraoperative picture of the same lady. So this is the after craniotomy. This is, I would like to orient you all. This is the frontal part and this is the temporal part. Here I have drilled the posterior orbital part, and then this lesser wing of spinal is about to go on. So I would like to play this video. I would like to forward a little bit, and after this I use this SCP punch and then start removing the bone from here to do the removal of this SCP and to do the sagittal unlocking. After this, in second stage, what I do is I try to open the dura. Durotomy will be done. After this dural opening, I hinge the dura anteriorly. Like this. Sorry, this is unedited video, so video is a bit long. I am trying to forward it. So after this, without removing this clots, subdural hematoma, I go for opening the basal cistern, and I remove this clot only after the cisternostomy. So I would like to show you the third video. Sorry. Yes, during this I have reached to the basal cistern. This is the basilar artery and its perforators, where I have beautifully reached the basal cistern. Once we see this basilar artery, then our job is done. So I'm putting the drain. This is cisternal drain tube. I'm going into to place it into the preponderant cistern here. So you see the brain has relaxed a lot after placement of cisternal drain. And temporarily, intraoperatively, I put the cisternal drain in this way. and fix it to the skin area here for short time. And then I start opening other part of dura to evacuate the this hematoma. So finally I remove the hematoma. So with that, this is the after the procedure, this is the post-operative image which is seen here. So this is another case, such representative cases who deteriorated after 48 hours of admission from initial GCS of M6 to M4 with dilated pupil on the ipsilateral side. So this is another case, 36 years male, road traffic accident with M4 and pupils 5 mm non-reactive. So this is the intraoperative picture, and here I would like to show the another video of the same patient. Going to the basal cistern, and this is the optic nerve on that side. This is carotid artery. This is PCP, and here we see this is third nerve, and this is the basilar artery. And this has been done in high magnification. And one thing is that we see lots of blood in the basal cistern. So continuous irrigation, and here is very mandatory during the cisternostomy. So one of the assistants should be doing the continuous irrigation here, and this is after doing the cisternostomy. So it was done recently in 2027. So finally, so in this case, after cisternostomy, I have kept the bone flap back. This is the bone flap placement, and cisternal drain is in situ. And this patient on follow-up, he was walking in this way. आओ इधर आओ, आगे आओ, आगे आओ, हमको देखो, आगे देखो, आँख खोलो आँख, हाँ ठीक है, आधा ऐसे करो, हाँ, आओ आगे आओ, अपने से आओ, तुम उधर छोड़ो ना, इसको छोड़ दो, बस हो गया. So this is another case. This is another case with the right-sided injury. This is the intraoperative picture. You see the ball's brain, and this is after this removal of clot. In this, my assistant lost this cisternal drain immediately after opening the brain. So this is young patient with GCS of E2, V2, and M5 with a sluggish reactive pupil on the left side. This is the intraoperative picture. This is the intraoperative cisternal drain placement. You see, I have again put the bone flap back. So this is another 55 years gentleman with fall injury and with 4 mm dilated pupil with non-reactive. And you see, this is the picture seen intraoperatively, the malignant brain edema. And this is the intraoperative picture. You see like jellyfish-like appearance of basilar artery and its branches. And this is the intraoperative picture on the go. And this is post-cisternostomy. You see how the brain is laxed. So cisternostomy, what I believe is one of the newer modality in the treatment of head injury. DSC is not always the ultimate. So because this cisternostomy addresses the brain edema, halting the progression of CSF cyst edema, and extradural SCP removal is not required in all the cases, because many a time what youngster think is that cystonostomy is difficult because we have to do the ACP drilling. It is not at all required in all the surgery. In some cases, it is must. So coming to the conclusion, cystonostomy is a new horizon in the management of head injury. It is safe in the hand of skull-based surgeon. However, the skull-based hands-on training is must for in the initial phase. And the large multicentric studies would be better. And the principle of equipoise imparts universal recommendation. And in our center, we have designed a study regarding the cystonostomy, and its results is expected to come in 2 years, because I have kept the follow-up for 2 years. Because of some technical problem, we are lacking to conduct this study here. I think it will start soon. So with this, I would like to wish happy Vijayadashami in this Tihar and this Diwali and Chhath. Thank you very much.
Thank you very much, Prakash. Excellent talk. And I would like Andrea to present his experience right now. Andrea, are you there?
Hold on. Let me get him in. I guess he's got bumped off.
Here I am.
Oh, okay.
Hello, everyone. Okay, so I'll share my screen. Okay. Can you see my screen?
Yes, yes.
Okay. Minute. So, hello everyone, and I will try to be brief, and I apologize in advance since my connection seems to be a bit unstable these days. So if anything, please stop me and I'll start over. And so when I first learned about cystonostomy, I started to read and watch videos to answer these basic questions. And when I looked for what is this cystonostomy, I quickly realized it was no different from the procedure I had seen many times in aneurysm surgery. And of course, after that, other questions came up. So does it work with trauma as well? What is brain shift edema? And how do you manage such a tight brain? And so it was a mess for me. And above all, one final question arose and was, would I be able to do it? So I started on a theoretical approach at first, trying to figure out what is the mechanism behind cystonostomy. And I ended up digging out a lot of papers about the glymphatic system and how CSF work. And these papers are showing how CSF might actually work as an interstitial fluid, and with the turnover occurring along the capillary bed in the whole brain through the spaces of the glymphatic system, which are the Virchow-Robbins spaces. And so we are talking, of course, about the theory. There's a long path ahead to see if these assumptions are correct, but these concepts could change how we see and how we interpret many conditions such as traumatic brain injury, neurodegenerative diseases, and hydrocephalus. I am not talking in the details about this glymphatic system. We have talked about this other times, and it's not the purpose of my presentation, but just to show for young neurosurgeon and people who are approaching to the cystonostomy, what is the theory, what is the mechanism behind behind what actually we saw, why the brain becomes so lax, and this might be one of the explanation. And what I learned about this is that one must research extensively and don't believe in something just because it's always been like this. This is something that it's always repeated in neurosurgery and in the department, but usually always is actually a very limited period. And for me, this is very important because we tend to consider some things as they are carved in stone, but in reality, nothing is. And in science, we move on with revolution, and this could be one revolution that will happen very soon. And in the near future, we may look at some conditions in a new way, and hydrocephalus is the clearest example. So keep in mind and study the CSF dynamics and the new theory that is being tested. So then I moved to a pathology perspective, and I started applying this concept in traumatic brain injury. And of course, I hit my head against the complexity and the variety of traumatic brain injury. I will specify that I will not talk about the indication and timing of surgical intervention because there's no consensus about this, and we have seen many discussion and many people talking about this, but actually there are no clear indications. So the more I studied about trauma and the more cases I discussed with my colleagues, I discussed with Dr. Cherian, I discussed with Dr. Iacarino, and the more I thought that our everyday approach is not enough. For example, I started to see the importance of distinguishing between simple acute subdural hematoma and complex ones. As you can see, this is an old classification, and actually it is not used very often in the recent literature, but look at the difference in the mortality rate. This may reflect the difference in the setting of secondary injuries, such as the delayed ischemia and the edema. And of course, there is an ongoing trial about ICP control with primary decompressive craniectomy that may help to clarify some issues, as Dr. Iacarino said before. And cystonostomy actually is exactly about that. It's about aggressively treating the secondary injury of traumatic brain injury to avoid and control as much as possible the ICP, especially in the first few hours and days after the traumatic event. That is why that is one of the reasons that the drainage is placed and kept for the first 72 hours. And these are I wanted to show you briefly two cases. As you can see, this is a subdural hematoma, and the GCS was 4, and it was performed by a colleague of mine, Antonio Romano. And you see, the bone flap actually was removed. The drainage was placed. It's not seen here, I think, but it was performed as cystonostomy. But the neurological outcome was very poor, despite good postoperative CT scan. And this is apparently quite a similar case. You see the compressed cisterns and the acute subdural hematoma. The GCS, of course, was higher, and this patient had a full recovery by the time of the discharge after performing cystonostomy. So these cases are apparently similar on CT scan, but there are many cases that can present with similar CT scan, but develop in completely different ways. Of course, in the first case, the secondary injury was already developing, and you can tell that by the poor GCS of the patient. And in this other case, the timing was probably more correct, and the secondary injury was avoided by the surgery. So in the end, studying and confronting with others led me to really appreciate the beauty of trauma. And now I try to analyze deeply every case, to notice the slight differences that may guide me to the most appropriate behavior. And I am aware that we still know too little about TBI, but we're an age that promotes cooperation. And of course, we are here sharing information and talking from all over the world. So I think it's time that our most expert people, some of them are here speaking with us, and they have to lead the way to cooperate in the future trials. So last but not the least, the surgical technique perspective. I will try to explain the most basic things to do to perform a sternostomy comfortably, even if you are a young neurosurgeon. Some things may be obvious to the experts, but I think it's useful for young people. And actually, it's good that Dr. Prakash explains some of the So first, from patient positioning, to the floor or very turned, and actually at the 30 degrees. Why is that? Because of this. Because this is the correct CA, and you can open the system comfortably. And this is what you see if you turn your head too much. You will have a vision of a better vision of the MCA and the Sylvian fissure, but you will lose your perspective, your correct perspective on. This is one thing to really keep in mind. Then the muzzle in one layer, and actually what I learned commonly performed and I had to learn this because, of course, you need to have to expose the sphenoid wing and to drill very basal to the systems. The bone drilling usually is less extensive in the decompressive craniectomy, while in the sphenoid wing, sometimes you have to also is not always required. The dural opening, somebody of the dura is to can you hear me?
Yes, now.
I think if you close your video,
the net will become more useful.
Okay. I'm sorry, but the connection sometimes just wait a minute. Okay. Can you hear me now?
Yes, we can hear you.
Okay. So I was saying the small durotomy is to avoid the excessive brain swelling that prevent you to access the basal system. So you perform a small durotomy to just above the basal system. You open them, and then the brain becomes more relaxed, and then you can do a more wide urotomy and evacuate the hematoma. Microscopy, of course, is not required for decompressive craniectomy, and it's necessary for cystonostomy. And of course, you have to know the anatomy. So very, very briefly, I can show you one of the first cystonostomy that I performed. And this is the frontal lobe. And as you can see, I put a patty, and then slowly with suction and irrigation, I go to the basal systems. One of the things that I found more useful is to go a little bit on the frontal lobe and to see the optic nerve to be able to actually understand where I am, and then following the optic nerve, of course, I can slowly release the CSF and gain some space, and then open the Lillekvist membrane. I will. So as you can see, this is the optic nerve. This is the ICA, and here I will open the Lillekvist membrane to see the basilar artery here in the deep. And then I just place the drainage. So cystonostomy can be done even by young neurosurgeons, but some things are required. Of course, the knowledge of the surgical anatomy, the correct approach. So make things as easy as possible. For me, I'm not an expert. I'm a young neurosurgeon, so I want to make things as easy as possible for me. And the head rotation, the position, and everything must be perfect. One must be prepared to handle complication. For example, in some cases, I prepare as I have to do a decompressive craniectomy just in case. And if possible, of course, start with easier case. And one thing that is very, very mandatory in the beginning is to have someone with expertise to teach you properly and assist you. And of course, I spent some time with Dr. Cherian. I had done some cystonostomy with Dr. Romano here in Italy, and they taught me what to do, how to do, and they supervised me. And of course, one thing is think before you act and take your time. And this is, of course, for every neurosurgery, but in trauma cases, I think it's very, very useful to actually take your time, take a deep breath, and then do. Always think before you use your hands. That is very, very useful. And thank you. I hope I was clear, and especially for the young people. And it was great to be able to talk here with you.
Thank you very much, Andrea. That's Prakash and yours perspective on young neurosurgeons doing cystonostomy would demystify this procedure for the younger neurosurgeons as well, to start and then slowly replace decompressive with microneurosurgery. Corrado was talking about there are places where you may not be able to do multimodal monitoring and all those things to make sure everything is all right till you do a decompressive. You must understand that the 5/6 of the world fall into that. The majority of the world is where we cannot afford to wait and watch and do multimodality monitoring and then throw out a bone piece and then use a $1,000 plate, titanium plate to replace and have a patient in doldrums. So this is something that we cannot afford. It's 5/6 of the world. In fact, if you put India and China together, that is 1/3 of the world's population. You add Africa, you add Central Asia, rest of Asia, you add the South America to it, it's more than 5/6. So this part of the world is really LMI, the low and middle income countries. And the situation in Europe and United States, not all United States, but parts of United States and Europe and maybe some countries like Japan. Other than that, everywhere it is the same situation where we cannot really afford to go ahead and keep on with a 100-year-old neurosurgical technique with the advancements in other parts like conservative neurosurgery, like multimodality monitoring. I'm not saying that's bad, but at the end of the day, if you are doing that and then not planning for a cystonostomy, cystonostomy is it's a surgery which has to be done much before decompressive. This is something that Corrado has said, and I completely agree with it. And we cannot keep on waiting with multimodality monitoring for one patient. And the trauma load in these countries are very high. And we cannot keep on waiting till something, till you cannot manage, and then suddenly the intensivist says, okay, let's take up, and then the patient is already cooked and we go in and do a surgery, which in my perspective is not really useful at that point of time. And in general, it's a 100-year-old surgery with no microneurosurgery at all. So this is my perspective. So I am very glad that the young surgeons.
If I may add something, actually, I think it's with what you were discussing before about convincing the intensivists of what you have done in the neurosurgery OT and what actually the guidelines are telling you to do. I find this. I found myself in this situation a few times, and it's very unpleasant. So it is necessary to actually publish things about the validity of cystonostomy, because you need to avoid the discussion with the intensivists. You need them to know that you did something that should be useful to the patient, and you have to have also a legal I don't know how to say allowance to do this, because if you do this and things go wrong, and then someone may tell you, why did you do this technique? This is not approved. This is not something that is approved by the guidelines. So this is something that in many places in the world is not a problem. In my country, for example, it is. So at least for these reasons, I think it's necessary to have strong evidence, to gather.
Yeah, you're absolutely right.
May I say something?
Yes, please.
First of all, there is no question of legal issues, because the cystonostomy is a normal technique, is a technique that we can use in skull-based surgery, in vascular surgery. So we are not doing anything of illegal. If we perform a cystonostomy during brain trauma surgery is not illegal. We can do it. And of course, when we show that we do a cisternostomy in Italy, because it's possible to do cisternostomy in Italy. Another thing to add is about, it's enough to compare the two presentations with Prashad and Gerosa, and it's clear that we need some more scientific issue, because Prashad said, sorry for the name, for my pronunciation, Prashad said that there is no indication for people with GCS below 5. And Andrea showed us people operated with GCS below 5. So when we talk about scientific, and I'm sorry that I say, call me neuroscientist, but unfortunately, we have to do neuroscientist. We have to explain in more clear way to the young neurosurgeon, to the people that want to do cisternostomy, who and when to do cisternostomy. How to do cisternostomy, it's your rule, and you are very effective in how to do, and you explain, and you put to able to do cisternostomy in Africa, in Asia, and this is your merit. You are great in your activity of educational surgeon. Now that we understand that it works, that it could be possible to do, we have to understand where and who and when, so all the selection of the patient. And last comment, please, is about your opinion on the cranioplasty. Once again, please, who operate with cranioplastic do not operate just for heterologous cranioplastic. You know, in the consensus conference of cranioplastic of ICRAN, we define that bone is the gold standard. So when we are talk about cranioplastic, we are talking about autologous cranioplastic. And when you have no possibility to use the free and cheap autologous cranioplastic, you can use the other heterologous materials, not only titanium, that, as you know, in one part of Europe is not used. Maybe in one part of Europe they prefer hydroxyapatite, or they prefer PEEK, or maybe in Germany and UK they use more titanium. So you know, we are friends and we work together. And now you have a responsibility from your words. When you talk about something, you know that there is a lot of people that will follow you. So it's better to choose the right words when we talk in a webinar. When we talk in front of a beer, we can talk in another way. When we have to talk in a webinar, and we have 72 people that follow in a webinar, about 20 people about YouTube, we have a responsibility to be more clear. So it's fantastic that Andrea show us how a young neurosurgeon can learn coming to your center how to do cisternostomy. And you know, for example, some cases of radage will not underwent into decompressive craniectomy. So we are far away to explain how to compare decompressive craniectomy and cisternostomy, showing this kind of patient. Showing this kind of patient is just to explain how it's possible to perform cisternostomy. But these patients are not useful to explain that cisternostomy is better than decompressive craniectomy. It's not our goal, it's not our mission. Decompressive craniectomy is a technique, cisternostomy is another technique.
Can I have a comment?
Yes.
Okay. Actually, first, thank you, Andrea, for the nice presentation. It's a peaceful way to present the cisternostomy. I like it. And one comment on just on the presentation that you said at the end that try to choose an easy case to start with. I will add sometimes the difficult case. It's the first cases for cysternostomy when you have very angry brain, let's say, as the professors described during the discussion, that yes, especially when you are doing microsurgery at the morning, and in our case we are doing vascular surgery a lot, so at night when there is a trauma, okay, it's easy, just traction to the frontal lobe, go to the cistern, and let's see if it's helpful or not. I mean, this is part of the armamentarium that we are using without exclusion of decompressive, because at the end, if the brain is not good enough, yes, I will be obligated to use the decompressive craniectomy. That's all, and I think this discussion is really helpful because sometimes it's different according to the area you are practicing in. In some areas, like we are in the Middle East and I'm practicing in Iraq, the surgeon experience at the level of evidence, it's close to the RCTs. But in more developed centers, yes, it's either proved by RCT or you should not do it, or you will have a lot of questions about your practice. It's really understandable, and thank you for all for this discussion.
Thank you very much. And yes, actually, you're very correct. And about the bad cases that are the first ones that you experiment on, actually. And of course, I have done that too. But at first, I have been to Dr. Cherian's and I learned the basics. And then when I was comfortable enough, I tried to do them in Italy, of course, under guidance. I work with Dr. Iaccarino, I work with Dr. Romano, and they are able to do that, and they help me, of course. And but it's true actually. It's better to select easier case, but in most cases, the worst ones are the one you have to actually to do that. And yes, we don't have I think a lot of traumas. Then we have very few traumas than other countries. So and usually from motor vehicle accidents. So it, of course, my experience is very different from yours, I expect. But you know, these discussions are very useful because my very little experience is maybe useful for someone else that wants to try, and I hope I did that.
Okay, we will invite Nilesh. Who is next? Nilesh, this is a beautiful discussion going on. So we will invite Professor V.D. Sinha.
V.D. Sinha, yes, sir.
Professor Goi is also here, waiting for his presentation.
Mm-hmm.
Should we start?
Yes, please.
Yes, sir.
So first, I want to thanks IP for hosting this excellent webinar and meeting. And my presentation is prognostic factor in craniocerebral penetrating injuries. We all understand that penetrating injuries of brain are very common in warfare, especially the gunshot penetrating injuries. As we see nowadays also, they are very common in warfare and especially developed countries. While low velocity penetrating injury, they are more common in developing and underdeveloping countries like here. In our state, we have a rural areas. So interpersonal assault by bamboo stick or battle axe is very common. The penetrating injury with the weapon impacted presented to hospital or to department is very unusual. So now penetrating injuries are very much, they're increasing in war practice and in civil, so it needs a consent to all neurosurgeons. So they are the various objects which can penetrate the skull, or case reports are there. Before I go for the prognostic factors of penetrating injury, just I want to talk about the dynamics of the penetrating injury so we understand better. So penetrating injuries can be low velocity penetrating injury and high velocity penetrating injury, where the velocity is a critical factor. Low velocity penetrating injury, where speed is 2,500 feet per second, and that disruption and laceration of tissue causing. The high velocity penetrating injury, they can be supersonic waves, velocity is more than 300 meter per second, and in subsonic it is less than 300 meter per second. So degree of tissue injury is proportional to quantity of energy delivered, and that is related to velocity. So in a low velocity, there is absence of significant impact forces, so recovery is very good. While in high velocity, there is a cavitation and shock waves are there that cause a lot of damage to the surrounding structures, and outcome is usually poor. If we see the pathophysiology, any penetrating object cause two changes. Either there is a primary impact or there is a secondary impact. The primary impact create three waves. Primary wave, these produce direct crush injury by a projectile resulting in the permanent cylindrical cavity. While secondary injury causes the radial expansion and then contraction around the permanent cavity that cause the temporary cavity, and while it is contracting, there can be influx of the material from the wound and cause the infection sources. In tertiary waves, they are the sonic waves. They are very high speed. Their intensity is very high, maybe more than 100 atmospheric pressure. But their brevity is only for very short time, maybe 2 microseconds. So their effect is less. And overall, this primary impact is very, very important for causing cerebrovascular injuries. So this is just a diagrammatic presentation. This is the permanent cavity here, and because of expansion, then there is a contraction causing this temporary cavity and damage to the brain tissues. As far as secondary impact, there is a raised ICP which causes a lot of problem, and edema starts within 6 hours and persists for 48 hours. Cardiopulmonary changes because of the rostrocaudal displacement of the brain tissue because of the pressure gradient difference at the foramen magnum cause herniation at the tonsillar herniation or herniation at the foramen magnum. So this is just a small video showing low velocity. There is a absence of impact, substance force, so causing not much injuries. In high velocity or bullet injury, they can be high velocity bullet wounds or low velocity bullet wounds. In high velocity bullet wounds, there is a very high speeding. They goes and cause lot of vibration and waves are formed, and there is sudden rostrocaudal herniation and cause death. While in low velocity, there is a hemorrhage, edema. It is gradual, so prognosis is better than high velocity injuries. In sorry. So this is the just a video of showing how this causing changes. There is a permanent cavity, hemorrhage, and edema, and they recollate to and move to the other side. Other thing is coagulopathies. Coagulopathies are there, and which cause their systemic changes, and at the local level at brain there is a release of thromboplastine causing the bleeding there, and the platelet numbers also decreases, and aggressivity also decreases. That causes the coagulation changes. So in a study, it was found that in 71% of survivors and in 94% of non-survivors, there was some form of coagulopathy in all the patients. Now we come to the prognostic factor. Prognostic factor can be general and they can be very specific prognostic factor. Specific prognostic factor may be weapon related and radiological factor. So general prognostic factor are age. We know advanced age associated with poor prognosis because they have a lot of comorbidities as well. And GCS, less GCS, 3 to 5, poor prognosis, usually have a good prognosis if GCS is more than 10. Hypotension, admission, dilated fixed pupil, coagulopathies, I already told you, high ICP, and major vascular injury in form of the injury of the major vessel or pseudoaneurysm, they have a usually poor prognosis. Multilobar or eloquent area involvement, like here, there is a multilobar involvement. So they have poor GCS as presentation and poor prognostic prognosis. Associated multiple injury, patient usually fall where there is injury, he falls. So he can have a associated spinal injury. So that is again a poor prognostic factor. Suicidal attempt because of the closed end injury, they have a poor prognosis. Now sometime there is a retained this body, we don't operate with this, it passes through the sinuses, there is a dural tear. So all these factors may contribute to the infection formation, like here is called infection. So it definitely showing toward the poor prognostic factor. Other general prognostic factors are seizure. Seizures in 50% of the injury, seizures are there. But multicentric study has shown that in long term, we don't need to give anti-epileptic, but the patient can have seizure. But in our routine practice, we always give anti-epileptic to all the patients. Delay in effective resuscitation, because early resuscitation definitely improve the outcome. Children have better prognostic factor than adult. Then any patient who has a wound less than 2 centimeter or the no exit wound, means the speed of penetrating object was less. So they have definitely better prognostic outcome.
Professor Sinha?
Yes.
Professor Sinha, I request you to give some time to Professor Goyi also, because
I'm going fast. So now type of ballistic injuries, these are the, so ballistic is a very important, especially wound ballistic, great area rotation along the leg axis, which cause fragmentation and deformation. And then as I told, velocity is the important factor, but with velocity, deformation and fragmentation is very, very important. Trajectory passing through the eloquent area, definitely a poor prognostic factor. Strike as 90 degree had maximum injury. Tangential wound or gutter wound, they don't penetrate in the skull, but they can cause hematoma, superficial brain injury, and poor prognosis, but they usually have a good prognosis. Unexploded missiles definitely have a, we should remove because they can cause toxicity and delayed detonation. Migratory projectile, they can go from one ventricle to other ventricle if they are in ventricle, or they can go to in the substance, they can cause because of weight hematoma, necrosis, and migration infection, have a poor prognosis. So this is an example of this pellet here, migrated to other ventricle, cause hydrocephalus or poor prognosis. Weapon impacted or not? If weapon is impacted at the site of scene, these definitely have a poor prognosis, because usually they are removed in zigzag fashion. So it should not be removed at the site. Now, radiological factor, multiple injuries, ventricular hemorrhage, compressed cisterns, ICH large, and they're all toward the poor prognosis. Then size, shape, and depth of penetration is important. Then we know the vascular complications are there in 30% of cases with 17% mortality. Especially it is more in children if the injury is toward the transorbital route. So I want to share few of my patients. This is a patient assaulted by a battle axe. See, this is a long handle, and we couldn't do the CT scan. This is the X-ray showing all metal part inside. This is we are removing, holding this handle by the arm, and this is 1 year after the surgery. Patient has minimal weakness on the hand and foot, and patient improved. Now he is married, son, father of one son. This is assaulted by X. It is superficial, low velocity injury, so outcome was good. This is another patient showing injury by the assaulted by the sickle, and patient has a good prognosis because it was only superficial penetrating injury. Now, self-inflicted injuries are very common, especially in the psychiatric patients. So this is the patient hammered to attempt the suicide, and this was just created the suprasagittal injury, and we could manage it by just putting a gel foam and pressure, and patient improved after surgery. Now, in children, it is very uncommon. The fellow was assaulted by a caliper, and but it was removed without any neurological deficit. There was no vascular injury. Sometimes conservative approaches are also used in some patients where we think that it was superficial, and we just remove, and serial CT scan were done to see the injury extent. This is another patient. This is the metal fragment entry. This is inside the brain, but we could remove it and patient improved. Wood injury is very special because if CT is done, they show the just air bubble appearance. So MRI is very important in this patient. So if we suspect wood injury, MRI should be done. So this is a postoperative CT and patient. There are few cases where stone went inside. This is the stone we removed. Now, as for the high velocity penetrating injury, the scenario was changed after the Second World War, when Cushing included all these guidelines, early transfer, good anesthesia, antibiotic, and dural closure, and very tight skin closure, and radical debridement. So mortality rate decreased from 54% to 28%. So this is of one of our case. We removed the bullet and patient improved. Sometimes there is a retained splinters, so we don't need to remove because if they are in very deep or elegant area, so we just have to follow off. If the meningitis, treat meningitis. If there is hydrocephalus, treat hydrocephalus, and the CSF treat them accordingly. This is another interesting case presented to us, assaulted by pellets in both orbit. And when we did the lateral,
Give time for Professor Goi because 7 o'clock we have to start.
Just 2-3 minutes. 2 minutes. So this is a pellet here, and there was no vision, so we didn't do anything. This is a girl presented with the. This is a girl presented with the fall and handle of bicycle injured the girl, and this is the bone spicule hematoma. We suspected vascular injury. So on angiography we found a aneurysm here, and this is a bone piece. This is an aneurysm. So we planned to do the surgery, and in surgery we could remove it. This is the bone piece. The aneurysm was dislodged, and there was a small hole. We couldn't block it, so we put a clip. So this is the bone piece. This is the pseudo aneurysm. This is the post-op angiogram showing the good distal circulation. It's a post of. So I want to just tell in summary that early resuscitation and good anesthesia, imaging, and previously what we were thinking of radical debridement is not necessary, because after Iran or African one, conservative is important, and showing the same. Thank you very much. Thank you, Haki. Thank you.
Thank you very much, Professor Sinha. Excellent talk. And we would like you, before the spine committee, I mean, Mehmet is here. Is Mehmet here?
I believe he
Yes, yes, I am here.
Yeah, Mehmet, we have one last talk. Do you think you can give us 5 to 8 minutes for that talk? Or, I mean, if you want to start, we can have your session first, and then we can ask Dr. Boy.
Please finish the session you are continuing.
Yeah,
then we can start. No problem.
Thank you. Thank you. Professor Goi, please start your session. Mehmet, as usual, thank you so much. Always very magnanimous.
Okay, I'm here.
Yeah.
Thanks,
Goi.
Guy.
Yeah.
Can you see my screen?
Yes, you want to make it bigger?
Yeah.
Yeah.
Okay.
There you go. Perfect.
So,
Yep.
yeah, it's my honor to be here with you. And my name is Yi Guo from Beijing Tsinghua Changgeng Hospital in China, Beijing. And the topic I shared here is the application of aligned fibrin nanofiber hydrogel, which is AFG, in promoting spinal cord regeneration. It's a basic research promising preliminary results. And there are two parts of my talk. The first one is fabrication and the characterization of AFG. And as we all know, spinal cord injury is a common and devastating condition all over the world. And it always leads to long-term disability, severe psychological impairments, and a heavy financial burden. And based on the WHO website and the estimated global annual incidence rate of spinal cord injury is 40 to 80 cases per million populations. And until now, the spinal cord injury remains to be the most difficult challenge, not only for the researchers, but also for the clinicians. And the Miami project to cure paralysis is the most famous project to treat the spinal cord injury, and we have some collaborations with them, and we visit them, and they have amazing facilities to help the spinal cord patients rehabilitation. And in my center, we also have some collaborations with our university, and to develop some methods to help those patients. And but recently, tissue engineering based strategy is emerging to be the promising approach to treat spinal cord injury, and various biomaterials were reported to promoting spinal cord regeneration through at least 3 mechanisms. And the first one is it can serve as a scaffold to support and induce extension of injured axons. And the second is it can alter the microenvironment of the injured extracellular matrix in the lesion site. And the third one is it can act as a delivery system to release various bioactive molecules to promote the tissue regrowth. And so the right lower 3 pictures show different kind of bioscaffold to improving spinal cord regeneration, and published in the paper. They have different components, structures, and biological effects. And this is our biomaterial. We developed it, and we fabricated the AFG hydrogel by using electrospinning and molecular self-assembly. And the left picture shows how to make it. During the electrospinning, the fibrinogen fibers were deposited in a horizontally rotating collector, and there is a thrombing in the liquid of the collector, and it will enzymatically cleave the fibrinogen to fibrin. So eventually, by chemical linking based spontaneous self-assembly, the fibrillar fibrin hydrogels can be formed. And this panel shows the characterization of AFG. The AFG bundle can be knotted and stretched, indicating its good flexibility. And the polarized the light microscope shows the polarized characteristics of AFG, and we can see the birefringence phenomenon with optical extinction in the cross region of the two fiber bundles. And the aligned topography of AFG was confirmed by scanning electron microscope from different level of scales. The AFG shows aligned features, especially in the nanoscale. It is obvious that the aligned topography of AFG makes it a perfect mimics of the extracellular matrix of spinal cord. Additionally, the elastic modulus of AFG is similar with the spinal cord. So the AFG might work as an artificial extracellular matrix to support the regeneration of the spinal cord. And the effect of AFG on nervous system was preliminarily observed in vitro. For example, to evaluate the effect of AFG on support of axonal growth and sprouting, we co-culture of the isolated rat dorsal AFG for 3 days, and the dorsal root ganglions shows significantly rapid and long neural outgrowth longitudinally. We also detect the effect of AFG on mesenchymal stem cells, and after 14 days after co-culture of these two materials, the mesenchymal stem cell shows a neural differentiation. Then we studied the effect of AFG on promoting spinal cord regeneration in 3 different animals, rats, canines, and non-human primates. And this is the rat dorsal hemisected spinal cord injury model to test the effect of AFG implantation. And we use a random fibrin hydrogel, which is the RFG and the saline as controls. And 2 weeks after surgery, the density of regenerated tissue in AFG group is obviously higher than the other group. And the 2 weeks after implantation, with the increase of the cell invasion, the fibrin scaffolds were degraded and replaced by the invading cells. And a large amount of neurons labeled with beta tubulin 3 were observed to form densely packed aligned cell cables in the AFG group, while the regrowth tissue in the RFG group was still distributed randomly. And these differences get more obvious 4 weeks post-surgery implantations. And remyelination of regenerated axon is the structural basis of the signal conductor function. So 16 weeks after the surgery, regrowth tissues in the middle of the damaged area were examined by the transmission electron microscope, as shows the left panels. And we can see in the AFG group, the myelinated axons could be seen clearly. The regrowth axon density in AFP group was significantly higher than in control group. And this is a DTI evaluation of the regrowth nerve fiber. Obviously, the regrowth fibers in the AFG group shows the best directionality and integrity. So we also performed to do the animal models in canines, the beagle dogs, the beagles, and this is the surgery we do the models, and we established the hemisected spinal cord injury model at the T11 to T12 level. The length of lesion is 4 millimeter, and this is the surgery steps. After coagulated the veins, and we remove the parts of the spinal cord to do the hemisected, and then fill the hole with the aligned hydrogels. And we can see that both MEP and SEP in the right hind limbs were attenuated by the surgery. And the DTI also implied after surgery to confirm the successful of the model establishment. And here the follow-up videos, and the follow-up lasts for 16 weeks. And we can see this is the first week AFG group and the control group. And here the 2 months and the 12 weeks. AFG group has the a good recovery, and it is noteworthy that 8 weeks after the surgery, the dogs in the AFG group can stand by forelimbs. However, in the control group, the dogs are always in the sitting position. And the histological analysis was applied to confirm the situations of tissue regrowth in the two groups. In H&E staining slices, a better tissue regeneration can be easily found. And while the big cavity and the syringomyelia in the lesion site can be seen in the control group. And in immunofluorescence staining was further used to clarify the cellular components of the regrowth tissue. The red color represents tubulin 3, which is the marker of axon, and the green color represents GFAP, which is the marker of astrocytes. So in the AFP group, the regenerated tissue contains a large number of axons and astrocytes, which is highly similar with the intact tissue in the contralateral site. However, we cannot see obvious axon regrowth into the lesion site in the control group. And then we do the non-human primates study. And this is a preclinical study in cynomolgus monkey with spinal cord injury. and we do the similar procedure as the dog, but we perform the spinal cord hemisection at T8 to T9 level. And here are some videos. This is and the 2 weeks after the surgery, we can see AFG group has some a slightly movement, but and the 4 weeks post-operative, the limbs can move more. And this is the 3 months after surgery. AFG group recovered very well, but the control group recovered. So also we do some AFG-based multifunctional hydrogel tests. And here's some summary. AFG and AFG-based multifunctional hydrogel can facilitate the spinal cord regeneration in diverse animal models. They have potentials for clinical practice of spinal cord injury. And at the end of the talk, I would like to appreciate the great efforts of the other members in our research group, and the other 2 PI, Professor Xiumei Wang and Professor Guihuai Wang, and the 2 PhD candidates, the Cao Zheng and Mang Weitao. And thanks for attention.
Thank you very much, Goi. That was a fantastic talk. We are looking forward to further better results in terms of this. And now I'd like to ask Mehmet to start off with the spine committee meeting. We're really looking forward to this. Mehmet, you please take over.
Yeah. Hi, everybody. There is one microphone must be muted. Okay. Actually, I thank IP and all the staff for organizing such a nice panel. We will be dealing with cervical spine trauma and spinal cord injury. Salman is here. Yeah, Salman, welcome. You are muted. You must unmute.
Hi, Mehmet. Hi, everybody. It's a pleasure to be here, and I welcome you all on behalf of WFNS Spine Committee and World Spinal Column Society. It's really a pleasure to be here and see you doing so well. Mehmet, please carry on.
Yeah. We have a very distinguished team of speakers. We will start with Dr. Enrique Osorio. He's a former chairman of the Spine Committee from Colombia. He will tell us the epidemiology and prevention of spine trauma. Enrique?
Good morning. Thank you for the invitation, and it's my pleasure to talk here with you. Let me. This is not the. Okay. Sorry. I lost. Okay. Okay, you can see my.
Getting there.
Okay.
We are seeing We are seeing your presentation.
Okay, thank you. First of all, I want to invite you to the 17th World Congress of Neurosurgery that will be held in Bogota next year, August 29 to September 3rd. Okay, the epidemiology of the trauma, the spinal trauma, the incidence in the world has increasing, and with an estimate annual incidence in 10.4 to 83 cases per million. The incidence of spinal cord injuries varies between 20.7 to 80 in USA and 8 to 130 in Europe per million a year. The annual cost of up to $267 billion US dollars. Let me see. I don't know how. Sorry that.
Enrique, it's at the bottom left. If you take your cursor down bottom left, you will see the.
Yes. Okay.
Yeah.
Okay.
Thank you.
Okay. Thank you. And the average age in patients with a spinal cord injury is 39.8 years. They tend to be older in Western Pacific region and younger in United States and Canada. Men 3.37 and women 1 women. It's more in men. Injuries in the cervical spine is 46% of all the spinal injuries, and the lumbosacral spine is 24%. The traffic accidents produce 39.5% of the spinal cord injuries, and the falls 38% in the world. The falls mechanism in low-income countries is 54% of the cases, and the violence is another important issue. And the sports-related injuries are rare in middle-income countries, and the United States and Canada is 8%. And the violence mainly due to penetrating trauma from firearm projectile. In Brazil, 42%, Sub-Saharan countries, 38%, South Africa, 25%, and USA, 11.7%. Some countries, such as Norway, Australia, and Canada, incidence is of less than 2%. Some countries, such as Finland and Israel, the spinal cord injury is associated with suicide, that in 10% of the cases. Occupational accidents is reported in at least 15 in all spinal cord injuries. The use of alcohol or drugs has been identified as an associated factor in 34% of all cases with traffic accidents. You can see in this map the annual incidence per 100,000 persons in the world. 3 in yellow and 14 patients in green. You see that the bigger amount is in the South countries, in Latin America, Africa, South Asia, Australasia. And then USA and North America, and some countries in Middle East. And the least incidence is in Europe and Russia. But it's important to see that the majority of the cases of spinal injury are in the low medial income countries. There are 8 times more than in the high income countries. The mortality in spinal cord injury is 0 to 60%, and the 36% and 59% require surgical intervention. And the mortality is higher in a spinal cord injury patient due to the traffic accidents, mortality between 40 to 50%. And the spinal cord related to falls is in high income countries tend to be related to falls in the elderly, while in the low income countries is related to the falls at work. For the prevention, there are this organization, the International Spine Cord Society, with the World Health Organization, create guidelines to prevent the spine cord accidents. And the best intervention to prevention of the spine cord associated to the road traffic crashes are legislating and enforcing drink driving laws, include alcohol concentration, use the seat belts, use of child passenger restraints, motorcycle helmets, setting and enforcing speed limits, including the use of speed cameras, reduce speeds around schools, hospitals, etc. Daytime running lights for motorcycles, and road designs that separate pedestrians and two-wheelers, cars, and heavy vehicles, area-wide traffic calming measures, and graduated driver's license systems. And for prevention of the spinal cord related to falls, it's important to floor clear of clutter and loose rugs, provision of good lighting, handrails and appropriate level furniture, window guard and high-rise buildings, barriers on roofs, safe harvest equipment, well barrows where applicable, and enforcement of building regulations, education of parents of young children, workplace regulation that limit weights carried on head and age of workers. And to prevent to work activities or occupational accidents, it's necessary to obtain data on the magnitude of the problem, hazard identification, if it's geological, hydrological, seismological, and rock evacuation process, the risk analysis and assessment, identification of the protective factors, design and implementation of the interventions to control risk, strength enforcement provisions and address offenses, monitor and review. And to prevent sports-related spinal cord injury, the cervical is common at the level of C4 with resulting tetraplegia in most common form of diving related. This type of diving injury is most often seen in men under the age of 35. And then to prevent the spinal cord associated to the sports, in general, the educational programs as the most important. In rugby, mandatory safety training for coach and referees. diving legislation and enforcement to safe pool designs, and with deep lightning, diving, bore height, and elasticity, prohibiting of the alcohol around water sports. And general sports, the playground standards for the depth of appropriate surface material, height of equipment, and maintenance. And in deep sea diving, early access to the decompression chambers. And in conclusion, the traumatic spine injuries produce a high percentage of morbidity with multiple disabilities. This represents a high cost to the society and high mortality rate. And we have to prevent, and for the prevention, there are principal these issues. Equity, of course, but the control of the violence, the education, the regulation, and the infrastructure of human and facilities. And in 2016, we made the Declaration of Bogota. Here you can see Dr. Andres Rubiano from Colombia, Dr. Mera Cheiran from India, the health vice minister of Colombia, myself, Dr. Franco Servadei, president of the World Federation, Dr. Andrew Mas, at that time, the chair of the trauma committee of the World Federation, Dr. Walter Johnson from the World Health Organization, and Dr. Key Park, the president of the Global Neurosurgery Committee of the World Federation. And in this declaration, we therefore hereby declare global neurosurgery as the collective and unified effort in improve all aspects of neurosurgical care whenever and wherever it is needed. And we have in Colombia a Neurotrauma and Global Neurosurgery International Fellowship, leading by Dr. Andres Rubiano in Cali. And we had applications in 2020 from Cuba, Pakistan, Nepal, Egypt, Venezuela, Qatar, Uzbekistan, and Emirates. And we promote that in all the countries around the world, we have the possibility to have the infrastructure necessary to attend the spinal cord trauma, the neurotrauma in general, and with the human people, the preparate with the professionals. And again, our invitation to the 17th World Congress of Neurosurgery in Bogota next year, August 29 to September 3. Thank you very much.
Thank you, Enric. Very nice overview. It's still a challenge to get many spinal cord injured patients, especially in low and middle income countries. Are there any questions? Salman?
I think it's an excellent presentation, Enrique. I really enjoyed that. As always, you're brilliant. What I wanted to ask was, is there any work being done by WFNS Spine Committee in this regard? Have we achieved anything by changing the way research is done all over? And we talk about it, but have we done anything about it yet?
Yes, at that moment, our spinal committee is not involved, but I think that is one of the issues that we have to develop at this moment.
Mehmet?
Actually, we did some consensus meeting, 2 meetings. One
yeah,
in
of course.
Moscow, the other one in Peshawar last year. And then we tried to make recommendations, and they are about to be published in the journal Neurospine. We will see in a few months the publications. Yeah. Thank you.
Yes, of course.
Really. I can share my screen now. Yes.
Mehmet, before you start, I must introduce you here. I think Mehmet has been the fighting force for WFNS Spine Committee all along. He's been the past president for Middle Eastern Spine Society, World Spinal Column Society, and has been chair of the WFNS Spine Committee for some time. And it's a pleasure to be a co-chair with him and to achieve so many milestones with the help of his non-stop pushing and nudging us. So Mehmet, here you go.
Thank you. Dear friends, we will talk about the acute emergency care of cervical spine trauma, especially transportation and immobilization of patients with cervical spine trauma. This is still a challenge. Actually, we have different periods of transportation. The one is the pre-hospital period. We must apply safe extraction, initial resuscitation, ABC of initial care, triage with rapid determination of the likelihood of spinal cord injury and immobilization. Then the patient comes to emergency room. Then probably if there is severe problems, ICU, then sometimes operation room. What are the options in pre-hospital period? When and what type of pre-hospital spinal immobilization are necessary for adults and children? And how long to continue cervical immobilization during this period? What are the criteria for pediatric cervical spine clearance? These are the questions. When we need a spine stabilization, if there is spinal pain or tenderness, including any neck pain with history of trauma, if there are significant multiple system trauma, if there is severe head or facial trauma, if there are some neurologic findings at the beginning, a loss of consciousness caused by trauma, or if mental status is altered by the drugs, alcohol, or trauma, and any significant distracting injury. In those cases, we mostly apply a rigid collar. However, immobilization is not recommended if the patient is awake, alert, and are not intoxicated, without neck pain or tenderness, without any motor or sensory neurologic deficits, and without significant associated injury. Best option for spine immobilization is a rigid backboard in conjunction with a hard cervical collar and tape straps to immobilize the entire patient. The previous application of sandbags on the side of the neck are yet not recommended much. These are the spine boards, but there is no single device that's been found to be superior to spine immobilization after spinal column trauma. High-risk patients should not be fitted with a collar only, and temporary use of a rigid collar is an option during extraction procedures, and unconscious, non-intubated patients should be transported in a modified lateral recovery position, because vomiting and respiratory tract obstruction may be a problem. And another issue is in the elderly patients. because they are somewhat kyphotic, and you cannot fix them on the straight board without difficulty. So if there is hyperkyphotic thoracic region, a slight flexion may be more appropriate to bring the patients to a true neutral position. This is the one. Actually, A, B, C, D, E actions are the emergency medicine spinal immobilization protocol. These are set up by the German emergency care providers. Very, very nice algorithm. And there are some risk and complications of immobilization, especially the problem with respiratory function. It may limit the respiratory function and be associated with higher rate of aspiration. Elevations in intracranial pressure may happen, and patients with medical comorbidities like ankylosing spondylitis, rheumatoid arthritis may be in risk, and penetrating neck trauma should better not be immobilized with any collar, because there is no difficulty with them in stability of the spine. Spine immobilization should not be used routinely for adult patients with penetrating trauma, as it is associated with increased mortality and has no benefit in preventing neurologic deterioration. There is so-called Canadian C-spine rule. Yeah, actually, the Canadian investigators have made rules for C-spine clearance. And these are mainly accepted by many trauma centers. But there are some difficulties in children, great variability in the application of spinal immobilization in children. For older children, it's not very difficult, but for kids less than 2 years old, 1/4 of the children cannot be immobilized. This may be a cause of variability in spinal immobilization of children. There is no consensus for use of particular precautions based on age and risk factors for C-spine rule in children. How long should we continue cervical immobilization during hospital period? And what are the criteria for collar clearance? If the patient is alert and asymptomatic, you can discontinue cervical immobilization following a normal and adequate dynamic X-ray. However, if the patient is obtunded or otherwise impossible to evaluate the symptoms, then discontinuing may be applied after a good CT scan or MRI. So this is a systematic review in hospital immobilization of the patients, and it's saying that conditionally recommend cervical collar removal after negative high quality C-spine CT scan, not an MR. In cases when the patients remain symptomatic and discontinuation of cervical immobilization at the discretion of the treating specialist should be done, and the collar immobilization may be discontinued without further radiologic investigations in the alert and asymptomatic patients. Okay, there is one algorithm like this. If the patient has, no symptoms, you can immediately remove the collar. If there are some pain or tenderness, or Glasgow Coma Scale is less than 15, or there are neurologic deficits, then remain in collar and urgent CT spine. If it is abnormal, refer the patient to a spine surgeon. If it is normal, but still intoxicated, or Glasgow Coma Scale is less than 15, then you must achieve a MR image probably. And then if it is normal, then you can discontinue. So these are recommendations of our spine committee. Immobilization of patients over the age of 12 years with high risk of spinal cord injury during the pre-hospital setting should include a hard cervical collar, spinal backboard with tape straps to immobilize the entire patient. In case of limited human resources, alert patients with minimal blunt trauma without penetrating trauma and any spinal pain can be transported without immobilization. Transport of patients with acute traumatic spinal cord injury to the definitive hospital center for spinal cord injury care should occur as soon as possible and not later than 24 hours of injury. Actually, this is quite difficult because the high quality spinal cord injury centers, transportation to those centers are not easy in most of the instances. After arriving to the hospital, collar immobilization may be discontinued in the alert asymptomatic patients. Following a normal MRI obtained within 48 hours, dynamic X-ray can be excluded from the list of options for investigation because we are considering it a bit risky. In the obtunded patient, collar immobilization may be discontinued after a negative high-quality C-spine CT scan. And symptomatic patients with normal CT scans should proceed to MRI. There is a big variability in spine immobilization of children, especially those younger than 2 years of age have more difficulties, and there is no consensus if the children should have different immobilization measures. I will summarize about our policy for close reduction and then finish my talk. And actually, as you know, this is the AO classification in F1, 2, and 4. There is no doubt, but in floating lateral mass, if there is a unilateral locked facet, the reduction is not easy. If facets are fractured, it is quite easy. So in those cases, with at least one facet is locked, too much weights are necessary, and there are mainly two options. One is the close reduction, immediate traction, application of a traction, and then trying to reduce it by increasing the weights, or open reduction. Which one to choose? Is it safe, close reduction? We need to monitor the patient. If the patient is awake and alert, then it's not a big issue. Do we need a pre-reduction MRI? And this is a concern because sometimes a herniated disc may cause further deficits during reduction. This is according to some studies. This is the incidence of that is about 1%. Transient injury occurrence is about 2 to 4%. And failed close reduction should be followed with open reduction. These are the main issues. Is close reduction feasible? Possible? If there is locked facet, it will be harder. If trauma is not acute, if it is more than 2 weeks before, so it's not easy. There are different papers in the literature. One is this: 15 patients had got clot reduction, but 6 of them failed. Then they went to anterior or posterior surgeries. This another paper, 2018. They have done awake patients, physical examination were monitored, obtunded patients, SEP were monitored, and rate of successful clot reduction was significantly high in incomplete motor deficits. Another paper, the conclusion is clot reduction should be attempted in patients with good motor examination. And this paper has, the authors have done it under general anesthesia with monitoring, no alert patients. This patient is against the clot reduction. This report is against the clot reduction. They have applied in 36 patients without preoperative cervical traction, immediate anterior reduction. Guidelines for Joint Committee of WNS-CNS from 2013 is saying that MRI is recommended if they cannot be examined during clot reduction. If the patient is obtunded or comatose, then it's better to have a MRI before clot reduction. Our recommendations for clot reduction of cervical spine fractures. There is no evidence that clot reduction of cervical facet, locked facets have more benefits to open reduction. If a clot reduction is attempted, awake patients with incomplete injuries are better candidates. If a reduction in patients with decreased consciousness is attempted, a pre-reduction MRI and open reduction should be preferred. If a clot reduction attempt fails, immediate anterior decompression and surgical reduction are better options. Best time for a clot reduction is not well known, although many papers suggest it should be as soon as possible. All patients after clot reduction should be operated for stabilization and fusion. You cannot leave any patient if you have achieved a reduction with a closed traction. This surgery can be with an anterior posterior or combined anterior posterior approach. Thank you for listening to me.
Mehmet, that was a brilliant summary of the whole guidelines, and you've gone through each and every step. Are there any questions from anybody? Do you have any questions? Yes, Enrique? I think it was very clear. You've gone through each and every step, and it's very, very clear. We are grateful for that talk. Superb talk.
Thank you.
Remember, if you could unshare, then I could share the screen.
Yeah.
Yeah.
Yes.
Am I the next to follow, Mehmet, or is somebody else in between?
Yeah, you can continue.
Okay.
Yeah, you are the next speaker. Yeah, actually.
Yep. Okay.
Salman Sharif. I don't think it's necessary to introduce Salman. Everybody knows him. He's the chairing the Spine Committee, and also he's the chairman of World Spinal Column Society currently. He will tell us the subaxial cervical spine trauma classification and management. Yes.
Thank you, Mehmet. Thank you, Ipe. Thank you, John. I think it's brilliant to be here, and it's wonderful that we could gather everybody together for this wonderful seminar. The big question is, can we make an impact? And it's been shown again and again that 3 to 25% of cases of permanent neurological impairment after spinal trauma are due to injudicious manipulation by paramedical personnel, examining physicians and radiology technicians. There are a few tips and tricks that we all should know. Everybody should be using ASIA, and there is a reason for that, because it's uniform, and then we can, even if you're on the other side of the phone, it's much easier to know what exactly is happening, and it's all been tested and tried. It's important that you know that what are your key muscles, and in upper limb and lower limb, what kind of sensory examination you're going to have, and every patient should have this form filled when they arrive in, and it should be repeated again and again every 2 hours, unless there is, if you're sure that the neurology is not going to change from then on. What is ASIA impairment scale? Everybody knows it, but I'm just, for the sake of the students, I'm going to just point out that complete, when you have got no motor or sensory function. Incomplete is when motor function is not preserved below the neurological level and includes sacral segment S4 to S5. Incomplete is when you have got at least more than half of key muscles below the neurological level, having a muscle grade less than 3. And incomplete is when you've got at least half of the key muscles below the level, having a muscle grade of 3 or more. And E is normal. Why is all this very important? We'll just go through our next slide and we'll find out. There is a thing called spinal shock, and you don't want to be labeling a patient as a complete injury before you have ruled out spinal shock. And this is important to look at the bulbocavernous reflex. You tag on the Foley's catheter, or squeeze the glans or the clit, or you can do electrophysiology to find out if the reflex is positive. If it's positive, then it implies that there's lack of suppressed spinal input to the sacral outflow, and that it means that it's complete spinal cord injury. If it's negative, then it's absent in spinal shock. Recovery below zone of injury. Why do we worry about we should be doing things as soon as possible? Because if you have got complete versus incomplete, what kind of neurological improvement after admission? So we know if you are ASIA A, which means you have nothing, there is a 3% chance of having a reasonable functional recovery if you are managed aggressively and you are hydrated well and everything is done according to the guidelines. If your ASIA goes to B, then 44% of patients are going to go in that grade. So we can know that nearly half the patients are improving, and 1/4 will go to good functional recovery, D and E. 5% of these patients may worsen with your surgery or your intervention. More than half of C are going to go to D and E, and 97% of patients with D obviously are going to improve further. Spine committee, as Mehmet just said, have made these guidelines with the help of looking at literature search over last 10 years. And what we found was that subaxial injury classification, which is classification describing according to the morphology, in which you have compression, burst, distraction, and translation or rotation. And then you get points accordingly for that. So if you, for example, if you have a burst fracture, you get 2 points, distraction gets 3, rotation, translation gets 4. Discal ligamentous complex involvement, if it's for sure, then you get 2. If it's intermediate, you're not sure, then you get 1. And if it's intact, you get 0. And according to the neurology, intact, root injury, complete injury, incomplete injury. And if there's a continuous cord compression, you get an extra 1 point for that. Subaxial spinal injury. So this study was published way back in 2013. And there's level 1 evidence that subaxial spinal injury classification and severity scale is recommended as a classification system for spinal cord injury. This system includes morphological, ligamentous, and neurological information in its scoring. So you've got all the features that are all included. And if you look at the rate of reliability according to different classifications, then you can see that according to the morphology, discal ligamentous complex, and neurological status, the scoring is pretty good compared to others where the scoring is pretty reasonable. So SLIC's severity scale abandons traditional characteristic of mechanism of injury and anatomy in favor of injury morphology and neurology. And so there is level 1 evidence suggesting that it's reliable overall, and internal consistency is indicated by worsening of score, reflecting worse neurology. SLIX provides good to intermediate, excellent inter-rater reliability, and it may be best applied in educational setting to confirm the fracture morphology and presence or absence of ligamentous injury between surgeons and radiologists. So, study done by Vaccaro again in 2014, they looked at literature review, and they again found same inter-observer and intra-observer agreement among surgeons of all levels. So this demonstrates SLIX was safe and effective. Sorry, can somebody unmute, mute Omar? Thank you. And you can see the same thing again and again. It's been proven again and again that we are, according to different discal ligamentous complex, neurology and morphology, pretty fair agreement and moderate to substantial agreement when it comes to intra-rater abnormality. What about the AO spine classification? What about its validity and reliability? So I think if you look at it, AO, it has, each region is classified according to hierarchical system with increasing level of injury or instability, and represents the morphology, neurology, and clinical modifiers. And they came up with this in 2016, initially in 2013, and then modified in 2016. If you look at morphology, type A are compression injuries, type B, failure of posterior anterior tension bands, type C is failure of all elements leading to dislocation or displacement. Type F, which is for facets, as Mehmet pointed out earlier, injuries are classified by their levels, and they're either C, B, or A in this order. So let's go through each one of them briefly. If you go type A, there are 5 subtypes. A0, no bony nor minor injury, such as isolated laminar spinous process fracture. AO is also used for presence with central cord syndrome without any fractures. With A1, compression fractures include a single endpoint without involvement of the posterior wall. With A2, coronal split. With A3, it's a single end plate. With A4, it's burst. So we look at it now separately. So with A0, when you have got isolated fractures like this spinous process and there's no significant injury. A1 is wedge compression, and A2 is split. A3 is when you have got displaced transverse fracture below the joint, and you've got complete burst, which was A4. So it's easy to look up and rate. What about tension bands? So if you look at this, if there's posterior tension band involvement, there's primary physical separation through fractured bony elements, and B2 was fracture tension band posterior again, but complete disruption. And B3 is anterior tension band, physical disruption. So we look at it again. So B1 is you've got posterior tension band without any disruption. B2, we have got the transalar fracture, does not involve foramen or spinal canal. With transforaminal fracture involving foramina, but not spinal canal. So anterior elements are involved here. So posterior, and then anterior with avulsion. So that is B. And we look at C, translation injury in any axis. You've got any associated injury, A or B, it should be specified separately as subtype injuries where anterior and posterior both elements are distracted without classifying as translational injuries. So for example, if you have complete disruption like that or complete axis displacement or translation, then we call this C. What about facet? Mehmet showed that earlier. So facet is non-displayed facet fracture, F1. F2 is facet fracture without potential of instability. F2 is floating. F3 is floating fracture. This is the one that Mehmet talked about earlier. And F4 is very simple. You've got subluxation, pursed, or dislocated facet. What about bilateral injuries? So you've got bilateral injuries, then you include that into a separate as a BL. So how do we classify this? So we start and look at if there is displacement or dislocation. If displacement, yes, you go to translation. Dislocation, if there is none, then you go on to tension band injuries. If it's yes, if it's anterior, then you know that it's B3 hyperextension injury. We talked about this. And if it's posterior, it's complete or incomplete. So then you can label accordingly. If there is no tension band injury, then you go into vertebral body fracture. If it's a burst, and complete burst, incomplete burst, split, etc. So that's how we rate this. And if it's a vertebral process fracture, then it can be A0, insignificant injury. And if there's no fracture, then obviously you know there is no injury. That's how you classify AO classification. And then AO came up with grading of neurological deficits. They include N0, N1, N2, N3, and N4, just like the SLICs. They include neurology in it as well, and NX when you cannot examine the patient because of whatever reason, intoxication, head injury, multiple trauma, if they're intubated. So this is, again, the brief summary of neurology, N0, N1, N2, N3, N4, and NX. And you can add a plus for continued spinal cord injury. Then they included case-specific modifiers, which are rarely used, but it's important to know. M1 is posterior capsular ligamentous complex injury without disruption. M2, critical disc herniation. N3, you've got a metabolic disease of some kind. And M4, signs of vertebral artery injury. So this was again assessed in multiple studies, but yet randomized controlled trials are yet to come out. AO spine classification demonstrated good statistical agreement for group A, B, and C classification. Obviously, this was a single center retrospective study, and they needed more studies to come out with it. So retrospective analysis, again, showing the same thing, that yes, there is some reliability, but there are issues associated with, since it's a complex classification. So again, we look at, if you look at A, B, and C, so we found that, you know, the accuracy was better with A and C, whereas with B and F, the accuracy was not as good. So again, a spine subaxial classification system, inter-observer and intra-observer reliability is substantial, but there was low number or disagreement in some of these injuries. Again, another study, and they showed the same thing, but exactly showed that there were lowest values for F1, F4, B2, and A3. So these are type of the injuries that there was less consensus, and there was highest consensus for simple injuries, as you'd expect. So WFNS consensus, subaxial cervical spine injury classification we said that SLICS is easy for surgeons and residents to reproduce at this time with relatively better inter-observer reliability. There was 100% consensus there. And we suggested the SLICS should be used as standard of care to guide further treatment and given preference over other present classification. For injuries in SLICS of score more than 3, non-surgical treatment with rigid collar for 6 to 12 weeks is recommended. There's good agreement rate in SLICS score of morphology, neurology, discal ligamentous complex, and treatment chosen is more than 90% in agreement. We do need randomized controlled trials and prospective studies to validate these and newer classification. What about AO? For AO, the reliability of injuries type A, B, and C was good. Intra-observer reliability, including subtypes, was substantial, but there's lowest value for F1, F4, B2, and A3, and that needs to be improved and somehow. And highest value was for the simple types of classification. AO supplemental classification is promising with neurology and other modifiers, although it is not user-friendly and complicated. This was not quoted in our guidelines. Oops, I'm back to where I was. Okay, thank you very much.
Thank you, Salman. Very nice overview. Actually, SLICS is easier to use, but AO classification is somewhat better than SLICS. Am I right?
You're correct, Mehmet. Let me just, sorry. You're very right. I think overall, if we see the reliability is very good with SLICS, but the problem is that those simple modifiers are not there. The fractures are not given in detail. There is more stress on neurology and discal ligamentous complex than stress on the different mechanism of injuries and the fracture type. That was the case with the initial classifications, and that has changed over time. And we've seen that I think the AO are working on, again, trying to improve this further, and I think it will happen. and we should be able to have more inter-rater and intra-rater reliability. There are many software now which can calculate all this for you as well, and so that may make it easier, but it would be difficult for countries where they don't have access to these software, etc.
Thank you, Salman. If there is no questions, we can proceed with Oscar. Oscar Rui Alves is from Portugal, a very good friend of us and a member of Spine Committee. And actually, he's also publishing our newsletter. We meet each other almost every day. Oscar, welcome. He will tell us about the medical management of spinal cord injury.
Okay, Mehmet, thank you. I think I see you more than my wife. Thank you, Mehmet. Thank you, Salman and Ed, for allowing me to present. So my topic is acute medical management of spinal cord injury. So you have the primary injury, the one that is sustained at the moment of the injury as a result of a force, as you can see here by analogy. And then you have a second injury, which sometimes can be of a larger extent. And this basically is a preventable cascade of events that can take place within minutes to hours, involves different pathways. And these are the ones you want to act to limit the injury. As you see here on a TY MRI scan, primary lesion, if you do a T2, you can start to see some spinal cord edema and swelling. And after the operation, months later, you see spinal cord atrophy. And this is exactly what you want to avoid. If you go deeper in the analysis at the molecular level, there are different pathways and different drugs that can actuate in different situations. Still, surgical decompression is the best neuroprotective measure that we can have. Assuming the effect of a secondary injury, this can be exacerbated by respiratory insufficiency and pulmonary dysfunction, and they are particularly common in cervical spine injury. It's also associated with systemic hypotension that reduces spinal cord blood flow and perfusion. There is a whole bunch of lab evidence that hypotension results in worse neurological outcomes. And this comes from hypovolemia, from reduced cardiac output, or directly from spinal cord trauma. Assuming the effect of these events, the earlier ventilatory and pulmonary and cardiac hemodynamic dysfunction is detected, the more likely effective often life-saving treatment can be initiated. And this is not a new concept. From 76, Zach and 84, Tatter in Canada, they think that immediate medical specific treatment of spinal injury with attention to maintenance of acceptable blood pressure would improve neurological outcome. But unfortunately, still today, the admission to ICU or similar monitoring setting, it's not universal. If you look at this very nice paper from Burley and Shen, pulmonary function is defective in a very high extent. It tends to occur on average of 4.5 days after acute spinal cord injury. It is 36% of the complications. It's the most common cause of morbidity and the most common cause of mortality of these patients. 86% of deaths are due to respiratory failure. So the incidence of respiratory complications can be significantly reduced by transferring the patients to ICU or equivalent. Immediately after the spinal cord injury, you have a profound reduction of forced vital capacity, inspiratory and expiratory blood rate, leading to further hypoxemia. The overall mean pulmonary vascular resistance is also less than normal in more than half of the patients. This leads to a ventilation perfusion mismatch at lung level. And because of that, you can have hypoxia in patients that don't require ventilation. because of this ventilation perfusion mismatch. They have adequate alveolar ventilation, but they are still hypoxemic. And some of the cases of the systemic hypoxia can respond to supplemental oxygen in most of the patients. This is a summary of what leads to pulmonary dysfunction, the impaired inspiratory capacity, also the retained secretion and the mucus plugs, and changes on autonomic and dysfunction with bronchospasm and pulmonary edema. The incidence of pneumonia is involving almost half of the patients, of course, with complete injuries, higher incidence than incomplete injuries. What about airway management? 3/4 of the patients require intubation, and whenever FVC is less 25% than expected. The independent risk factors for intubation are the injury severity score that depends not only on spinal cord injury. Whenever the spinal cord injury is above the level of C5, and if the injury is complete. And in this scenario, early intubation is recommended. The tracheostomy time after intubation can go from 3 to 10 days, or if you're doing a surgery, you can do it at the time of the surgery with no risks of cross infection. It is well perceived now that if it is done before day 7, it's associated with reduction of cost, duration of mechanical ventilation of 6 days, and ICU length of stay, a medium difference of 8.7 if you do it before day 7 or after day 7. The overall incidence of tracheostomy can reach almost 70%, with differences, of course, less in incomplete injuries. It can be from 6 to 1/3 of the patients, and complete injuries, much higher levels, much higher incidence of tracheostomy, of course, when the lesion is above the C5 level. It can reach 80% of patients. A very important paper published by Bernay could identify some data that can help you to extubate patients or to lead them in tracheostomy, and mainly this is related with pulmonary secretions, with associated injury, the gas exchange, the FVC, the mental status of the patient, and the ASIA status of the injury. Basically, 2 graphs showing the same thing, a table and a graph that shows that most of the patients that end up in tracheostomy are the ones with ASIA classification A. In this paper, enrolling 114 patients, a prospective observational study, they tried to set up a clinical pathway for airway management, and they were very successful to predicting the need for intubation in 82% of occasions, and applying this pathway, less than 10% of extubation failure rate. And this is based on FVC, volume of pulmonary secretions, and gas exchange. And this is basically how it works, their clinical pathway. And this was very useful in clinical decision making. There are criteria for winning mechanical ventilation. I'm not going through all of this, but that's a step that you are very careful to do it. And another study, a class 3 study, it was clear that the implementation of this clinical pathway with a structured respiratory protocol is effective in reducing mortality, respiratory complications, the incidence of atelectasis, the ventilation time, decreased requirement for tracheostomy, intensive care unit length of stay, intensive hospital length of stay, saving more than $20,000 per patient with the implementation of this kind of protocols. There are other things that you can do. You can assist cough to improve cough efficacy. Moderate evidence in favor of this. Respiratory muscle resistance training. You can use intermittent positive pressure breathing with a very low quality data. There is also moderate evidence that non-invasive ventilation can be useful in the treatment of respiratory failure and the avoidance to need intubation. Continuous bed turning for kinetic therapy, there is very little evidence, and it seems that very important is the intensive physiotherapy that prevents the need for tracheostomy and reduces the length of stay at the ICU. Very important when you proceed to suction of secretions that you follow recommendations like you have here that you can see in every textbook. Aside from respiratory function, you have hemodynamic function, and you have to pay attention to the autonomic nervous system. Whenever you have a transaction of the spinal cord, you have removal of the sympathetic control from upper centers on the heart, on vasculature, but you still keep the parasympathetic influence, both through efferent to vagus, to the sinus node, and efferent from arterial baroreceptors. There are two types of hemodynamic functions related with autonomic dysfunction. One is neurogenic shock, that you can find in roughly 20% of patients. The definition is when systolic blood pressure is less than 100 millimeters mercury and heart rate less than 80. And of course, when you go down in spinal cord from cervical to lumbar, the incidence of neurogenic shock is reducing. You have also another entity called autonomic dysreflexia. It's a constellation of signs and symptoms in spinal cord injury above T5-6 level in response to noxious or non-noxious stimuli below the level of the injury. This is a really severe condition that needs to, it's underdiagnosed and needs a high suspicion rate to be diagnosed. But there are also cardiovascular instability that it's not related with autonomic dysfunction. From this paper from Lemon, you see separating group 1 of patients, severe cervical, minor cervical, thoracolumbar. You see there are a whole bunch of electrocardiographic abnormalities distributed almost equally from these groups. There is potentially life-threatening cardiac arrhythmias and hypotension that you see all over 14 days after the injury, especially in this first week of the injury. And this is really the window. You have to define the admission or the stay of the patients, the intensive care unit. As you see here, all patients with severe cervical injury, Frankel A and B, had prolonged bradycardia lasting at least 1 day, where patients with Frankel C and D only 35%, and lumbar spine much less, around 30%. So this can help you to stratify the admissions to intensive care unit, being cervical patients having the preference and the severe ones on the top. Hemodynamic compromise and systemic hypotension, sometimes you need to do bolus injection of atropine and even placement of temporary pacemaker sometimes in 30% of patients with severe cervical injury. Episodic hypotension unrelated to hypovolemia was identified in 68% of patients requiring alpha-DAM pressor therapy. And almost in 60% of patients, you could see primary cardiac arrest. So detection and treatment were certainly best accomplished in the ICU setting. If you implement this kind of aggressive medical resuscitation and blood pressure management, you can improve outcome, and this improvement is distinctive from the benefit you harvest from surgery at 1 year follow-up. And Vale were the first ones to being able to show this. ICU with invasive monitoring, swan guns, catheters, and arterial lines, and blood pressure augmentation. The goal should be to maintain minimal arterial pressure above 85 for 7 days after the injury. You reduce morbidity and mortality, also other topics like sepsis and urologic complications. And this aggressive monitoring and management, there is minimal morbidity associated with this strategy. As you see here, The proportion of mean arterial pressure below 85 for all patients, it's higher in patients that do not improve, or the mean average arterial pressure. It's also lower in patients that don't improve. And it seems that ASA, IES grade patients, grade A patients have greater benefit than grade D patients. You have to understand where the alpha and beta adrenergic receptors are in the setting of acute spinal cord injury. This will help you to understand what kind of drugs are effective. In general, dobutamine, it can cause vasodilatation with possible risk of reflex bradycardia and should not be used. You have other options like dopamine, norepinephrine, phenylephrine, and ephedrine. Dopamine has a greater complication rate than phenylephrine, especially in older patients. Dopamine or norepinephrine is recommended in high cervical and thoracic injuries above T6 with both hypotension and bradycardia because of bradyarrhythmias due to an opposed vagal tone. And pure alpha-adrenergic agents such as phenylephrine are recommended in lower thoracic injuries. The spine committee, the WFNS spine committee issue some recommendations, and I'm just summarizing them here. Mean arterial blood pressure higher than 85 millimeters of mercury for 7 days in patients with spinal cord injury improves neurological outcome. Correction of hypertension is recommended as soon as possible. Patients with spinal cord injury suffer from cardiac issues, including hypotension and bradycardia, and it is worse in complete injuries. Hypotension and bradycardia must be aggressively managed. In cervical or high thoracic lesions with both hypotension and bradycardia, drugs like norepinephrine or chronotropic and inotropic effects, as well as vasoconstrictor properties may be used. The level, the completeness of injury, the age, previous diseases, tachypnea at admission are associated with a higher likelihood of respiratory complications. These patients should be aggressively managed. Of course, the future directions on this topic is well-designed, really powered studies to better define the length of stay in the ICU. And we need also robust data on patient stratification according to the severity of injury. Of course, less severe patients will need less monitoring. And as it has been extensively done for brain trauma injury, regarding spinal cord injury, we need to recognize the most appropriate threshold levels for mean arterial blood pressure, and the length of augmentation therapy needs to be defined as well. When it comes to medical treatment, there is not really much in our hands. We have methylprednisolone, is a synthetic corticosteroid with anti-inflammatory and neuroprotective effects through its inhibition of lipid peroxidation and calcium influx.